بسم الله الرحمن الرحيم. Dear colleagues, let's start today, the next day of the Pedia Dubai International Conference, 9th one. Yesterday, thanks God, it was very successful gathering, and also there is unexpected numbers of attendees. The lecture was amazing, and also the opening ceremony was done smoothly and very nice. And today in the all newspaper, the Al Khalij and Al Bayan, Emirates Al Yom, and many journals, they are publish the success of the first day of the conference. Always I said, the success, it is a teamwork, and it is not one-man show. So thanks for all of you. We are attending yesterday till late time, even till 7 o'clock evening. And the all lectures, they are very nice. And today, our pleasure and honor also to hear from two very eminent speakers from Ispahan, Professor George and Professor Alexandra, and thank two of them. They are coming from abroad, and they are speak today in the lectures and workshop. So I hope for you all to enjoy our meeting. My pleasure to introduce the first speaker of this session. The speaker is Dr. Izzat Al-Tahir. Dr. Izzat is a consultant pediatric and the head of the Department of Pediatrics and Special Care, PPUNS and NICU in Diba Hospital in Fujairah. Dr. Izzat is an Arab board of pediatric specialization and membership of the Royal College. And he has also a diploma of the Child Health Ireland, and he's a head of the Infection Control Committee. So Dr. Izzat, he will speak today about the very important subject in the NICU, and especially that time it is infection control in ICU. So let's to welcome Dr. Izzat. Thank you.
Good morning, everybody. Welcome to 9th Pedia Dubai. I would like to thank Dr. Sharif, the chairman of the conference, and the organizing committee for inviting me, and Dr. Mamdouh Suilam. And hope you are enjoyed yesterday. It was really amazing, as Dr. Sharif said. And thanks for Dr. Sharif to make us attend in COVID-19 era, to break our isolations and our from each other, everything virtual and webinar. So I will just start today. I'm going to give you some hint about infection control in an ICU, with concentration about CLEPSI, central line associated bloodstream infection, which is the most common in our ICU problem. We know that in ICU, we need TBN, we need antibiotics, we need to maintain the blood glucose, the calories, a lot of invasive procedures. So here comes bloodstream infection in ICU. I'll just have a general introduction about infection control in general. I'm going to neonate, then going to diagnose of CLEPSI and decrepsy and pathogenesis, and the most important is prevention. So we have pioneer of infection control. Infection control, well known a long time. Dr. Ignace is the father of the infection control. From 1815, he advised his medical student and physician to use lime water before and after touching the patient. Idea which is not accepted by his peers at time. And then came Professor Joseph, which he was using for hand hygiene carbolic acid, which reduced nosocomial infection in the Glasgow General Hospital, and this was accepted by his peers. In review of the BC, we found that it's well known before that Professor Sam Hita was using fumigation technique, cleaving the nails and cutting the hair, and flamed his surgical instruments. So it's not that new. So hand hygiene, as I said, it's not new. Again, I speak about Dr. Ignace. He's obstetrician, and he found that in his department, 18% of his women died of puerperal sepsis. It's called before children bed fever. And he found also that the rate of death in home delivery is very reduced. So he advised his doctors and students to wash hands before and after touching the patient, or after touching and after autopsies. And he found the death rate here when he is interfered. When he does the interference of the care, here the death rate dropped markedly from 18% to 1 to 2%, just by hand hygiene. So if you are in hospital, one of 20 of our patients, they got hospital-acquired infection. Of those 20 who got infection, one will die. So simply, if you calculate here, the risk of death will be 20 times 20 will be 400. Your death rate from healthcare associated infection will be 1 in 400, which is really high. So prevalence of healthcare associated infection, let us compare developed and developing countries. We found that the healthcare associated infection, around 5 to 10% of admission in acute hospital care, and it is calculated, HAI, calculated as the fourth leading cause of death in USA. In developing countries, the death rate is 2 to 3 times higher than this, and over 4,000 children die daily, every day from HAI. Here, a study of 29 European countries, which compares the different types of infections. Here, they compare different types of infection in children, in ICU, neonate even, okay, and the BICU. And they found that this study done in 2012, around 18 months, in 1,150 hospitals. And they found that the bloodstream infection, the pink and the light yellow is NICU and neonate. The bloodstream infection was 10.7% of his NICU admission. Their NICU admissions. So let's go to neonate now. So prevalence of HAI in neonate in developing countries, the rate of bloodstream infection among neonate is 3 to 20 times higher than in developed countries. And around 50% of the patient admitted to NICU and got clepsy infection, more than 50% of them will die. I will show you the difference. Sorry. So why neonate? We know neonates are very tiny babies, premature, very low birth weight, congenital malformation, prolonged stay in the hospital, frequent invasive procedures, TBN, delayed enteral feeding, formula feeding, incomplete immunity and immaturity, inadequate nursing staff or overcrowding, and lapses in hand washing. So what is clepsy and what is crepsy? By definition, clepsy with central line associated bloodstream infection is the primary bloodstream infection in patient who has central line more than 2 days. Okay, so more than 48 hours before development infection, and the infection must not be related to any alternative cause. Crepsy is more comprehensive definition. They said that clinical signs of sepsis plus positive peripheral blood culture in the absence of obvious source other than central venous line with one of the following criteria. Semi-quantitative, more than 15 colony-forming unit, culture from part of the castor with the same organism isolated peripherally. Simultaneous quantity of blood culture, 3:1. More heavy growth in the CVC comparison to the peripheral by the rate 3:1. And the time difference, okay, is 2 hours or less. I mean, the organism will appear first in the central venous castor, then he develop, you detect it in peripheral. Differential time of positivity to call, which is predictive value for this is uncertain. Now CDC, it's calling clepsy or crepsy lab-confirmed bloodstream infection with the same definitions. So now we are calling it lab-confirmed bloodstream infection. Here in this study, you can see the difference. I want to show you here in this study that the difference between developing countries and developed countries. Here, this study in 2020, done 12-month study in big center in Cairo. They have around 1,090 in ICU, and they see the rate of bloodstream infection in clepsy here. You find it around 22.9, almost 23 per 1,000 days central line. What about Cleveland Clinic here? This is from 3 clinics all over the world, and they wanted their aim is 0 clepsy. Their rate in 2013 was 0.8 only. So in developing countries, more than 20 times the rate of clepsy than developed countries. So the burden of clepsy, approximately 90% of clepsy occur in central venous line. Mortality attributed to 4 to 20% in higher centers. Estimated death rate 500 to 4,000 annually. Attributable cost per infection for each baby around $35,000, and per year around up to 2.3 billion. So common source, actually, unfortunately, our hand, healthcare worker hand, then central lines, presence of central lines, ventilations, invasive and non-invasive procedure, a lot of equipment, very busy environment, very busy. Cystoscope, your medication, your fluids. So diagnosis. To diagnose clepsy, you should have clinical signs. Baby should have symptoms. So apnea, hypotension, hypothermia, fever, feeding intolerance. So different baby is symptomatic. Plus, you have separate blood culture from catheter and peripheral vein. The same organism, and they are obtaining prior to initiation of antibiotic. So in summary, you should have positive culture of the same organism from periphery and from catheter, and more than 15 colony-forming units. Differential time of positivity 2 hours, which I said now. They reviewed it, which they said we will not depend on it. Remember that when you put UVC, you are very near to the heart. And the rate of eclampsia in UVC and UAC is the same. So let us review some clinical studies. This studies from Korea and 2019. They said healthcare associated infection in ICU, significant morbidity and mortality among hospitalized newborn. Almost 25% of very low birth weight, they have multiple infection, more than one infection during their stay in the hospital. And it is due to eclampsia. So eclampsia are the most common type of nosocomial infection in ICU. There's another study from Dublin. This study over 7.5 years, from 2006 to 2013, included 3,000 neonates with total of 656 catheter, eclampsia index varied. Here they compare the femoral venous catheter, and which we are not using anymore, and with UVC and big line peripheral insertion central line, and you will see here the incidence. Sorry. The femoral line is very high, 12.3 per 1,000 days, and umbilical venous catheter around 10.6, and peak line is the least, which is around 5.3. So it is half of the UVC. So what is the origin of microorganisms? From where come? Unfortunately, most of the infection, 60% of the infection, from skin organism, endogenous skin flora of the baby, plus experiencing healthcare worker hand or contaminated disinfectant. 12% from contaminated hub, same endogenous and exogenous from our hand, and less than 1% from contaminated infusate. But around 28% from distant hematogenous infection and unknown source. So risk factor for nosocomial infection plus IV catheter, ventilation, suction, medication, healthcare workers, overcrowding, understaffing, prolonged hospital stay, contaminated enteral feeding, neonate, other neonate with infection, and colonization by pathogenic organisms. This also studies the risk factor. They said that prematurity, very low birth weight, invasive procedures, indwelling vascular catheter, endotracheal tube, ventricular shunt, parenteral nutrition with lipid emulsion, alteration in skin and mucous membrane barriers, broad spectrum antibiotics, and prolonged hospitalization. We know also prolonged broad spectrum antibiotic lead to fungal infection. There's another study from American Academy of Pediatrics 2015, over 4 years, and 2 years study. And they said that they compared the late onset infection with eclampsia rate. They found the highest risk to get eclampsia, the less gestational age, the highest the rate of eclampsia. So prematurity is the highest risk factor. So micromere, so around 750, it is the highest, then followed by very low birth weight, extreme preterm, followed by very low birth weight, which is significant difference according to the gestational age and birth weight. Here another study, same from Korea study. Again, they confirmed that low birth weight is the most important factor for the occurrence of eclampsia or eclampsia, and they showed that micromere less than 750 reveals the highest eclampsia rate. For them, it was 3.3%. And here it was very definite from Netherlands study. They showed again the same conclusion that the less the gestational age, as you see here, the less gestational age, the highest the eclampsia rate. The more weight you are giving, less infection rate. Here about the organisms, 2/3 of the organisms, gram-positive organisms, staph, coagulase negative staph, cones, and followed by 37%. It was as high as 59 and decreased to 37% now, followed by staph and enterococcus. If you see here, 2/3 due to gram-positive, so mostly still gram-positive is high in the list. Then Candida, 5 to 6%, and other gram-negative organisms with predominance of Klebsiella in some areas, Pseudomonas, E. coli, and others. Just to mention that cones is problem because it's contaminated of the skin infection. We know that it's present in the skin of newborn. To get cones, we hope that you have multiple culture. If you cannot, we know neonate is difficult. 1 ml is the least to have, but you should have at least 1 lab criteria and 2 clinical criteria to say that it's clepsy. And remember, clepsy means it is central line and peripheral line positive. If you got only from clepsy, it's not, and peripheral line negative, it's not clepsy, it's contamination. Again here, 9 countries from different world. It shows the same organism, again, cones, staph, and the other organisms, the same sequence. So prevention is primary. The most important is prevention. Infection control is everyone business in the unit, in the hospital, in the administration, in the environmental surrounds, in the clerks. So it is the responsibility of everyone in the team. So form a dream team, not to have infection. So prevention is primary. It protects your patient, protect healthcare personnel, and promote quality of health care. So our aim is to control the risk of factors in your unit and to strict adherence to protocol for the insertion and maintenance of central venous line. So our aim to break the chain of transmission of infection. You know, infectious agent, reservoir, portal of entry, portal of exit, susceptible host. We have to break 1 or 2 or more of this chain of transmission. Don't forget transmission-based precaution, contact precaution, droplet precaution, airborne precaution, especially now COVID, we are using N95 for our gram-negative, I mean negative prevention is follow bundle of care. You should have head cover during any procedure, mask, sterile gloves.
Dr. Azzat, 5 minutes more. Huh?
5 minutes? Okay. Gowns and strict hand hygiene prior to your insertion. So here CDC in 2020, they found that poor hand hygiene the rate is 40% among healthcare workers. So you should improve your adherence to reduce infection and eliminate resistant organisms. Don't forget the type of hand hygiene. We know routine soap and water, 40 to 60 second minimum alcohol-based, 20 to 30 second, 5-moment hand hygiene. All of us, we know it to follow. So just a few facts. Cervix as small as pinhead may contain up to 20 million bacteria. Bacteria can double their number in 20 minutes. We can eliminate 90% of the germs just by proper hand washing. Wet hand transfer carry around 60,000 bacteria, while dry hand only spread 200. Residual moisture left in improper dried hand is a key factor for bacterial contamination and transmission. So dry your hand is just as important as washing your hand. This is a nurse or doctor touching the baby. He told her, I hope you washed your hand. So please wash your hand. So bundle of care, we have to follow bundle of care prevention. Again, you follow a cart for insertion and maintenance. Using central line bundles, hand hygiene, remove unnecessary lines, use maximum barrier precaution, skin antiseptics, avoid femoral lines, report eclampsia. Unless you measure it, you don't know it, okay? Here, just I want to comment about what the type of disinfect, because this is an area of discussion. 10% bovidine iodine, which is traditionally used till now, versus chlorhexidine with alcohol, and the concentration 2%, 2.5%. This is area to discuss, but now they started chlorhexidine before, not used before 2 months, but now they started even 28 days baby old, 1 kilo, but to have age of 10 days. It is skin irritant, it's absorbed systemically with CNS toxicity, but it's very safe, and comparison between bovidine iodine and the chlorhexidine, significant improvement in decreased rate of eclampsia with chlorhexidine. Now they started to use, and a lot of published study about this. The comparison around maybe if bovidine iodine, the infection rate 1.7 per thousand, and by chlorhexidine only 0.8 per thousand, American Academy of Pediatrics. So keep umbilical catheter 5 days for arterial catheter and 7 to 10 days for umbilical vein. Here, just I want to stress about antibiotic lock therapy or prophylactic vancomycin. Prophylactic vancomycin before insertion of the catheter has no role till now. Antibiotic lock technique, it is controversy, and a lot of studies about it, but it proved to reduce the central line as bloodstream infection, but still controversy about it. Because it leads still to high concentration of antibiotic. You are using 100 to 1,000 times, and antibiotic resistance is 1 point, fungal infection is another point, toxicity allergy is third point. So a lot of controversy about it, but no doubt that it's beneficial in certain cases. So educate your staff here. 2019, nursing care is improving very fast. So patient to nursing patient ratio, 1 to 1 or 1 to 2 in ICU, you should keep this ratio. Monitoring staff performance, most important, regularly educate, train, and give feedback to your medical staff about the various preventive measures at each stage. So build culture of safety, educate your staff, identify defect, learn from your defect, implement teamwork and communication tools, educate staff, create a chart and checklist, empower staff to stop procedure, remove unnecessary lines. So don't forget that breast milk, still ideal prevention. Probiotic now we think, follow antibiotic stewardship program, kangaroo care, limit your visitors, all this will help for prevention. So in summary, eclampsia is contribute to increase morbidity and mortality in our neonatal units. Clinical evaluation and microbiologic confirmation from peripheral and catheter line, no other source. Routine culture have no role in the absence of clinical suspicion of infection. This is colonization only. We are not doing it. So causative organism, still 2/3 is cones and staph, enterococcus, and then come to candida everywhere. And gold standard therapy is prevention, dream team, hand hygiene, CVC care, staff education, adequacy, breastfeeding is good prevention. This is my reference. So this is a thank you note from Baby Joy. I have done 136 days without bloodstream infection. Keep up the good work. My mom left some cases for you. So thank you and most welcome. Okay.
Thank you very much, Dr. Izzat, and a very interesting and very informative lecture. Let's move to the next speaker. Before we move to the next speaker, I want to welcome my brother, Dr. Muhammad Miqdadi, He is really the hero, and he's coming from Abu Dhabi, and appreciate his present really. And always I said, Muhammad is an, the fruits and dessert for any conference. So his lecture is a dessert. So that's why we want to make it at the end after finishing the eating. So thank you very much, Dr. Muqtadi, for coming to us. We will move to Dr. Next speaker, Dr. Lamia Yahya. She is a clinical pharmacist in Corniche Hospital in Abu Dhabi, and she will be with us virtually, and she will speak about also very interesting and very important lecture about total parenteral nutrition in units and overview. So please, the floor is you, Dr. Lamia.
Good morning, everybody. It's really a pleasure to be back to the ninth media conference. Thanks for the kind introduction. And I would like to thank also Dr. Mamdouh Suwailem and Dr. Sharif for their kind invitation. So parenteral nutrition for neonates, an overview. So by the end of this session, we shall be able to list the parenteral nutrition indications in neonates, to outline the importance of early optimal parenteral nutrition, to review the neonatal parenteral nutrition's contents, the fluid requirements, and PN as part of a total fluid intake in babies, the energy requirements and non-protein energy, the macronutrients, the electrolytes, the minerals, and the micronutrients. So as a quick introduction, in late 60s, Dr. Diudrik and his colleagues were working on or experimenting on supplementing nutrition through the parenteral route. They used central catheters, central IV catheters to introduce nutrients. They started with animal studies, and then they were successful in about 8 adult patients. By that time, baby Colleen in one of the hospitals in the United States was born with a congenital anomaly that prevented the baby from feeding enterally. The baby was not growing, was failing to thrive, and was sentenced to death unless the intervention by Dr. Diudrik and his colleagues, who tried the same, giving nutrients through the central line, and they were actually successful in saving that baby and bringing her weight up from 3.5 pounds only to 6.5 pounds in a stream of 6 weeks. So this leads us to the fact that in our today developed medicine, parenteral nutrition is a core element of the care of these preterm babies, and that central line, despite its hazards with infection, as we heard earlier, is a lifeline for these babies. So we are talking usually about starting nutrition early in preterm infants, but why early? We know that they have low tissue energy stores. Their glycogen, if any, is only produced during the 3rd trimester, so they have missed that phase in the pregnancy. Therefore, they will consume that glycogen in a very short time after birth. They have obligatory tissue catabolism, where we know now that they break their own body's protein at a rate of 0.5 gram per kg per day, and some experts say even more than that. They have essential fatty acid deficiency. They present early in life with disturbances in circulating electrolytes, especially a problem of hypernatremia, probably due to dehydration. They show fluctuation in their glucose readings. They show delayed tolerance to full enteral nutrition due to the prematurity of the intestine, and that compels the need for parenteral nutrition. And they, most of the time, show incomplete catch-up growth and development when you compare them to the peer full-term neonates. Now, despite it is a lecture about parenteral nutrition, I would like to emphasize the importance of enteral nutrition, and namely early trials of enteral nutrition. So it is encouraged as early as possible, maybe earlier in the form of small amounts, what we call trophic enteral feeds. And according to the risk of your patient, you want to advance by about 10 milliliters per kg per day at least. And according to the risk stratification, maybe even more than that. But why is it that I'm emphasizing the importance of enteral feeds? Because it is the physiologic route. It has shown positive outcomes for the GI mucosal integrity, the absorptive ability, and improvement to the immune function. Of course, the risk of infection, as mentioned, is high with parenteral nutrition, especially when combined with a prolonged NPO status in these babies. So the central line brings the risk, plus the NPO status and the atrophy to the enterocytes promotes translocation of bacteria and systemic infections. We know that enteral feeds are positive to the health of the liver. Even those babies who's been on prolonged parenteral nutrition, as soon as you start some enteral feeds, you notice improvement in their readings of direct bilirubin and less liver disease. And of course, prolonged NPO has shown on these babies to show some behavioral changes like oral aversion. They don't like to be fed by mouth. So now that we know the importance of early enteral feeds as well, let's go back to parenteral nutrition and see then what are the indications of parenteral nutrition in our preterm babies. So prematurity, of course, is the most compelling factor. Most of the units stick to less than 30 weeks gestation due to the gut immaturity and weight less than 1,500 grams. And recently, some units are adopting less to 1.25 kilograms. So less chance for babies to get into parenteral nutrition unnecessarily. And then there are other indications, namely pathology of the gastrointestinal system, precluding it from becoming the useful route of enteral feeding, at least temporarily. Some of these are surgical cases like neck necrotizing enterocolitis, in which sometimes requires some intestinal resection. If massive, might result into short bowel syndrome, which compels us to very prolonged periods of parenteral nutrition, and then some other surgical, temporary or long-term, like diaphragmatic hernia and others. So there are other indications also when the babies are very sick and hemodynamically unstable, undergoing shock, for example, especially with very high doses of vasopressors. The ischemia to the gut cannot be excluded, and sometimes a decision is taken for individual patient to hold enteral feeds at least temporarily until we think that the perfusion to the intestine has been improved. And then, of course, in different other conditions, surgical or very sick babies, according to the clinical decision. But when to start parenteral nutrition when it's indicated? Most of the literature support early introduction, and even some experts say within the very first hour of life. If you think about it, this baby, when a fetus in uterus, was getting continuous supply of nutrients in the uterus. So you want to try and replicate that as soon as possible. So recommended early for and including lipid from the first day of life, as well as vitamins and trace elements from the first day of life. So the literature speaks to us about short and long-term benefits. Moises and colleagues in a systematic review in 2013 spoke about the short-term benefits. They spoke about getting quickly regaining the birth weight and better weight at time of discharge, with no evidence of increase in morbidity or mortality. The SCAMP trial published in the UK in 2014 spoke about the long-term, talking about decreased postnatal growth failure, and namely better head circumference readings, which tells us about a better neurodevelopmental outcomes. And recently, the European Society for Pediatrics Gastroenterology Hepatology and Nutrition guidelines published in December 2018, the most up-to-date from this organization, recommending to start parenteral nutrition as soon as possible after birth so as to avoid metabolic shock caused by interruption of continuous feeding that occurred in utero. So now that we know that we need to start as early as possible, what are the components? Of course, fluid as a vehicle for the different macro and micronutrients. Energy is very important, and we'll give the amounts. Macronutrients, we call them macro because they are needed in relatively large amounts and because they are the energy providers. Those are your proteins, your carbohydrates, and lipids. Electrolytes, sodium, potassium, minerals, calcium, phosphorus, and magnesium, and the micronutrients. Micro because needed in small amounts, but very essential and important as coenzymes for many of the biochemical processes in the body. Those are our trace elements and vitamins. So fluid and energy, how much? For the full term, in the first day of life, usually about 40 milliliters per kg per day. Often we start them on 60 milliliters per kg per day. We increase by about 10 to 20 to reach a reasonable volume to provide good nutrients and to take the solute load in the circulation. So about 120 to 150 milliliters per kg per day. But the preterm infants usually need more. So in the first day of life, we start them at least 80. Sometimes we start them at 100 milliliter per kg per day, and we monitor their blood gases and we look at readings of sodium. We monitor their fluid balance almost every 6 hours within the first 24 to 48 hours, because this is the time when they seem to sometimes need more fluids to overcome problems of dehydration and hypernatremia. But usually the increments, the usual increments, if everything is okay, are about 10 to 20 milliliters per kg per day. And we mostly stop at 150, 160 milliliters per kg per day, where they seem to get reasonable amounts of calories, but some of them might need a little bit less or a little bit more. And we need to remember that parenteral nutrition is part of the total fluid intake, and that if there are other fluids that are running either to keep the patency of arterial lines or to deliver continuous infusion inotropes or sedatives, we have to deduct those volumes, and what's left will be your parenteral nutrition volume. Otherwise, you might be infusing diluted amounts of parenteral nutrition that are deducted from for different fluid purposes. What about the energy requirements? If we look at the basal energy expenditure, it's about 40 to 60 calories required just to keep the vital organs and to keep living and breathing. And then energy for growth for those babies, about 45 all the way to 67 calories to put on about 15 grams of weight daily. Unlike adults, here we're not thinking a lot of energy for activities and movement. So the ESPGHAN in 2018 guidelines for the preterm infants, they recommend 90 to 120 calories per kg per day. In the recovery phase, that's usually beyond the first 24 to 48 hours. In the first day, which they called the acute phase, they are okay to stick to up to 55 calories per kg per day, only because you cannot reach higher than that as you are limited by how much total fluid intake in the first day of life specifically. The factors that influence the energy requirements in these babies are mostly factors that we try to control while caring for those babies in incubators with temperatures that are controlled and humidity that is controlled. So prematurity leads to heat loss through the premature skin, and that's why they are in controlled incubators. Low birth weight, they have very high active organs that are premature and trying to catch up, so the energy for the whole body is very high. When they are under physiologic stress, they seem to sometimes need more calories, more energy. If you think about respiratory failure and how they need to recruit the respiratory muscles to keep breathing, they will need more energy. The feeding method, enteral feeding, requires energy for digestion and absorption, while with parenteral, that is negligible. and the ambient factors, we spoke about them. So the energy source, it's very important to emphasize on the non-protein sources of energy, namely the lipids and the dextrose. And the experts recommend almost 50-50 of non-protein energy to come from dextrose and lipid, but many times we end up giving a bit more from dextrose than we do from lipids. And the experts also emphasize on an important ratio: how many non-protein calories you give for each 1 gram of protein. And that ratio seems to be between 20 to 25 calories per 1 gram at least. Some experts speak about a bit higher than that. And this is important because you want to have the protein to go into tissue synthesis and growth for these babies, and not to be turned into calories because you are giving less non-protein calories. So next we will speak about those macronutrients that bring in the protein and the calories. Speaking about the protein, it's important to start early and to start optimal amounts as you start parenteral nutrition, so along with dextrose and lipids. The evidence has shown that this prevented significant protein loss and catabolism, showed minimal catabolism, as I mentioned, and resulted into positive nitrogen balance as early as the first day of life. So again, if we go back to ESPGHAN's recommendations, as well as the American Society for Parenteral and Enteral nutrition recommendations of 2019, we see that you can start your first day to add amino acids in about 1.5 at least, all the way to 3 grams per kilogram in the very first day itself. And then you can advance to a maximum of 3.5 to 4 grams per kg per day. The 3.5 is the upper limit with ESPGHAN, and up to 4 grams is the upper limit with Aspen. For the term infants, 2 to 3 grams per kg in the first day seem to be reasonable, and then you stick to 3 grams as your upper limit per kg per day for the term infant. Now let's speak about the second macronutrient, the carbohydrates in parenteral nutrition, and in parenteral nutrition, they come as dextrose. And it's important here to speak about the rate of dextrose infusion. So we no more refer to the dextrose in parenteral nutrition in percentage or even in grams per kg. The best is to speak glucose infusion or dextrose infusion rate in milligrams per kg per minute. And because the literature will give you the recommendations based on these numbers, and you can then evaluate whether you are underfeeding or overdoing it with the dextrose infusion. So the first day for the preterm baby, 4 to 8 milligrams per kg per minute, you increase gradually by 2 to 3 to reach a target of 8 to 10 milligram per kg per minute. So in this range, you are being nutritional, you are giving nutritional amount of dextrose. The maximum is 12 milligrams per kg per minute if you need to overcome hypoglycemia or to give more calories, but more than that will cause problems, and we'll speak about it. For the term baby, maybe a bit less in the first day of life, and we target 5 to 8 with a maximum of 12, 13, but sometimes we have to give more to some of the term babies as they sometimes struggle with hypoglycemia due to being born to mothers with gestational diabetes. So really in hypoglycemia, and I'm asked this question a lot, we infuse up to 14, 16 milligrams per kg per minute. Theoretically, there shouldn't be a ceiling because of the consequences of hypoglycemia on the brain. So where did we get these rates from? Basically, these are physiologic rates. If the baby is left alone that preterm, not given any source of carbohydrates, they will produce endogenous carbohydrates as much as they can to support the brain, and they will start 4 to 6, 4 to 8 milligram per minute. So that's your starting point. Where did we get the maximum from? It's the maximum oxidative capacity of the liver, over which, so if you infuse more, 13, 14 unnecessarily milligrams per kg per minute, the liver will just turn it into fat and store it. Why dextrose? As mentioned, it's the main or the chief energy source for the neonatal brain, a metabolically active organ beside the other organs. We noticed that the serum glucose will drop within the first 1 to 3 hours, but then they will pick up, and sometimes they go into gluconeogenesis for some time and produce hyperglycemia, but we know that they have limited stores of glycogen, and thus it's important to support them with a balanced nutrition containing dextrose as part of it. Now, the consequences of excessive dextrose intake, hyperglycemia that causes osmotic diuresis and dehydration and sets the stage for sepsis, so it's not recommended. Increased carbon dioxide production, which might sometimes interfere with ventilation. Lipogenesis, as I mentioned, higher rates of infusion will compel the liver to turn them into fat and store them in adipose tissues. But when the excessive infusion continues, the liver is not able to move these fat molecule outside and will be stored on the liver itself, causing liver steatosis and inflammation to the liver. Now to the third macronutrient, the lipids. They are tolerated from the very first day of life. The recommendations is to start already 3 grams per kg per day in the first day, immediately after birth, and the maximum is documented to be 4 grams per kg per day for the preterm infant, and preferably to include some lipids that contain omega-3 fatty acids, as they are thought to have an anti-inflammatory effect on the liver. Why the lipids? They are source of very high non-protein energy in small volume. So 1 gram of lipid emulsion, 20%, is only 5 milliliters, does not add a lot to the total fluid, even in a fluid restricted patient, and will give you 10 calories. So will improve your calories intake on those babies significantly, and therefore improve the net nitrogen balance. They contribute low osmolarity to the TPN, so they are not irritant to the veins, and they provide the essential fatty acids that are needed for the neurodevelopment and for the integrity of the skin, amongst other functions. Now to the electrolytes and minerals. We usually keep electrolytes, sodium and potassium, in maintenance amounts. And sometimes we have to correct in the parenteral nutrition if there is strict fluid restriction. So sometimes, yes, we might give a bit more than the maintenance if needed. Limited intake of sodium in the first day of life. Many units now revert to giving only a little bit of sodium glycerophosphate that will serve both phosphorus and a bit of sodium in the first day of life. And that's because they usually show hypernatremia in the first few 24 to 48 hours of life. And they will be getting sodium from many sources for flushes and for patency of lines. Potassium, usually classically we say none on the first day of life, but then 2 to 4 millimole per kg per day. But recently, ESPGHAN and in their most up-to-date guidelines, they ask us to review our statement about no potassium from the first day of life, and also the phosphorus. And that's because these babies are prone to refeeding-like syndrome, because with the high intake of amino acids and dextrose, there will be some intracellular shift of potassium and phosphorus, which put them at the risk of refeeding syndrome with consequences on the cardiovascular system. So if you establish the renal function, baby passed urine, it seems that the renal function is normal. We don't have evidence of accumulation of potassium and phosphorus. Why not maybe give a little bit potassium from the first day of life as well, maybe in the form of potassium acetate, maybe 1 millimole per kg, to help you also combat that metabolic acidosis that we see early in life with these babies. The minerals are calcium, phosphorus, magnesium, important to include from the very first day of life. During the third trimester of pregnancy, those babies will get high amounts of those minerals in utero, and when they are born prematurely, they have missed that, and therefore they are prone to osteopenia of prematurity. Some experts speak about the ratio, the molar ratio between calcium and phosphorus, and they recommend calcium to phosphorus to be 1.3 to 1 and even 1.7 to 1, which is in the practice difficult to attain. If you think about it, you always are struggling with higher readings of ionized calcium, and we're worried about nephrocalcinosis and other problems. But if you get the chance, sticking to this ratio might help the accretion in the bone and avoid osteopenia of prematurity. I'm about to conclude. These are my last 2 slides about the micronutrients. We have multi-trace element solutions that contain zinc, copper, manganese, selenium, and they all known to have physiologic important roles, specifically zinc for the integrity of the GI system and the skin, and maybe extra of it is needed in short bowel syndrome infants. Most of them act as coenzymes, as I mentioned, in biochemical processes in the body. Chromium comes as a contaminant, but has a physiologic role, so we're happy with it. But aluminum sometimes comes as a contaminant with parenteral nutrition that is toxic and doesn't have physiologic role, so we try to limit it. The vitamins are the fat-soluble vitamins A, D, E, and K. They all should be included, as well as the water-soluble vitamins, vitamin C and the B vitamins. And as the trace elements, they are also coenzymes in many of the biochemical reactions important for the health of these babies. So here I conclude. Thank you so much. And thanks again for the invitation.
Thank you, Dr. Lamia, for this comprehensive and made easy lecture about TPN in neonates. And thank you also for following to be just on time. Thank you very much. Our next speaker, our next lecture will be about cholestasis in neonates, an update. And it will be presented by Dr. Yasser Kamal Rashid.
Thank you. Thank you, Dr. Mamdouh and Dr. Sharif, for my invitation to the to the 9th Pedia Dubai. Inshallah, today we will discuss neonatal cholestasis, summary about neonatal cholestasis, but we will focus on biliary atresia. Actually, this presentation, I think it is important topic for all pediatrician, neonatologist, pediatric gastroenterologist, pediatric hepatologist. And I hope you find some benefit from this presentation. These are our objectives today, but we will discuss, we will enumerate causes of neonatal cholestasis. We will define neonatal cholestasis, enumerated differential diagnosis. We will discuss specifically today biliary atresia, and to know how to diagnose and management of biliary atresia. Actually, the time and the early proper diagnosis of neonatal cholestasis is very important, because the time factors play an important role in the prognosis of such cases. So early suspicion on put you all differential diagnosis in your mind when you're managing such a case is very important. Neonatal cholestasis, we define neonatal cholestasis physiologically as measurable decrease in bile flow. Pathologically, we defined it as bile pigment in the hepatocyte and other features like bile duct proliferation, bile duct plugs in the hepatocyte. These are essential to diagnose neonatal cholestasis. But clinically, accumulation of bile or any of its components, bile composed of many components, not bilirubin only. Bilirubin only is a small trace of bile, but bile salt is a major component, phospholipid, cholesterol, and bilirubin. Accumulation of these substances in blood can lead to manifestation. If bilirubin accumulated, it will lead to jaundice. This is the component of bile, which mainly bile salt, phospholipid, cholesterol, and the bilirubin with other conjugate. And this scheme can explain to us how the mechanism of cholestasis. Actually, the hepatocyte has two membranes, sinusoidal membrane and the canalicular membrane. Blood came facing this sinusoidal membrane, then this component of bile enter the hepatocyte. From the canalicular membrane, this component will leave the hepatocyte. For example, bile composed of many components, as we mentioned before. For bile salt, it will be carried to the hepatocyte, to NTCP, and excreted according to many transporter protein. For example, LFIC1, ATP-B11, this transmit bile acid. If mutation happen at this level, it will lead to FIC type 1, familial intrahepatic cholestasis type 1. Also, some of bile salt excreted by BSEB, bile salt export pump. If mutation occurred at this level, it will lead to familial intrahepatic cholestasis type 2. Bilirubin will be transmitted by MRB2, multi-resistance drug protein type 2. Mutation at this level will lead to Dobbin-Johnson syndrome. And we will discuss this point later. Patient may have cholestasis without jaundice, and other patient can also have jaundice without cholestasis, features of cholestasis. Phospholipid can be passed through canalicular membrane through MDR3 multi-drug resistant protein type 3. Mutation at this level will lead to familial intrahepatic cholestasis type 3. Cholesterol, this is cross a canalicular membrane according through two transporter, 50% each, ABCG5 and G8. Mutation at this level will lead to cytosterolemia. So cholestasis and hyperbilirubinemia are not synonymous. Frequently linked, but not unrelated. Sometimes the patient have cholestasis without jaundice, other patient, but few cases can have jaundice without cholestasis. We should be aware about the etiology of neonatal cholestasis. We should know differential diagnosis of neonatal cholestasis to know how to reach diagnosis or how to reach proper diagnosis in a proper time. We will enumerate in neonatal cholestasis. First, neonatal hepatitis. Neonatal hepatitis may be viral, may be bacterial, may be parasitic, may be idiopathic. Viral, most common cause torches. Torch should be ruled out, the hepatitis B surface antigen, but please not to request the hepatitis C in such cases. Bacterial, any sepsis can lead to neonatal cholestasis by also certain mechanisms. This endotoxin can lead to affection of some protein leading to cholestasis. Bacterial UTI is a common cause, but sepsis anywhere can lead to neonatal jaundice. Parasitic, for sure, one of the torch is a toxoplasma. Idiopathic causes, actually idiopathic hepatitis, previously it was the leading cause of neonatal cholestasis, but with awareness about the neonatal cholestasis, awareness about the differential diagnosis, about advancement of modalities for diagnosis, especially genetics, metabolic screening, this is not now the first cause of neonatal cholestasis. This other another causes for bile duct obstruction is one of the major causes of neonatal cholestasis. Cholangiopathies, these include biliary atresia, choledochal, non-syndromatic paucity, syndromatic paucity, bile duct stenosis, Caroli disease, bile duct perforation. All this can lead to cholestasis with bile duct obstruction. Others related also to bile duct obstruction, like inspissated bile, like cholestasis, like tumor masses, but tumor and the masses is not common in our age. It's common in adult. Cholestatic syndrome, some syndromes can lead to neonatal cholestasis. For example, familial intrahepatic cholestasis with different types, ARC, Nelson, cholestasis of North America, Agenese syndrome, all this can lead to neonatal cholestasis. Metabolic disorders. Metabolic disorders, either carbohydrate disorders like galactosemia, like certain type of glycogen storage disease. Not all type of glycogen storage can present it early in neonate with neonatal cholestasis. Cystic fibrosis, protein metabolism disorders like tyrosinemia, which is common cause, and one of the major causes can lead to early neonatal liver failure. Lipid storage diseases, especially in Niemann-Pick type C. Other metabolic disorder like cystic fibrosis, like urea cycle defect, also certain type are only, not all types, not all forms of urea cycle can lead to neonatal cholestasis. Mitochondrial disease, bile duct synthesis defect, these all are metabolic diseases that lead to neonatal cholestasis. Also, toxic and drugs, which is important in our field, like TBN, ceftriaxone antibiotic, fetal alcohol syndrome. Miscellaneous causes we cannot put in certain category: shock, histiocytosis, some trisomy, graft versus host disease, veno-occlusive disease, erythroblastoma fetalis. All this can lead to neonatal cholestasis. As we mentioned before, the incidence, now biliary atresia, because of awareness, highlights, definition of prolonged neonatal jaundice, but for biliary atresia, to enhance the doctor to search, to investigate for biliary atresia. So awareness about how to diagnose the biliary atresia, make it the first one in the etiologies of biliary atresia, with development of genetic screening and also metabolic screening, raise this to second and the third, and the idiopathic now is the fourth. But previously it was the first on the top of the etiologies of biliary atresia. What's biliary atresia? Biliary atresia is progressive, inflammatory, obliterative disease of the biliary system. Biliary atresia, the importance to know how to diagnose biliary atresia. Biliary atresia is the leading cause of liver transplantation in a child group. It also can lead to liver fibrosis, cirrhosis, portal hypertension, cirrhosis, and the manifestation of decompensated liver failure within a short period, considered in most serious 60 to 9 days, if not managed well. This is the most common form of cholestasis, as we know before. Biliary atresia can be classified according to the etiology into two forms: fetal or embryonic form, or postnatal form. What is the difference between these two forms? Actually, histologically, there is no difference. There is no difference histologically. A difference only on the presentation. Embryonic or fetal type, this is constitute only 10 to 35% of all cases of biliary atresia. Cholestasis present since birth. So please, doctor who are following bilirubin in neonate, please request at least one time it direct. Didn't consider all the patient will be in direct hyperbilirubinemia. The bile duct remnant may be absent in such a patient. There is associated malformation for patient with congenital or embryonic type, but this congenital malformation is not present with the postnatal form. Kimura and Hayes classified the biliary atresia anatomically into three types. Type 1, unfortunately, this type carries the best prognosis after a surgical correction, but actually this type, its incidence is very low, only 3 to 5%, some serious make it 5% of all cases of biliary atresia. This type, first type, carries the best prognosis after surgical correction, but the least incidence. Type 2, which is obliteration, including a common bile duct, both hepatic, right and left hepatic duct. This is constitute about 20%, and its prognosis is intermediate between type 1 and type 3. Type 3, unfortunately, this is the baddest prognosis among all cases of biliary atresia. Obliteration include extra and the intrahepatic biliary duct, but this is the most common type of biliary atresia. As we mentioned, the time factor is very important. So we need to hurry as we can to do early diagnosis. So suspicion of biliary atresia among a patient with neonatal cholestasis is very important. To know how to diagnose the biliary atresia is very important. To send the patient to the surgeon in a proper time is a very important point. How to diagnose the biliary atresia? Actually, diagnosis of biliary atresia is challenging, difficult in such cases. Why difficult? Because there is no confirmatory test to diagnose biliary atresia except the intraoperative cholangiogram. No other confirmatory test. All tests are suggestive for biliary atresia. Stool color is very important to take, to notice in such a patient. Clay colored stool is one of the cardinal features of biliary atresia, but it can occur in other forms of cholestasis. Associated anomalies. Associated anomalies, this is like polysplenia, intra-abdominal vascular malformation, marrow rotation, levocardia. This is common with the embryonic type, not with the postnatal type. Clinically, the patient will present with jaundice, with clay stool. Growth is an important point. Actually, this point is patient with biliary atresia, their growth is usually normal at the start, but later with the development of liver fibrosis, liver cirrhosis, ascites, the growth of the patient will be affected surely. Also, in addition to bleeding due to vitamin K, as all you know, that cholestasis will make the absorption of fat-soluble vitamin spore. No single test can be beneficial for diagnosis of biliary atresia except the IOC. Abdominal ultrasound. Ultrasound is important tools for diagnosis of biliary atresia. This ultrasound should be done on fasting babies, not in feeding a baby, because feeding will lead to contraction of the gallbladder, which is, will mask the presence of biliary atresia. Also, other features like TC sign, subcapsular hepatic flow, all these ultrasonic features of biliary atresia. الهيدا scan أو الهepatobiliary scintigraphy. This is the hepatoimmunodiacetic acid test. This test can differentiate between neonatal hepatitis and biliary atresia. Neonatal hepatitis means whatever the cause of cholestasis, metabolic infection, other causes rather than biliary atresia. Neonatal الهيدا scan depend on the hepatic uptake of the dye and the hepatic excretion of the dye. Actually, in patients with biliary atresia, the excretion will be affected, but the hepatic uptake will be normal. To increase the sensitivity of and specificity of this test, we give the patient phenobarb 5 days before the HIDA scan. It will help to increase the test sensitivity. But we need to remember that the HIDA scan is sensitive test, but not confirmatory. Some centers are doing a bile stained tubal duodenal aspirate and do aspiration and test for conjugated bilirubin. If it came positive, this rule out biliary atresia, but not done in all centers. Liver biopsy. Liver biopsy is also a very important tool for diagnosis of biliary atresia. Accuracy 95% or more, but proper sample is very important. At least you need to take 5 to 7 portal tract to diagnose biliary atresia. This is one of the study we did it in our university to assess sensitivity and the specificity of liver biopsy in diagnosing biliary atresia, we find some features of histopathology carry more than 97% of specificity and sensitivity, like bile duct blood, like duct proliferation. This came with biliary atresia more. Okay, no, I finished already. This intraoperative cholangiogram management. This is Dr. Kasai, Morio Kasai, who did the first Kasai surgery. Factor affecting the prognosis of biliary atresia, the time of surgery, so proper diagnosis in early time is very important. Second, a remnant of bile ductules at the porta hepat at the time of surgery is very important. Early post-operative usage of steroid, some center compare it. Recurrent ascending cholangitis, one of the most serious complication, can lead to failure of Kasai operation, and finally, surgeon experience. Liver transplantation, if patient is not resolved after Kasai or entered on secondary biliary cirrhosis with other complication of portal hypertension, this patient should be for liver transplantation. But please, if you find a patient neglected biliary atresia, no need to send for Kasai. Send the patient directly for liver transplantation. Also, this study we did for patients who did liver transplantation, compare the patient biliary atresia who did Kasai with patient who didn't Kasai for result of liver transplantation. Actually, a time factor during the surgery, too much prolonged in patient with Kasai procedure due to the adhesion, due to the anatomical changement, but other patient who didn't do show less time of the surgery. Last message, our message today is only one message. Early accurate diagnosis is unimportant for successful treatment. Thank you. And I hope this COVID pandemic will end soonly, to invite you to our first International Scientific Pediatric Gastroenterology, Hepatology, and Nutrition Conference, inshallah, in the next year. Thank you.
Our next lecture will be about blood pressure prematurity, what we know so far, and it will be presented by our eminent Dr. Janine Khani, a consultant, a neurologist and pediatrician, and he's the chief of service of pediatric and neurology in Arafa Hospital Abu Dhabi, which is affiliated with Royal Hospital in the United States. He is also TMA chairperson. He is certified American Board of Pediatrics and also American Board certified in neonatal and perinatal.
First, before Dr. start, I want to thank Dr. Junaid for his participation. Ready to hear me? Hello, Dr. Junaid, can you hear me? Okay.
Yeah. Okay, Sharif. Thank you very much, and good morning to everybody. Due to some restrictions from the hospital administration, I cannot come to Dubai. But anyway, I can be with you all the time, and very soon we will be do a live conference. So, topic of today: what are the factors affecting the outcome? Okay, so the topic of today is factor affecting outcome for the low birth weight babies. The topic is very vast, but I try to cover it in this giving time. So the prematurity and survival is always the hot topic for all of us, and it has a lot of morbidity and mortality. But what we have to do in a in a very meticulous way, we can do and we can help those babies. So the early deliveries, the death can be the more than 40% of, and 40% of infant morbidity. This is the very latest data from Abu Dhabi, and it is published from the Zayed University in International Journal of Environment in 2020 in Public Health. And the rate of the preterm and the low birth weight were found to be high, it's 6.3%, but it still is lower than other Middle Eastern countries. But so they suggest that the current study highlights the need for further interventional research to tackle these public health issues, such as reducing the high CS rate. And this is one of the problem, that we have a high CS rate, and it can affect the outcome of those babies. The morbidity in singletons without anomalies is also high, and it is not only the very micro preemies, it's also in the moderate preemie and the late preterm. And as you can see here, they can also get intubated, and they have the other morbidity, and the p-values are significant in that. Now, look, come to this part, the cognitive ability. This is the very important data to look into it. 24 weekers, and this is 32 weekers, and this is the adjusted IQ. So even the 33 weeker barely reaches the 95 IQ, adjusted IQ, and adjusted controlled mean is 100. We have to think about it. So we can give a baby who can be the good human being of the outcome of that as an adult, and he can be important member of our social society. So, but if we have, just save the baby and then forget about what is the cognitive ability, then it's a big problem. So that's why this is just a very recent data which is presented in Hot Topics. I was in Hot Topics and it just finished yesterday, Thursday evening. And this is the data from the Germany, and they are doing it. This is the Sweden, Germany, Austria, different European country. So very micro preemie, the many of those centers are giving just a comfort care. And the reason is that we have to understand that just the survival is not the only important thing. There are many other things which we can have to look into it. So I have to admit that whenever I saw a picture in a magazine and newspaper, 22-weeker, 450-gram survivor, and there's a big hype on that, miracle baby. These are just hype around nothing, and it not give a right situation that what is happening to the baby. And why I'm saying that, because the Satyan, Dr. Satyan make this very important slide. The factor influencing the adult outcomes for the preterms, not only the pregnancy and fetal health, the environment, the socioeconomic status of the family, the education, the pollution, the maternal and the paternal factors, the preterm and the birth and the consequences, the many of those can affect the adult outcome. We're not looking just to survive this baby, but to look the healthy adult outcome of those babies. So having said that, we have to admit that these babies cannot be dealt with very good outcome in any center. So this is the study which is take 1976 to 2010, and they found out that the mortality rates increase for preterm infant not born hospital with a level 3 NICU. So not all the NICUs are able to have those babies. And this is again published in 2018 in OBGYN, and they also suggest that morbidity, mortality composite outcome showed that VLBW infant delivered at high levels NICU had improved outcome compared with those delivered at low ones. So we have to understand that everything related to those babies are important. Now there is a lot of prenatal intervention, and this thing we will go through one by one. So let's start that the baby is not delivered yet, and the mother is with you, and you are expecting the baby to deliver. The most important thing nowadays, which can affect the outcome of those babies, is antenatal steroid. Please ask your OBGYN to give antenatal steroids. We are giving antenatal steroid up to 38 weeks of gestation. If the mother come and just deliver, you cannot do much. But if you have, most of the time you have that much time to give antenatal steroid. And there's a lot of data, but look at the death, IVH, grade 3 and PVL by ANS exposure. Here, the ANS antenatal steroid is in here, no antenatal steroid. So any age group, it is much better outcome. Same with the IVH grade 3, exposure to ANS is much better outcome. Not only the IVH, but also the respiratory support, the composite need after the betamethasone is much improved, and it is statistically significant as compared to the placebo. Severe respiratory morbidity is also improved in the antenatal steroids. So there's the two major outcomes I just told you, but there are many ways antenatal steroids help. So this is just the meta-analysis as published in 2016, and it favors the corticosteroids in the help of the severe respiratory distress syndrome. Another thing which you can do, you should give to all those ladies and all those mother antenatal magnesium sulfate. And this is the neuroprotective effect in utero exposure to magnesium sulfate. It has antioxidant effect, it blockage of glutamate activated calcium channel, prevention of large blood pressure fluctuation. There are two major trials. One is analysis, and the one is trial, PREMAC trial, which is about 600 women, less than 33 weeks, and they have a very good, strong trend toward protective effect of magnesium against CP or death. Then the Cochrane review had the meta-analysis, which is 5 trials, including 6,000 infants, and they also found that there's a significant reduction at risk of any CP and moderate to severe CP. Number need to treat is 63, but magnesium sulfate is not that expensive, so it is okay. Now, the interpartum interventions are also very important. We have to look into it, into many things. First is, as I mentioned about the C-section, look at this data, which is published in 2009. This is the 50%, this is the respiratory morbidity, the 50% is the highest. This is the elective C-section. Look at the 34, 35, 36 week, the elective C-section, the respiratory morbidity is high as compared to the planned vaginal delivery. And it goes, and it is the same at about 39 weeks. But due to some reason, which is not explained very well, in 41 weeks, it start again increasing. Now come to the neonatal factors. So the most important thing nowadays, when the baby delivered, we heard about delayed cord clamping. Delayed cord clamping has a lot of effect. Please do not mix with the delayed cord clamping with the umbilical cord milking. Again, this is very recently, the day before, 2 days ago, the ILCOR member presented this data into the hot topics, and they found it out the same, which we know that delayed cord clamping has a benefits as compared to the umbilical cord milking in a very premature babies. And it is not only the benefits which is written here, there are many. This is only just the tip of the iceberg, is the many other benefits. But I will show you one data which is get my attention too much, because we are using this technology of the NIRS in my previous place of the work. The delayed cord clamping 60-second to 90-second improve the tissue oxygenation index. This is the brain tissue oxygenation, and by the help of this technology, you can see how much is the saturation. So look at this at 4-hour, 24-hour, and 72-hour, it is higher than as compared to the control group. So the delayed cord clamping, you should apply it in your centers. The ETT sectioning or the sectionings at any time of any babies, if there is no consensus on that. And if the baby don't need a section, do not do the section. There is no such thing called routine section. And why I'm saying that, because in the full-term babies, look at that, the minutes to at 86% saturation and minute to 92% saturation in section babies and section babies, it was delayed. It is delayed by almost 3 minutes, and 92% is almost 4 to 5 minutes. So look at this. So why we are doing it? If we don't need it, we shouldn't do it. And that's why there's another data in 2013 that if you just wipe the mouth and nose, it is just as good as you are sectioning and without any delayed in the saturation of the babies. Now, the very important thing, that mechanical ventilation. We should avoid mechanical ventilation as much as possible. The intubation should give the stress, procedure, higher intrathoracic pressure, reduced venous return, and suctioning. Hemodynamic changes can happen. We just discussed about that. So that's why there are many studies done on that. One is by our friend Dr. Hani Ali in 2012. Is a retrospective study. Is found that the IVF was independently associated with lower birth weight mechanical ventilation and the cumulative duration of the mechanical ventilation. So not only the respiratory problem, the neurological outcome can be affected by the ventilation. The other study, which is 2018 in the Alberta group from the Canada, they published that high tidal volume delivery during mask PPV at birth was associated with brain injury. Strategies to limit the tidal volume delivery during the mask PPV should be used to prevent high tidal volume delivery. So this is the thing, that the gentle, as much as gentle you are with the baby, that is the outcome is good. So this is not a brainer that CPAP, we are all using it in the delivery room, even the very smallest baby, we start with that. This is the Cochrane review in 2016 and go in the favor of CPAP. So the death of the BPD is in the favor of the CPAP, is published in the neonatal research also. But the problem is this one. I always show this study, this article provided by Peter Davis, one of our friend, and they did a very comprehensive studies about 12,000 babies. And what they found it out in a very micro preemies, 25 to 28 weeks, the 43% is the failure rate of the CPAP, and 29 to 32 weeks, it is the bigger babies, 21% the failure rate. And the incidence of the death of the BPD increase in those babies. So how to tackle that problem? So my response to all those evidence is that, yes, we started with the CPAP. Yes, we rescue the babies. I have a very low threshold. So as soon as we reach 6 centimeter or anything above 30% of oxygen on those small babies, we give the surfactant. So is this right to, yes, if you go through all the evidence, there is no time to go through it, but it is right. And the CPAP is not the magic bullet for the BPD. We should, as we see just in the previous slide. So the search is still continue. The CPAP and the surfactant without the ETT, yes. So what we are doing is the LISA technique, and I will show you something on that. So now you deliver the baby, you put the baby on the CPAP, but the baby is not doing well. So we have to give surfactant because it's a surfactant deficient baby. Surfactant not only help in the respiratory problems, but also help in the neuro development and the IVH, as you can see here. So the prophylaxis versus rescue, this is the controversy, is that you should give the surfactant prophylactically to all those babies, or you do the rescue. The problem is the literature. The pre-CPAP literature showed the prophylaxis is better than rescue. The CPAP era, which is late 90s and the early 2000, it showed decreased death or BPD if it's stabilized on CPAP than rescue surfactant. So the rescue surfactant is recommended, but we are having a very, very low threshold. As soon as we think that the baby needed, we give the surfactant, we remove the catheter, and we put the baby again on the CPAP or NIPPV. So how to give the surfactant? This is the ensure technique. You intubate, you remove the surfactant, laryngeal mask administration. This is gaining attention in hot topics. The data is presented. But we are, as you said, using the LISA technique, and the death and the BPD, as you can see, are not crossing the line of one confidence interval as compared to here with ensure technique. And not only that, there's a ranking probability of strategies published in 2016. The least, if you see the death or the chronic lung disease, the LISA ranking #1 in favor of decreasing both. And if you take the BPD alone, again, the LISA technique is #1. So this is about the surfactant, how you do that. Which surfactant? There's a lot of debate. There's one meta-analysis is published in Cochrane, is the favor in the porcine or porcine surfactant, but still the debate is going on. Whatever you have, if you are doing and you are doing other things in the right direction, I think the outcome can be good. Caffeine, you all know, we will start the caffeine at the day one, okay? As soon as the possible, you should start, but we are not starting in the delivery room. There is no data to suggest that. So start the caffeine as much as possible, and there is no data that we should start in the delivery room. Caffeine is really a very good medicine in helping those babies. Another controversy is about the transfusion, that the transfusion has the risk of the independent risk for many things. So here the first, the controversies between the RBC transfusion and the NECs, which is not really anything related to it. And the data suggests not. But among the very low birth weights in RBC transfusion, for subsequent developing severe IVH, yes, it is can be the independent course. So this is the latest guideline given yesterday by Dr. Harish Kirpalani, that how you, when you transfuse the babies. So it is cardiopulmonary disease, if 12 gram, 36%. If it is on oxygen dependent, then it's 30%, otherwise 7. So although they said in their debate that there is no difference between the conservative and the liberal transfusion data, but they like the more restrictive transfusion policies as compared to the liberal. Postnatal steroids has always a lot of controversies, but there are some data which suggests that if you give the postnatal steroid after 7 days of life, it can help the outcome of the babies in the right directions. Now the comfort measures, the pain, stress, swallowing, all these can help this baby. So the quiet, dark environment help in the neuro development of those babies. So appropriate respiratory support, avoid rapid IV flushes, UA, UVC sampling. This is called the IVH bundle of the care. And we had this bundle in my previous place of the work, and it's very easy to follow. You just have to take that you are following it in all those babies. And I cannot share the data right now because our publication in reducing IVH in preterm baby less than 30 weeks of gestation in NICU level 3, a bundle of the care, it is in public. It is already in publication, so it is come in 2-3 months from now. So I will share that data. It really help in reducing the IVH of the babies. Midline head positioning, we should do that for the first 72 hours, and the data suggests in favor of it. Now, the other cares are very important, maintaining the temperature. Many times you will see if you take the temperature of those micropreemies, they are hypothermic. So please try to maintain the temperature 36.5 to 37.5. The fluid management is big controversy. Somebody start 70, somebody start 90, but this is the recommendation, 70 to 90 ml per kg per day. Restrictive fluid reduce PDA, NAC, and BPD. Links sodium supplementation to day 3 improves the outcome. And early feeds, as just Lamia talk about that with the EBM. This is another important outcome, or another important guideline from the consensus guideline 2019, and also the AAP. Please do not try to treat the numbers. So the treatment of hypotension is only, I put it in red and the bold, recommended when it is confirmed by the evidence of poor tissue perfusion, such as oliguria, acidosis, and poor capillary return, rather than purely on numerical values. And the reason is that the dopamine has the vasoconstrictor effect, and when the baby is on the transition and the pulmonary vessels try to relax, and if you start the dopamine, it can give the vasoconstriction in the pulmonary vasculature and can give you the PPH, and which can affect the your treatment and everything. So please do not go through the gestational age and the mean blood pressure, and you start just to see if the baby is perfused very well, if it's oliguria or not, if it is poor capillary return, and then only. This is again the controversy. The PDA, we are not treating that often, but when we have to treat, we use the paracetamol. Hemoglobin, I already discussed about it. Now, the impact of choosing bovine products. Now, this is a very important thing that, so not only the NEC, the formula feeding is not appropriate. We have to encourage breast feeding. And of course, beyond NEC prevention, there is a lot of other things which we have to look into it. The breast milk is the best. It decreases the ROP, it decreases the mortality, it decreases the BPD, and the neurodevelopmental outcome is also great. Now, this is again another friend of ours is Dr. Joseph New publishes this in 2020, that how you prevent the NEC in those small babies. So decrease risk of NEC. Antenatal steroid is one of them. If you have to close, the ibuprofen has much in favor of the not to get NEC as compared to the indomethacin, but we are using acetaminophen, which is more less side effect as compared to both of these. The very important thing that lower saturation can give you the increased chances of NEC as compared to the higher. So we are putting 90 to 95%, and these are some data on that. The important thing to show here is the slow versus delayed or the early. So that's the thing, that you shouldn't slow the feeding. You give 20 to 25 ml per kg per day and increase progressively, which goes in favor of better outcome as compared to the delayed feeding. Human milk fortified, because the recommended dose, as Lamia just mentioned, is 4, but the premature milk has only 2.5. So that's the problem. That's the problem here is going on. So we have to fortify the milk. And as you can see here, not only the protein, but also the other micronutrients. If you give the human milk alone in those premature, the chances of having osteopenia prematurity and other problems are high as compared to the fortified milk. You can fortify it with the powder, but now the human milk fortifier is also available. So this will not take too much time. Now this is the preterm birth anticipated. You give antenatal steroids, ask them. What we are doing is accordingly to get a better outcome is that if the baby is more than 27 weeks and breathing, we start with nasal CPAP, 30% oxygen, and titrate accordingly. And if this baby will not tolerate, then of course we intubate, give Lisa technique, and give the surfactant. If the baby is less than 27 week, we have a very low threshold to do the Lisa and give the surfactant. As I told you, prophylactic work is rescue, the failure of the CPAP. In those micropremies, the chances of having more failure are more here as compared to the international data. We put the saturation limit 90 to 96% for less than 1500 gram or the 32 weeks. Hemodynamic stability, check the urine output, check the perfusion, check the lactic acid by your blood gas, and do not jump onto the pressors or the dopamine and dobutamine unless until you really need that. Had in the midline for the 72 hours. So we have this IVH care bundle, which I just showed you. It is very effective in reducing the rate of the IVH. We strictly follow the golden rule. We have to complete all the major things like UAC, UVC, if the baby needed antibiotics within first hour of the life. Caffeine, as I told you, is the very important to start as early as possible. Not only the respiratory problem, it helps in the neurodevelopmental outcome of those babies. Cranial ultrasound we do in the day number of life of 3. Try to have as much as non-invasive monitoring. Whether you have NIRS or not is not a problem, but you try to do as much as non-invasive monitoring. Do not use the blood gases too much because when you take the blood quickly and give back that blood quickly, it can affect the autoregulation, cerebral autoregulation of those babies. So if you don't need, there is no need to do the very frequent blood gases in these babies. You can just monitor by the non-invasive monitoring, pulse oximetry, and the carbon dioxide or the carbon dioxide measurement, entitled carbon dioxide measurement. TPN we just discussed. Rightly, we start with the 3 gram per kg per day amino acid, 1 gram per kg per day. The intralipid 80 ml to 90 ml per kg per day. The fluid we start day 1, which we call vanilla TPN. Early feeding, as soon as we have the breast milk, we are not waiting for more than 48 hours for breast milk. Remember this, and we just discussed in the hot topic with Dr. Joseph New, the worst thing is the empty gut, then is the formula, then is the donor milk, and of course the best is the breast milk. So this is the thing, the breast milk is the best, then the donor milk, then the formula, and the worst is to keep the baby, keep the gut empty. So that's why start as soon as possible the feed. We remove the UAC, UVC less than 7 days, and if the baby needed for some reason, we put the PIC line. Of course, the minimum handling, there is no such thing called routine sectioning or routine this thing, routine measurement. If the baby needed, we touch the baby, otherwise there is no this thing. And of course, the kangaroo care. So that's all I have to talk about. But in the last, I will give you this thing that all those micropreemie babies are saying that I'm not just a small baby, I am a preterm baby, I am a unique baby with unique problems. So we have to handle them uniquely. Thanks a lot.
Thank you very much, Dr. Juliet Khan, for very informative and very interesting lecture. There will be room for further discussion. We are waiting about Muhammad, so we will try to invite the questions. I can put the speaker, we can come to the stage to.
Assalamu alaikum. Dr. Zak, thanks a lot for your presentation on CRBS. I just want to know one or two things. Why we do not send the central line catheter tips for culture? Why we don't send the catheter tips of central lines for culture to see whether there's a contamination or infection? Why don't we send the central lines
Okay.
tip?
Yes. You see, doctor, we are sending for a meaning, okay? If you want to isolate organism, okay, and you want to treat, right? So if you want to colonize, all catheters, okay, will be colonized.
Yes.
Either internally or externally,
yes.
okay?
Sure.
And the organism liable to make biofilm, I mean, from the host factors and from the microorganism, good? Okay. So if you start to isolate the colonized catheter, okay, you will make here confusion in the lab, in the infection control, in the house care associated infection. So once isolated, you will find infection control come to you. So this is catheter induced infection. So report it, do it, what you did for it. So that's why internationally,
We don't send.
you don't send. Contamination is nothing. Like exactly like you have throat in your organism.
Yeah.
You have in your throat organism. On my hand organism. I wash hand, I treat it.
Second
Okay.
question follows the same thing.
Yes.
When should and how should the neonatologist or a pediatrician interpret the result from the culture we take from the central lines, but we take from the peripheral lines? Suppose both for aerobic, anaerobic, and fungi. We take from the central lines or we take from the peripheral lines.
Yes.
So what are the guidelines to guide us? Suppose from the central line, the result comes after 12 hours, it's positive for, suppose, X gram positive. And from the peripheral line, the result comes after 8 hours, it is positive. Is it contamination or is it infection? Because the baby may be symptomatic. That's why we have sent the culture from central line as well as from the peripheral line.
Right.
So how do we interpret it, whether it's an infection or it's a contamination?
Okay. So, now we agreed that once a baby clinically is not well, symptomatic, that is the time I will take blood culture, and once I have central line, I will take from central line and periphery. Okay. Routinely, if the central line is the cause, the heaviest of the growth will be in the catheter, right? So internationally, they said that mostly even they were putting this criteria, but which is not followed now anymore, that 3 times the growth, the heaviest growth culture, for example, colony forming unit will be 50 from the catheter and will be, for example, 20 only or 15 from the peripheral. So this is central line infection. And I spoke about differential time to positivity. Again, it is very easy to isolate first from the line because it is heavy growth, and then it will come to you culture. And they calculate the time around 2 hours, minimum 2 hours, okay? And they reviewed these values, and but once a baby clinically is positive, you take blood and you start antibiotic, and then you reevaluate after your culture.
That means all bacteremia are not similar to septicemia.
Sorry?
All bacteremia,
Dr. Khalid, please make the microphone away.
All babies who have bacteremia, they not be having septicemia. It is mandatory the child who has bacteremia will have septicemia. What's the difference between this bacteremia and septicemia? How you differentiate with the child is bacteremic and is septicemic?
Okay. Bacteremia, doctor, is just the presence of bacteria in the blood.
Yeah.
Septicemia is sepsis defined clinically unstable baby. Hemodynamic stable, apnea, life-threatening. Sepsemia is life-threatening. He can have metastasis anywhere. He can have go to meninges, to his joints, to whatever, go everywhere. So bacteremia can be just the presence of the organism in the blood.
Thank you.
This
Thanks.
is the difference. Okay, thank you. Just please, I would like just to say comment about epilepsy, about the disinfectant we are using. Now, if you review the literature, you'll find chlorhexidine gluconate with alcohol is the ideal now. Dilution is 0.5%, even I said 28 weeks. And you can minimize the toxicity just to let it on the skin till dry for 30 seconds. And minimum is 15 seconds. And by this, you can reduce the epilepsy rate to very high value, to around 5 times less what is present in the time being, if in compared to 10% of iodine. The other point about anti-look therapy, antibiotic look therapy, the American Academy studied it extensively now, and they found that the incidence of epilepsy reduced by 67%. So it is still area to be applied to other center. Thank you.
Okay, no more questions. May I call Dr. Yasser Kamal to receive his award? Thank you, Doctor, for sharing your knowledge today. We will have a 10-minute coffee break, and we will start again the next session after 10 minutes. Thank you.
Good morning, all. Thank you, Dr. Adil, for the introduction. Thank you, Dr. Sharif, inviting me for the 9th Pediatric Pedia Dubai. It is a very nice, and it is an evidence-based medicine conference. It is the first time we meet after 10 months of holding because of COVID. We have one interesting subject now, non-invasive ventilation. I think all pediatricians face non-invasive ventilation, and they have to be oriented and fully evidented about this lecture. First of all, I have nothing to disclose. Objective for this lecture, we will go through different non-invasive ventilation strategies. We will focus on how can we use. We will go through the evidence. We will see the risk and benefit, indication and contraindications, predictors of failure, which is a very important part for a successful non-invasive ventilation, and we will explore little about our own experience. So decision to start ventilation for any baby, it is not a simple decision. It is not totally safe. It is a decision need critical analysis, need clinical judgment. We need to understand fully what is the goal for the initiation of ventilation for any pediatric or neonate. Without risk, we said ventilation, always there is risk. So how can we think about mechanical ventilation, non-invasive ventilation? So what ventilatory support we will use? It is invasive versus non-invasive. What is the mode or interface I will select for my patient? What is the mode? And this is extensively discussed yesterday by Dr. Imam. And even what is the choice for ventilators? There is many ventilators in the market, and you need to choose what is suitable in your case. 3 points need to be in your mind when you initiate ventilation. What about airway failure? Because the presence of airway failure will put you in one single selection about invasive ventilation. There is no non-invasive ventilation. What about the oxygenation problem? Simply baby desaturate, this is not reflecting what is going on. You need to understand more about the oxygenation problem of your baby and how severe this oxygenation problem. And we will see later on what is recommended for ARDS. The immediate anticipation for intubation is also will close the door for non-invasive ventilation. The last, sorry, the increased ventilatory demand. And there is new study support this area, especially in patient with sepsis. There is new recommendation how to do respiratory support. So non-invasive ventilation is a ventilation without use of invasive tube or invasive instrument. Mode of ventilation, we have many modes. The famous mode and old mode, negative pressure ventilation. We have CPAP, commonly used in neonate. We have high flow nasal cannula, which is commonly used in neonate and pediatric, even in adult now. And other modes of non-invasive ventilation, like pressure control ventilation, BiPAP ventilation, pressure support ventilation, volume control ventilation, and there is new modes of ventilation like NAVA, non-invasive ventilation, and other sophisticated modes. What is the mechanism of action for non-invasive ventilation? Number one, it will do chest stabilization. It will upload the diaphragm load and the muscle for the chest cage load. It will increase the tidal volume and the minute ventilation. It will improve your functional residual capacity and improve ventilation perfusion also for the lung. It will prevent atelectasis, especially in small babies with secretion. It will decrease the O2 beam and it will stent the airway. Also, it is known to improve apnea and hypoapnea. Why non-invasive ventilation may work better in small babies and infants, and even it work also better in adult, but in pediatric age groups there is many reasons to use. Also, we maintain the chest compliance. The predicted functional residual capacity improvement in pediatric is much more than adult because of the dead space is less. It will increase the pharyngeal tone, which is very important during expiration. The fatigue, anti-fatigue fibers in the diaphragm, it is less in the pediatric age group. So non-invasive ventilation is a good modality to use. And it will show a better improvement in oxygenation with marginal increase in pressure. You don't need to go up too high with the pressure to get an improvement in oxygenation. What other benefit can non-invasive ventilation give to you? You avoid the intubation with all the risk for intubation. It will improve the time for the bedside caregiver, so the sister may have better performance and doctors also. It will decrease the nosocomial infection. This is very logic because there is no risk of VAP. It will potentiate the decrease of stay in ICU. The days of stay in ICU will be less cost, no sedation, and for long-term non-invasive ventilation also, you will avoid the risk of tracheostomy. So rule of non-invasive ventilation, or others can say this is the indication of non-invasive ventilation: hypoxia, hypercarbia. This is the well-known two reasons for initiation of respiratory support. Cases of post-operative usually may get benefit. Post-extubation, some cases will benefit with early initiation of non-invasive ventilation immediately post-extubation, especially patient like CB, patient with muscle disease, patient with prolonged ventilation. In chronic cases, chronic obstructive airway disease will be benefit. Cystic fibrosis, because they have chronic illness and chronic lung disease, they have a great chance to be supported with non-invasive ventilation. Neuromuscular disorder, but we know neuromuscular disorder may go one way, acute like Guillain-Barré or non-acute like other cases with genetic disorder. And also non-invasive ventilation is a good modality for the end-of-life care. When we decide no ventilation, you can replace your invasive ventilation with non-invasive ventilation. What will stop you from using non-invasive ventilation? We mentioned before the anticipated need for intubation, immediate need, cardiopulmonary arrest. Patient post-cardiopulmonary arrest is not suitable for non-invasive ventilation, with some exceptional cases. Patient with low Glasgow Coma scale less than 8 because they cannot protect the airway. Apnea, this is very good parameter to follow. If your patient have any attacks of apnea more than 2 in the last 24 hours, he is not suitable for non-invasive ventilation. And if you have upper airway problem like epiglottitis or burn. This is a busy slide, but it will reflect what we face really in initiating non-invasive ventilation. The interface will be a major issue for most of the physicians and nurses, because selection of the interface need experience, need training, need understanding. Sometimes you need judgment and sedation. There is many interface, maybe whole mask, nasal mask. There is many things you can use. There is one review article, how to initiate this non-invasive ventilation, and this is why I bring this and all details present in this article. What complication you can get from non-invasive ventilation? As any ventilation, air leak is the most worrying complication you will get. Aspiration, because there is no ET tube and there is risk of acute gastric dilatation and vomiting. Hemodynamic instability, because non-invasive ventilation will improve the left side heart, but it will decrease the function of the right side, and it will decrease the venous return. So hemodynamic instability may be there. Severe hypoxemia can be a complication for non-invasive ventilation. Many patients may end with hypoxemia, trauma because of the interface, and gastric distension. This slide, it is not ICU slide. This is a slide from the same paper we just shown for the interface. It will show you how to go through the initiation of giving baby oxygen. If the baby need escalation, how to go for high flow nasal oxygen, how to go for CPAP, how to go even for non-invasive ventilation, and by the end to invasive ventilation. I said this article is very good. Try to go through it. Again, what about the evidence in ARDS with non-invasive ventilation? The success rate of non-invasive ventilation was lowest in patients with acute respiratory distress. It is 22. And following extubation, the outcome also is not good. This is a more recent study. It is 2019 by Jan, reflecting what is going on in ARDS. It gives the same conclusion, that the outcome with ARDS, non-invasive ventilation, is not optimal and the failure rate is very high. There is a very important row here for FiO2. If you go from this lecture only with this row, this is excellent for you. Because if you compare the FiO2 given for the two groups, the successful group and the non-successful group, in the successful group, the maximum 60. So most of the successful cases getting FiO2 40 to 60. For the non-successful group, they are 60 to 80. So from this article, the maximum FiO2 you can use in the maximum FiO2 you can get for your patient is 80. Some centers using 100%. I don't recommend this. The maximum here 80, and it is associated with high failure rate. Here in the success group, it is 60, and the outcome is good, and the success is good. What about using non-invasive ventilation in lower airway? It is beneficial. We are using, all of us, in acute bronchiolitis, in asthma, and we can see here the success rate is very good. It is up to 70 something, and which is a good outcome for patient with bronchiolitis and asthma. Now, this is the serious part of the non-invasive ventilation. Predictors of failure. How can I predict my patient will not benefit from non-invasive ventilation? Pneumonia, as we mentioned, and acute respiratory distress syndrome, there is great risk of failure, and those patients need to be taken seriously and to be followed closely. If you have a low score for your ICU, like PRISM or any other score, and multi-affection, multi-system affection, this also carry a great risk. Blood, this is the score for sepsis. Also the score for sepsis, if it is high, this against use of non-invasive ventilation, and it is a red flag, this patient will fail and need intubation soon. Response to treatment, which is very crucial. Any patient, as shown in the studies, start non-invasive ventilation, need to be closely monitored for the first hour. Blood gas need to be repeated in the first 30 minutes, maximum 60 minutes. If there is improvement, continue the treatment. If there is no improvement, reassess and judge. pH less than 7.25 is a risk factor. Saturation, this is very important. This is the assessment for acute adult respiratory distress syndrome. If your assessment, the hypoxia index is less than 200, which is moderate to severe ARDS, the risk for failure is very high. Also, you can get information from the ventilator. You are using the ventilator with EBAB and IBAB. You can see what is the mean airway pressure you deliver to your patient. If it is more than 11.5, this is a risk factor for failure. And small age, this is reflecting what we said before, the risk of apnea, the risk of small airway and secretion. This is very important because non-invasive ventilation is a good tool, but safety also need to be in the front. Another recent study about the same, what is the failure in non-invasive ventilation? This is 2019, and it will say the same. The failure is higher in ARDS. The failure is higher with complicated cases. There is also one single marker used in other study, which is in conclusion here, tachypnea. You can use this only as a marker of failure. In some areas, you cannot calculate the scores, you cannot do hypoxia index, you cannot calculate for pulmonary indices. Just simply follow the respiratory rate. If the patient respiratory rate improve, this is a good sign, continue. If the patient respiratory rate don't improve, this is the first and the most bad sign. This is our study we do years back for non-invasive ventilation. It is done in Oman. It is a retrospective study comparing the use of non-invasive ventilation in different age group. We can see here the demographic data. It is almost all patient homogeneous, but non-invasive ventilation used more in small babies. This is the indication why we use non-invasive ventilation in the study. You have here pneumonia, bronchopneumonia, bronchiolitis, aspiration pneumonia, recurrent apnea, which was against the recommendation earlier. But sometimes in a center with extensive experience and good hands, they can modify the risk for such patient. Hematology patient usually benefit from non-invasive ventilation, like patient with leukemia and they are immune compromised. We need to avoid intubation and we can use non-invasive ventilation. Sickle cell disease with lung involvement usually benefit from non-invasive ventilation and post-operative patient. Here we compare the two groups, the group of ventilation before and after. You can see there is improvement in the heart rate, improvement in the respiratory rate, improvement in oxygen saturation, and all significant, improvement with significance. CO2 elimination, which is a very important part. So non-invasive ventilation from our side, or from our experience, is safe and can be used in many indications safely, except pneumonia is a risk factor in our study and they need to be restudied. This is another case. This is a neglected case of nephrocystinosis. This is a baby come to us and she need ventilation for 3 months. We ventilate her in 3 months with non-invasive ventilation. And this is the picture before and after ventilation. Just because if you remove the respiratory load, this can improve the growth of such small babies, neglected babies. This is another interesting part. Usually, we use non-invasive ventilation, CPAP, high-flow nasal cannula in our units, in the ward. But what about those patients requiring escalation? Those patients require to be transferred to another hospital. If the family asks you a simple question, doctor, you will transfer my baby, is it safe? You may not find the answer. Or you may give a rough answer. Yes, this is non-invasive ventilation, it is safe. But here in this study, you can find it is what is the exact risk for non-invasive ventilation during transport. It's 0.4, and how much for the adverse outcome also mentioned in this paper. So you can answer the family and you can give them an evidence-based answer for the safety during transport. What else important in transport? The ambulance is totally different from the unit. So if you have pressure in the unit, it may not be available in the ambulance. If you have certain oxygen flow in the unit, it is not exactly the same in the ambulance. So this need experience and needs the team to be aware how can I use the non-invasive ventilation in the ambulance circumstances. And each unit can do this safely, inshallah. This is another study. This is non-published study. It is from the last Federal Pediatric Critical Care Conference in the last week. It is in Brazil, and it reflects the use of non-invasive ventilation in patients with end-stage liver failure and liver transplantation, which may be a very new. يعني patient with liver transplantation and liver with end-stage liver disease, they have extensive ascites, they have hepatorenal syndrome, they have abdominal distension. For the logic, the use of non-invasive ventilation may not work in this group, but in Brazil they start to use and they have a success rate. It is not high success rate like midway success, but anyway there is success even when you use for patient with liver disease and abdominal problem. Also, cardiac centers start to use non-invasive ventilation post-operatively for open heart disease, which is a good step. So in conclusion, because of the time, non-invasive ventilation can be used in acute and chronic situation and cases. It improves hypoxemia. It will be excellent in immune compromised patient. It will help you post-extubation. It will get benefit to your patient to avoid intubation. And we need more studies to get more information. Take home message, this is one patient also ventilated with non-invasive ventilation. Here is a selection of machine. This is Philips machine. This is not a pediatric machine. This is adult machine. Because this patient almost 12 years and she has cystic fibrosis, and ventilation in such patient will be difficult. If you use a pediatric ventilator with low flow, this patient will never be comfortable and she will refuse the ventilation. But we use the Philips machine, which with very high generation flow, and the compensation for leak also is very high. You can see the patient can live normally. She can remove the mask in between. She can eat. This patient ventilated for 3 months with cystic fibrosis. So non-invasive ventilation is good modality for respiratory insufficiency and for ventilation in ICU. Successful rate will depend mainly on the training of the treating team. Don't invent the wheel. Every information, as I show you in the papers, don't try to do something new. All the information available for non-invasive ventilation, just go and read. Try to follow the evidence base. Don't follow your experience. We all have extensive experience in non-invasive ventilation, but whenever we have new evidence, please try to use the evidence, especially the maximum use of FiO2. In our unit, the maximum use of oxygen, 60%. Any patient above 60%, consultant need to be informed, reassessment, judgment to continue or to stop. Most probably stop non-invasive ventilation, be ready with invasive ventilation. Thank you very much.
Thank you very much, Dr. Anas, for informative and comprehensive lecture. Only allow one questions only for Dr. Anas because limited time for praying. Any questions?
Yes. Very good question. Actually, I was preparing like this. I don't know if this will come or not. I have like 4 documents about how to initiate non-invasive ventilation. Can we show this one? You have to maintain a document like a guideline for you in your unit about how to initiate. There is like one paper document for high flow nasal cannula and one like this. I have this document how to initiate high flow nasal cannula and how to maintain, when to escalate from high flow nasal cannula to CPAP and how to maintain. The other part of the question, the second part, high flow. This is excellent question. It is raised in the treatment of ARDS. We have a high failure rate in the group of ARDS, those patients with adult respiratory distress syndrome. But if we compare our performance and our initial setting with the adult initiate non-invasive ventilation with a beep of 10. With a beep of 10. This is why the result in the adult is better than the pediatric. I show you in this oxygen paper, there is also the initial setting. It is almost 6 to 8. So we initially do maybe a mistake. We are supporting those patients with low pressure that will end with failure. This is very good. The patient with higher pressure may be required in certain circumstances, especially ARDS, when your hypoxia index is less than, near 200 or around. But if you have patient like with asthma, it will not be wise to initiate a high beep. Although some patients may improve with high beep in asthma, but this is extremely rare and this need understanding from the lung dynamics and what specific requirement for such patient. But in general, patient with bronchiolitis, patient with pneumonia, they may benefit from higher oxygen depending on the adult studies. This is not my recommendation. And patient with asthma and other diseases like heart problem may benefit from lower pressure initiation. The recommendation extensively studied in Australia, and it is recommended 2 per kg for the first 10 kg. And yes, and if you will go higher, it will be 0.5 per kg above 10 kg. Yeah, please follow the guidelines. But this also for the beginners, for the resident, for the first on call. Consultants may use a higher flow in certain circumstances. Suppose you have a patient with SMA and he require ventilation. You know this patient problem is not oxygenation, his problem is ventilation. This patient will benefit from higher flow. We have an interesting conference years back in US. They gave us in the animal lab the high flow. We use it ourselves, and you can try the high flow by yourself. The sense of high flow is not bad. If you are using 20, it is almost same like 40. And also for the pediatric, it is the same, except if the high flow is extensively high. For pediatric, if you are still less than 40, this is safe and you can use in certain patients. But this need advanced decision. It is not like a general decision. Assessment, teamwork. I give the team what is the ventilation protocol or what is the ventilation strategy in my mind, they will follow. Then in SMA, you use high flow, maybe 3 or 4, and you use the minimal FiO2. And usually we keep this patient with very low oxygen saturation. The system initially will resist, but the idea of giving low oxygen is to keep the stimulus for the central nervous system for hypoxia. And if this patient exposed for high oxygen for a long time, there will be insensitivity, and there will be like blunt response to high CO2 and the blunt response to hypoxia, and this patient can arrest. You need to generate a specific strategy for each patient for ventilation. Welcome.
Thank you very much, Dr. Anas, for nice explanation.
No more questions?
No more questions, okay? Okay, thank you very much.
Now, I'm proud to announce and present Dr. Mahmoud Sadek Habib, my senior, and he was present one of the most important topics, interesting topic about new NICU, how to protect our newborn brain, which I consider one of the important topics regarding the outcome of NICU practice. Dr. Mahmoud Sadek Habib is a consultant neonatologist, head of neonatology and pediatric department in Latifa Maternity Children's Hospital, chief of the neonatal and prenatal fellowship program, which is in Dubai, UAE. Proud to present you, Dr. Mahmoud.
Thank you, Dr. Amr, for the introduction, and thank you, Dr. Sharif, for the invitation and the organizing committee. Assalamu alaikum. Thank you. I have nothing to disclose. These are some of the references in the topic, and I will run quickly through the topic because this topic I give it over 2 days as a workshop in Ukraine. So now it is 20 minutes. Worldwide, we have every year almost 15 million newborn preterm baby. Out of these preterm babies, 1.1 million die, and usually because of preterm complications or intrapartum related events. So it is a critical situation which needs attention from the healthcare providers. The most important consequences of prematurity is the long-term neurodevelopmental problems ending with cerebral palsy or motor and cognitive impairment, visual and auditory deficits, also emotional burden for the family and financial burden for the society. And as an example, in USA, almost 26.2 billion dollars is needed every year for these premature consequences of premature deliveries. So the focus for the care of the premature is not only the survival, it is to have a normal premature with a normal neurodevelopment and as much as possible normal life for this newborn and his family. So prevention is the best medicine. Some key facts about the brain: almost 100 billion neurons at birth. During the first year of life, neurons form new connections every 1,000 every second. At 3 years, it is twice active as brain, and it needs more energy than the adult. And that's why it is very important to take care of the brain, because all these areas on the brain, if anything is affected, it will affect either the speech, the touch, the neurodevelopment of this baby. So we say the brain is built antenatally during the pregnancy. We say the brain is built. We have a brain growth from mid-gestation to 2 years of age, almost from 25 to 75% the growth of the brain, and with billion of neurons building. So prenatally, there is genetic factor, but the most important is nutrition, antenatal care, and low stress, which cover the part of the 1,000 day of delivery, or of gestation and delivery. And we have postnatal factors, which is the support again, nutrition, stimulation, healthy environment, and low stress. The premature, especially the premature, is a vulnerable population for damage in the brain. Especially, it occurs around the 40 weeks. If he's delivered premature, then if he's delivered premature, all the senses, all the pathway needed for the human brain development, the sensory pathway, the language, the higher cognitive, it will be affected. So the baby, instead of having a normal brain when he's born at 25 weeks, ending with a normal brain at a term baby, he will not have this, and consequently all or many parts of the brain will become affected. So from here came the concept of neurocritical care. Initially, it started with the adults, a collaboration for the neurosurgical cases, multidisciplinary approach. And the first neonatal critical care took place in San Francisco Hospital, California, San Francisco, 2008. And it depends on certain concepts, which is brain-focused care, which we will speak how it is, new therapies and diagnostic tools, and care bundles. If we follow many of the things which we will say, I disagree in the morning when Dr. Junaid mentioned 450, 420. We had 450 and we had 420 babies who delivered, discharged, and we are following in the clinic. They are neurodevelopmentally normal. So it can be done, but it needs, of course, a lot of effort and a very good teamwork. So the neuro and ICU, as I mentioned, it's a collaboration between the neonatologist and the pediatric neurology. It is built on 4 parts or framework we call neuroprotection, neuromonitoring, neuroimaging, and neuroassessment. And the main thing is to maintain a stable cerebral blood flow and oxygen delivery based on hemodynamic monitoring. Now, the first one, the neuroprotective care, is organized by 7 core measures: safeguarding sleeping, nutrition, positioning, partnering, family care, protecting skin, healing environment, and minimizing pain. It can be challenging, but it can be done. Of course, everything, when to be done, you have to prepare a very good staff, to prepare a very good guidelines and rules for the work. Safeguard sleep. The goal is to assess the infant sleep wake state before caregiving and to protect prolonged periods of uninterrupted sleep whenever possible. Because the neurosensory of the brain development of the premature baby, it depends on the rapid and non-rapid eye movement which happen during sleep. So if it is interrupted every now and then, definitely the proper development of the brain will not take place. Visual system matures towards the ends of normal gestation. So that's why, as we will see later on, you don't even have to, when you have to avoid the light, especially before 28s, from directing on the face of the baby. Now, at least you should leave the baby sleep a continuous 60 minutes. What happened nowadays in most of the NICUs, and I will, as you will see from the records of the sounds, how many decibel, every now somebody is speaking, somebody is pricking, somebody is changing the pumper. So no rest for this baby at all. So definitely if this take place, then his proper neurodevelopment, it will be affected. Try to protect the eyes from bright lightning all the times. Only when you care, you will use a dim light. Use narcotics and sedatives only when it's necessary and with the minimal dose, because again, it affects the rapid and the non-rapid eye movements of the sleep. Positioning, the best position is the prone nested and side line nested, because I want to reduce as much as possible the manipulation of the baby in order to maintain his autonomic system, which control the blood pressure, the heart rate. So if I move him in improper way, or he's sleeping uncomfortably and he's very sensitive, with added extra factors from here and there, his blood pressure very easily it will go up. This fluctuation in the blood pressure, definitely it will be one of the factors which leads to IVH or affection of his neurodevelopment. Avoid turning more than 45 to either side. Therapeutic positioning, when we say it is, the baby is comfortably nested with his hands flexed in a special way, his legs flexed in a special way, so he's comfortable. This will help his autonomic system to run properly. Handle with care, again, for the same reason, because of the autonomic stability, because all this I am targeting to maintain a normal cerebral blood flow so that no fluctuation will happen. So we have instructions for all the team when they care for the baby, whether it's the respiratory therapist, whether it is the occupational therapist, or the nurse, or the doctor, how to deal with the baby, how to turn him and move so that his autonomic stability will not be affected. And always, like mentioned in the morning, suctioning only when it's necessarily, minimize pain and stress, flush and draw the umbilical lines very slowly, especially when you are doing exchange transfusion. If it is done quickly, definitely it might even kill the baby. So all this will lead to a less chance of IVH. Family care, partnering with the families. Now, most of the hospitals, they are JCI, they are baby-friendly hospital. So automatically, the area is shifting to a family-centered care. In our hospital, we made the design of the new extension in a way that the mother can come, sit, breastfeed, She want to express, there is a special room. She want in the same room, there is a special chair, comfortable with cover. So when this is provided, this will, as we will see now, the touch of the parents and many other factors will help the neurodevelopment of the baby. Now, this family-centered care, it will help the implementation of the kangaroo care, which is very important. And of course, the most important principles of family-centered care, that they are partnered with you as a doctor in the care of the baby, is proper explanation, proper support, empowerment, and respect, and delivering the information. By now, I'm sure everybody is using kangaroo care in his unit. It is a must, at least in our unit. Even the tiniest baby, 25 weeks or 26 weeks, if vital signs and even on ventilation, he can do kangaroo care, whether the father or mother. And these are some of the benefits. And if you notice, I put green light on the things which is affected by the autonomic system. So it decreases stress, decreases crying, it stabilizes physiological parameters, minimizes pain, improves sleep. So it is, and most important, it helps on the exclusive breastfeeding and the more production of the milk. And of course, if you want to implement this, you should have guidelines for this in your unit, which cover the steps for kangaroo mother care in the unit. Same like you put 10 steps and steps for the successful breastfeeding. Also, you have to minimize pain. Of course, there is no specific science for pain. It can be, but all these things can happen. You can see facial expression, brow bulge, brow drawn together. So you have to get acquainted with this common things which happen, so that you will realize that this baby is in pain, he needs something to be done. And of course, no neonatal unit should be without a pain assessment tool, which decide what I'm going to give to this baby, whether it is a pharmacological or non-pharmacological treatment. And the best thing nowadays is the kangaroo care, the non-nutritive sucking, and the sucrose. You just dip the pacifier in the sucrose, or with a syringe, 2 drops on the tip of the tongue. This sucrose, for 2 minutes, it will release the endogenous opioid, and it will help the baby in not feeling any pain. Stress, there is some also stress which reflect that there is affection of the autoimmune system. Many, it's a big list. The handout will be with the, in case anyone interested. And there is things which shows that the baby is stable. There is no fluctuation in the color. He's sleeping calmly. He's having a smooth, well-modulated tone. The sleep is proper. Contrary to the other situation, there is a glazy-eyed, staring eye. Sometimes if you put the light suddenly on the baby, he will not be able to disengage from this light, which is very serious for the premature babies. Healing environment. Now, the healing environment, it deals with the things which surround the baby in the NICU. Which we call it the sensory surroundings and experiences, which is temperature, touch, position, movement, proprioception, smell, taste, hearing, and noise, and vision, and light. All these things, it should be attended and take care of it. Otherwise, definitely the results will not be good neurodevelopmentally for this baby. So, for the temperature, baby is already inside the womb of the mother, warm. When he come out, it is a warmed incubator. Then immediately he should be shifted to an incubator which not noisy, already preheated to the optimum temperature. Because the more he utilizes energy, the more he's the more he, he become hypothermic, and he want to produce energy, the more his oxygen consumption will become, and the more cerebral blood flow will be affected. So ideal, and of course, ideal infant environment is skin to skin. In India, they tried with even 1.2 kg when this kangaroo care thing started. There was shortage of equipments and incubators, and many babies with 1.1, 1.2 kg survived just because of the kangaroo care. It is really a gift from God. The mother can adjust automatically inside her by the way, will of God. Temperature can go down 2 degrees or 1 degree up according to the temperature skin of the baby. So kangaroo care, always remember, it is very important. Touch. Again, this is the first of the senses to develop early in fetal life. It is very important for growth, development, communication, and learning. The parental touch and nurturing is crucial for the infant's emotional well-being. We always advise the mother when she comes to visit her baby, or the father, after they do disinfection, sit beside your baby, speak with your baby in a low voice, touch the baby. This touch, it is very important for the sensory neurodevelopment of the preterm. If the mother is not there, sometimes the nurse will hold the baby hands, not tightly, just as if cuddling the hands. This, you can even sometimes see the vital signs. Baby is crying or tachycardic. When you do this, he's settled down. So touch is very important, especially when it is from the parents. The sense of touch, vestibular and proprioception. This develop after touch, the inner ear and the brain. They control balance and eye movement. Usually, it's when the baby is inside the womb, he moves in any direction he wants. In the NICU, again, skin-to-skin contact is very important for this thing. Then we go for the taste and smell. The taste, it starts by 24 weeks. The baby can appreciate the same smell and the same taste of the amniotic fluid when he was in the mother. So when you give him the milk, the mother of the milk, as if the mother is around him, and he touch, he feel, he recognize the biological level of the contents of the milk. Olfactory system, it functions by 28 weeks, and usually again it can smell the mother, can smell the same thing from the milk. That's why we say use the pacifier or drops of the mother milk on the tongue of the baby. It will help him in this situation. Taste and smell. The ability to control states enables the infant to process and respond information about the environment and begins the brain's hand wiring of behavioral skills. Self-regulation, now to coordinate and organize motor activity, levels of arousals, attention, it is essential later on for learning, planning, decision-making, complex actions, and resisting temptations. All this will be helped by giving simply few drops from the mother, whether for tasting or smelling. The noise. The ear is formed by 20 weeks gestational age. But the baby, he will not be able to assess the sound properly except by 6 months. So auditory input at this time is capable of stimulating physiological response, and accordingly, if I am speaking beside this baby, and I will show you the level of the voices if we are doing this, it will immediately trigger changes in the autonomic system, which means either his heart rate will become high or his heart rate respiratory rate will become high, blood pressure might go up, so it can lead to fluctuation of blood pressure. All this increase in cerebral blood flow in response to a loud noise, which can lead to IVH. So noise can also cause permanent structural damage to the cochlear nerves. When the sensorineural hearing loss occurs in the NICU, then definitely this baby, he will not be able to develop later on the proper speech and language. There will be definitely delay in his speech and language because it's both dependent. The American Association of Pediatrics recommends that the noise level should be below 45 decibel. Most NICU have noise levels reaching up to 90. This is an example. If you can see, sometimes if you put only formula bottle on top of the incubator, it can reach up to 108. Continuous adult exposure to workplace for 8 hours, 90. So most of the things, it is high voice because, okay, thank you. So sound level in incubator, when closing the portal, it can reach to 124, and the recommended is below 45 decibel. We put in the NICU one of the projects which we do, quality improvement project, to reduce the sound. We have a sound detector which record, we see what's the level, we take action to improve things, because it's not fair to work hard on a 450 grams and then eventually, because of some people are speaking loudly or closing the door in a bad way, he will be neurodevelopmentally not normal. The baby will not be able to develop regarding the vision, being the final sense to mature. Usually the fetus he does not need outside light, and adequate sleep is essential for retinal development and intact pathways to visual cortex. A visual experience from term infants should include light directed away from him, not at his face. If you do this, as I said earlier, for a preterm baby, he will become, his vision, he cannot disengage. He will have like a stare look, which is very serious if it is repeated. And the best thing for the baby, the cradle position. His prone position, he's not exposed to the light, so it helps both as a secure position and for his neurodevelopment. There is visual development of preterm infants can be supported by 3 basic goals: safeguard sleep, protect eyes from direct light. Protecting the rapid eye movement will help the proper vision later on, and dimming the light and these things. For infants less than 28 weeks gestation, maintain light away from the baby. For infants 28 to 36 weeks, you need light just to support seeing what's happening. But mother face is very important. If you direct the light on the mother face, it's okay. Now, nutrients, it's very important for this is the remaining of the neuroprotective. Nutrients particularly affect early brain development and later adult function. The usual nutrients, components of all the nutrients which we take, it's very important for the energy. So if there is defect in any of these things, in any of the components, like protein, you will get critical sensible period by neurodevelopment. Every component, it can lead to one of the neurological affection. The human milk, it has all the components needed for nutrition. That's why if you compare it with this is the components of the human milk. It contains antibodies, anti-inflammatory, probiotics, everything. This is the component of the formula. So imagine when you give this to the baby and you ignore all this. You can see what will be the result for the development of that newborn. And that's why The breastfed baby, always we say it's much healthy. And for the premature baby, all these things, decreased incidence of infection, neck, diarrhea, better neurodevelopment, more rapid gastric emptying, all these things, it is because of the, when you give premature, when you give the mother milk to the baby. Of course, the mother milk baby, one of the challenges that most of the time, it is not enough. But it is well known that a non-breastfed child is 14 times more likely to die in the first 6 months than the exclusively breastfed baby. Evidence is very strong, as you've seen in the previous slide, that neck improved neurodevelopmental outcome is much better when you are giving breastfeeding than if you are giving formula feed. Of course, if it's not there, you will give the donor milk. If it is not there, you will give the formula. But as I said, one of the challenges is to increase the mother milk. And many times the mother milk can be deficient. It can be due to nutrient limitations of human milk, maternal postnatal depression, maternal medical complications. She's in an ICU. She does not have the milk. She's refusing to give milk. So for this, you should have always a plan how to manage such situation. So that's why you should, fortification is there, especially if there is limitation. There is something called new BFHI, which is it's the same like BFH, Baby Friendly Hospital Initiative, with some added features, not widely spread. Few Swedish countries, they utilize kangaroo care and family-centered care. All this will help to ensure that there is either from the mother or a support or encourage her to give milk. The 10 steps to successful breastfeeding, everybody I think is aware about it. Now, according to the new update, critical management procedure, that there should be international code, feeding policy, and establish a data management system. And this is unfortunately one of the major defects in the area now. If you go to the WHO, you will not find any data. Maybe the last one, it was in 2016 or 2018, 17. So for everything, when there is data, you can see your results, and based on these results, you can take action and do quality improvement projects. Of course, all these things, how to support breastfeeding in the hospital, rooming in, support mothers, counsel mothers, do not provide anything apart from the mother milk, discuss before even delivering. And this is the International Code of Marketing of Breast Milk Substitutes. No donations, no advertising, no gifts, no free samples. Then this was the neuroprotective part. The remaining is just two slides. The neuromonitoring, this, I want my target in the NICU that the cerebral blood flow is maintained, the oxygen consumption is okay, so that the baby will not go into extra effort in order to get oxygen, or an extra effort which will lead to fluctuation of his cerebral blood flow. So one of the things which is very helpful is the amplitude integrated electroencephalogram. And of course, I mean, one has, it doesn't, you don't need, when you have the augmented integrated electroencephalogram, you don't need to have the neurologist there, because you can get trained on it and read it yourself. If the neurologist is there, then he can help you with this, or he can do the usual EEG. And in one study, it showed that the results, severely abnormal AEEG recording within 72 hours after birth can predict white matter damage and long-term poor outcomes in very preterm infants. So it can be used as an early marker. The near-infrared spectroscopy, it measures the regional oxygen saturation of brain, kidneys, and abdominal systems. The idea, you put the electrode, which has two markers, which has two sensors. One, it gives the light, and the other one, it's photodetector. The light will go through the skin, skull, and the brain, and then it will be detected by the other side. And usually there is 25 to 75% arterial to venous ratio. The expected here it is, of course, it will be very bad if it's like this. The proper one, it should be in this range, 55 to above 85. There is no international consensus on this, what is the normal, what's not the normal. But most of the people, they are following these readings. At the moment, we are doing some studies on the renal because it is very less studies, but the cerebral already, most of the people are using this, and the mesenteric is using this. It is help in monitoring. 2 minutes. These are some of the actions which you will take it when it is low or high, whether you will adjust your ventilation or increase fluids or neuroimaging. It will help you and identify conditions and accordingly manage. And neuro assessment, of course, neurological assessment of the newborn. It is not easy like the pediatric. If there is a neurologist, excellent. If there is no neurologist, then the person should be fit and know how to assess so he can detect things early and do the needful. So the take-home message, brain development is influenced by what happens in the NICU. Negative and positive experiences influence brain development. NERS and EEG are really helpful tools for the NICU. The 7 core measures of the neuroprophylactic or neuroprotective care in the NICU, it is a must. And of course, breastfeeding and exclusive breastfeeding is a must also, and very important for the neurodevelopment of the newborn. Thank you.
Thank you so much, Dr. Mahmoud. Really, I had amazing practice before in ICU, Fatima Hospital, almost for 2 weeks. And evidence is that, mashallah, unit there, almost following strictly the most advanced guidelines of needs. And mashallah, like Dr. Mahmoud said, kangaroo ear, skin to skin, control of the light, sound, noise, and everything. Even I'm proud that during my work there, my first publication was the unit of the nurse, and this is the first time to practice nurse, I think, in the MENA region. Thanks a lot, Dr. Mahmoud, for that informative and very valuable lecture. So please, if anyone want to ask a question for Dr. Mahmoud, you're welcome.
Okay, we shift to the third speaker, which I extend my pleasure to introduce Dr. Orfat Al-Zahabi to speak about a wonderful topic regarding normative neonatal facial biometrics in United Arab Emirates for non-invasive early detection of genetic disorder. Dr. Orfat Al-Zahabi, consultant pediatrician and head of pediatric department in Fujairah Hospital. Let us welcome Dr. Orfat.
Assalamu alaikum. Thanks, everybody. Thanks, Dr. Hamar. Today, my talk will be different from the other topics. I'm going to talk about a normative neonatal facial biometric in United Arab Emirates for a non-invasive early detection of genetic disorder. Actually, Ministry of the Health and the Prevention are doing some project regarding the early detection of syndromic patient. And the Minister of the Health doing this project in cooperation with the Sheikh Zayed Institute in Washington, D.C. The aim, how to diagnose the syndromic patient or dysmorphic baby from the birth. So before going to diagnose the syndromic patient, we have to know the normative neonatal facial biometrics. These my teams, or who participate in this one, yeah, I saw it. Yeah. Okay, this the teams already participate in this project from Fujairah Hospital and Al Qasimi Hospital. So the birth defect. Unfortunately, the UAE ranks the 6th out of 193 countries in the term of the prevention of birth defect. This already published in 2010. And as you know, birth defect constitutes the fourth most common cause of the death. So newborn screening can identify the early children at risk for a better outcome. So address silent local health need to develop the advanced health child care service, and really what the Minister of the Health and the Prevention work hard for this. So newborn condition, because as we know, newborn condition can affect the child's long-term health or survival, often associated with facial dysmorphology and the cardiac condition. So if we can pick the dysmorphic feature from beginning, we can go ahead and screen these patients from the cardiac disease, from many organs can be affected. We cannot shift him from syndromic to non-syndromic, but at least we can provide him better, better lifespan. So early detection, diagnosis, and intervention can prevent this and disability. So as I mentioned, we are doing this project, the United Arab Emirates, Ministry of the Health and Prevention, and Al Qasimi and the Fujairah Hospital. But now also we extend to the Abdullah bin Umran and Al Baraha Hospital. But unfortunately, during the 2020, our data become less. We are not working hard because, you know, with the corona outbreak, everything is changed. And the other part is Children's National Health System, Washington, this Sheikh Zayed Institute for Pediatric Surgical Innovation. This is the project. Actually, we are working in two projects. This is a kind of the really innovation and to show how the technology can affect the health care. So our project, the MGene, this is what I'm going to talk. I will share some data about regarding the MGene. MGene is the early and non-invasive detection of the genetic condition. It is like a smart or application download in the smart phone and take a picture for the newborn baby, and it will measure the distance and angles of the face of the baby to tell us this is dysmorphic or non-dysmorphic. The other project, I'm not talking about this project, is TestAid. Just a brief, I will tell you what is TestAid. TestAid, same, it's like application download in the smart phone and connect with this stethoscope and will tell you for the cardiac examination, this is a murmur, is a nonsense murmur or pathological murmur. So the data, initially we work in the newborn period, just a baby fresh delivered, but now we extend even with the more big children. But today I'm just going to share with you the data for a newborn only. So from 2015 to 2017, we collected around 1,059 babies. Now we collect more than this. Okay. From Al Qasimi Hospital, around 630 newborn, and Fujairah, 429 baby. You know, the facial what landmarks affected by gender, affected by the gestational age, the ethnic group, all of these can affect the facial. So the gender distribution among the data collected, mostly male and female, mostly same. And Al-Qasimi may be male, more predominant than a female. In Fujairah, female more. And the ethnic distribution. Also, we have to feed the application about the original of the mother and the father, because all of this can affect the face. Okay, from most of the patients from the Middle East, and in Al-Qasimi, because Qasimi Hospital near Dubai and Sharjah, and there is a multinationality. Not like Fujairah. Fujairah, usually the Emirati baby there. But that's the Fujairah, the Middle Eastern or Emirati baby is more in Fujairah Hospital rather than Al-Qasimi Hospital. So gestational age, because also preterm baby, the face is not like the term baby. Initially, we are focused on the term baby. In Al-Qasimi Hospital, we collected data, mostly the gestational age around 38 plus, plus 1, and then Fujairah, almost the same, 37.2 plus minus 2. Now also with the preterm baby, we are collecting also picture for a preterm baby, but the idea, we don't want any tubes. So maybe we have a less preterm baby, because the preterm baby, they have a lot of the tubes here, and the tube will interrupt the picture. So we cannot take what picture with a tube here and here. If we just compare our data with the Dubai data, this data actually collected in 2015 in Dubai. If you just see our data, mostly same, male and female, mostly same. For the ethnic group, because Dubai, there's multinationality, so usually non-Emirati is more than the Emirati in Dubai. And this is the ethnic distribution from the fact book by CIA. This is 2015. Mostly Emirati population around 11.6%, and 59%. This is from South Asia, 38 from India, here Bangladesh 9.5, Pakistan 9.4, other 2.3, Egyptian same, mostly same like us, 10.2. The population in the Emirate, okay, and 6.1 Filipino, and the other 12. Okay, here also from the fact book, 85% of population in Dubai, 85% of population in the United Emirates is found in Dubai, Sharjah, and Abu Dhabi. And physician density around 1.56 physician per 1,000 population. Sex ratio, almost the same, 1.05 male to female. But unfortunately, infant mortality rate around 10.3 deaths per 1,000 live pairs. This, I found this diagram from one article published in 2010. I know it's quite old. Okay, shows what neonatal death, the code of the neonatal death. But here, if you just see the highest one, it's belong to the United Arab Emirates. So really, the neonatal, congenital abnormalities lead to the neonatal death here in the UAE. Congenital abnormality usually associated with the genetic patient. So really, we have to take action, because most of our neonatal deaths related to the congenital abnormalities. Here, the other causes, the United Arab Emirates is the lowest one. So we have really to work hardly in the syndromic patient or genetic patient. Okay. So here, congenital disorder in the Arab world, 65 affected children per 1,000 live birth. In Europe, North America, Australian around 52, less than us, among 1,000. And here, more than 270 genetic disease in UAE. Now, I think with the more advanced genetic study, we have more than this. And 60% autosomal recessive. So this morphology is a study of the human malformation. Okay, and it is to say this is dysmorphic or not dysmorphic, it is a subjective assessment. So really we need some tool to help us to tell us really this syndromic or non-syndromic, dysmorphic or not dysmorphic. I don't want 100% the tool, but at least near. But you know, in the round, everybody will say this is dysmorphic, this is not dysmorphic. We need the technology really to help us in this issue. So official biometrical are critical. So now from research to the clinic. So this is our MGENA project. Okay, MGENA, it is a non-invasive application that will provide a virtual genetist at the bedside, screen patient, detect facial dysmorphology, and allow remote care. So what's the aim of the MGEN? Detect a wide range of genetic disorder, what we hope, and reduce a morbidity, mortality, reduce a cost and time for a genetic testing, provide a virtual genetist at the bedside. So before the machine to tell us this patient syndromic or non-syndromic, we have to feed the application about the normal patient, how is our faces looks like before to say this is dysmorphic. Here initially we collected many data, normal baby, okay, and we feed this application to calculate the distance, the angle, to know what the normal, what the abnormal. Okay, the age range between 4 to 7 days, and as I mentioned, we measured a set of the distance and the angle between the facial landmarks and the eye, nose, mouth on all pictures. Okay, this is a real baby newborn. Of course, when we are taking a picture for this newborn, we are taking consent also. And here what we are, the application going to measure the distance, okay, and also the degree, this horizontal baseline and also a vertical baseline. Here the palpebral slanting this is a normal baby to see what the degree between the inner cans and the inner and outer cans, and this distance between the the inner cans of the both eyes. This is our the normal for us for Emirati. Here mostly the picture for Emirati babies. Okay. Here also the palpebral fissure to see how much. Okay, this around 27% plus minus 3% of the face. And here the vertical, the opening of the eyes, how much? It is around 9.3% of the plus minus 3% of the face. Here also the mouth and the nose length. So if you feed the application about the normal faces, at that time we can't say the abnormal regarding to the based on the normal landmarks. So as we mentioned, we hope or we wish this technology can help us really to take the wide range of the genetic disorder, reduce the morbidity and mortality, and reduce the cost and time for genetic testing, and provide a visual genetist at the bedside. So, conclusion, collection of the pairs population information in the North Emirates. This initially, we started Qasimi, then Fujairah, and we shifted to Ras Al Khaimah. And essential to provide the vital statistic data for national youth and to compare this data with the other region, like a GCC. And we need this data really to support the newborn screening and the healthy baby program for early detection. As early detection can improve the patient outcome. So we hope the digital technology can help us more. Inshallah, next presentation, we are going to tell you the result of the MGN. It's still under study.
Thank you very much, Dr. Rotlat, about interesting and comprehensive topic. And I think this is need more study.
Yes,
Yeah.
still, we are collecting more data and more data, but unfortunately in 2020, our data become less and less.
But it cannot complete it by the chromosomal study or genetic analysis?
No, the idea is like a neonatal screening. Okay,
Yeah.
it will not tell us exactly what's the syndromic this patient.
Yeah.
Okay, but who patient we are going to take him to send him to the genetist rather than to send him to the home.
I see.
Okay, so we want early detection. And as I mentioned, we will not share syndromic patient to non-syndromic patient, but at least early detection, early intervention can improve the lifespan for him. Yeah.
Thank you very much.
Now, allow for a few questions.
Yeah.
Because very, yeah, Victor?
See, what I mentioned, this project is still under study, but application, it will be used only for a doctor. Right now we are doing the project in Qasimi, Fujairah, and Abdullah bin Imran. Also in Al-Baraha Hospital, but now Al-Baraha Hospital mainly for a COVID patient. But it is still under study. It's not approved to be sure. We will discuss with the minister about this issue, Ajman. Yeah, we want to extend to the whole North Emirate, like not only Ajman, Al-Qawain, Kalbakhar, Fakkan. There is many hospitals in the Ministry of the Health. Yeah.
Okay, Dr. Azzat.
Very interesting, and I think very beneficial in the future of our babies. Early detection is very important, and known the best implementation. Just my question here, you mentioned about here the nationalities. You see Far East, for example, Philippine and Korean and African and Arabs, Middle East. So what you do for this? And here you took the measure, you use your measure as ideal, right? And to compare about, you are giving the program your measure.
This is the application what assigned by Sheikh Zayed Institute in Washington. What we are doing, we are collecting the data, we are taking a picture, okay, and automatically by the application going to measure this distance, okay, and according to the nationality, because we there is a certain question, we have to fill this question, like the ethnic group of the mother, ethnic group of the father, and the gestational age, the birth of the date, all of this we have to feed the application. Then he will calculate the distance and measure. Then it will send it to the Sheikh Zayed Institute, the all information. But still, and I don't have really too much information about how we are how we are reading this one. It's just like the application. Yes. Emirati, the Middle East, okay. And if it is South Africa or North Africa, different from the Africa. Okay, and even from the South Asia, different from the Asian, South Asian. But we have to really mention about this, the ethnic group, because it will affect the landmark of the face. But right now, what we are collecting, we are seeing the normative. Still, we are collecting more normative landmark for Middle East and for what Emirati we collected. It's enough data, but also we need more for the other nationality.
Okay, Dr. Sharif.
Friction? Infection. Okay. From 26 weeks, we have done it with some babies. Okay. We have done it with babies who are on full ventilation and babies who are on nasopharyngeal. Infection rate since we started this, because all the parents of the premature babies, once they come to the NICU, there is a dedicated nursing staff for the infection control, or we call it the link nurse with the infection control committee in the hospital, who teach the parents on all aspects of infection, washing the hands, taking care of self-hygiene. No mobiles is allowed in the unit inside, although sometimes we see some people, they use it, immediately somebody will come and tell them, please put it aside. At certain stage, we even prevented them from entering their bags. Since we implemented more than 10 years, we did not see any increase in the rate of infection. Actually, when they are on mother milk, it is per se antibiotics. Relatively, and with the proper care. Yeah.
Any more questions?
Yeah. In the beginning of COVID, we said nobody is allowed for entering the unit except the mother. She can come and see her baby because she's already in the hospital and tested. Otherwise, even if the father is there and he's not tested, he was not allowed to enter. Later on, after 3 or 4 months, we started releasing the banning, but there is strict control until now from the beginning on all aspects of infection. And of course, when you in advance teach these parents, last time one father, he called from home that my relative is having COVID and I was with him, so I'm not going to come. And we instructed him what to do for everything. But milk can be given. I mean, the milk of the mother, even if she's COVID positive, the baby can take the milk. Yeah. Yeah, provided she has to put the mask, proper hygiene.
Thank you very much, all our speakers, about the very nice session. And now we have, we're closing these sessions now for 1 hour. For 1 hour, we'll go to the break and lunch. Thank you very much.
All right. We shall begin the seventh session this afternoon. For the moderators, can we call Dr. Muhammad Abu Zaid and Dr. Mesaf is here.
Good afternoon, everybody.
Welcome back to our afternoon session. I hope everybody had a nice lunch, heavy lunch, so you can have time to listen properly to our speakers. Thank you very much for Dr. Sharif for invite me to be with you. We will start our session by Professor Muhammad Magdadi. First of all, we will congratulations, Professor. He achieved a professor position recently in the Khalifa College, Abu Dhabi. He's American Board of Pediatric Gastroenterology, Hepatology, and Nutrition. He's a Chief Medical Pediatric General Gastroenterology and Hepatology and Nutrition Division in Sheikh Khalifa Medical City, Abu Dhabi, UAE. And as I mentioned, that he achieved a professor position recently. He is going to tell us about short bowel syndrome, the long and short of it. Please welcome with me Dr. Magdadi, Professor Magdadi, sorry.
Shukran. Thank you, Dr. Mus'ab, for this nice introduction. Can you all hear me well? All right. I have the pleasure today to talking to you about this important subject, which fits very well in the morning talks about neonatology and taking care of in units. All right. Over the coming 20 minutes, I will talk about the background. We will talk about the pathophysiology, and we'll touch on the important points about the management of short bowel syndrome. I wanted to share our experience at Sheikh Khalifa Medical City, but I was told my talk will be 20 minutes instead of 30 minutes, so I'm going to delete that part. A quick background. What is a short bowel syndrome? Actually, the definition of a short bowel syndrome is a malabsorptive disorder that's caused by the surgical removal of a significant part of the small intestine. So it's a malabsorptive disorder. Yeah, actually, this disorder is this definition rather is a functional definition because it entitles that there will be malabsorption of the macro as well as the micronutrients there. The short bowel syndrome can be a congenital disease or an acquired, and obviously the acquired is more likely or much more common than the congenital one. There is a lot of details about the definition, but in general, what people agree that you have to lose probably more than half or 2/3 of your small intestine to start having the manifestations of what's called a short bowel syndrome. The short bowel syndrome definition is a surgical definition. Recently, it has been replaced by a better definition, which is called the intestinal failure. Intestinal failure equivalent to short bowel as well as the malabsorptive definition of the short bowel syndrome. So most of the literature today talks about an intestinal failure, whether you have removed part of it surgically or you were born with a malabsorptive disease like microvillus disease, microvillus inclusion disease, or other enteropathies, congenital diarrheas, and others. So you might have all your intestine there, but if it's not functional, then you will call it an intestinal failure disease. The commonest causes of intestinal failure in 2020 is probably necrotizing enterocolitis is probably the commonest. In our region, we still see a lot of patients with congenital villus disorders. At SKMC, we cared for probably 5 or 6 microvillus inclusion disease. We have a couple of tufting disease, and also we have other few with congenital villus disorders. Congenital anomalies, typically what we see who are newborns who might develop volvulus or born with a big omphalocele, and the intestine unfortunately get necrotic and had to be removed. In older patients, you might see it in patients with inflammatory bowel disease who might undergo surgery, an extensive surgery for a big part of their small intestine. And we have one patient that was secondary to trauma. Obviously, it has to be a massive trauma to make you lose your intestine. All right. The symptoms and the management actually of an intestinal failure depends on what's the remaining part. So our surgeons, and I'm sure your surgeons, they will tell you, I removed this, I removed that. I tell him, no, I don't care what did you remove. My question to you, what did you leave in for me so I can work at it? So that's the most important thing. How much intestine did you leave for me? Did you leave the ileocecal valve in place? And did you leave part of the colon? That's my questions to the surgeon. So it's not what you removed, it's actually what you left in there for the patient for me to work at. In the right context of the patient, you're a patient with surgical or functional intestinal failure, most of the patients that will have different constellation of symptoms and signs. The commonest of which is diarrhea, and sometimes steatorrhea if you are malabsorbing the fat. A typical manifestation would be a failure to thrive or poor weight gain, and it might be combined with fluid or different kind of electrolyte losses. Abdominal pain and distension can happen there. So the obvious symptoms are the diarrhea and the failure to thrive with fluid and electrolyte imbalances. Sometimes we might have a specific more symptoms, i.e. if the fat malabsorption is affected, you might get the adic enzyme malabsorption. If you have lost part of the terminal ileum, you might have malabsorption of the bile acids or the B12, for example, and others. It depends which part of the small intestine was affected. Moving on to talk about the pathophysiology of the intestinal failure. The small intestine, as you all remember, is the duodenum, the jejunum, and the ileum. Most of the times, the duodenum probably is still there. It's rarely to be affected by NAC. So the jejunum or the ileum. The jejunum, if you want to remember it in a short sentence, jejunum is responsible for nutrients absorption. So most of the nutrients are absorbed in the jejunum. It has a lot of the enzymes there. It has a huge surface area there, and it has a lot of the transport carrier proteins that's important to absorb many of the nutrients. So jejunum means nutrient absorption by far. The jejunum is a leaky organ, i.e. you might lose a lot of fluids in the jejunum. So if you have a patient who only have the jejunum there, be prepared that this patient might lose a lot of fluids there because the jejunum is a leaky organ. If the jejunum is functioning, it will absorb a lot of the water and the electrolytes as well there. The adaptation on the jejunum is unfortunately limited. It can adapt by the function only, while the ileum can adapt by the function as well as by the structure, i.e. the ileum can grow in length and in diameter to absorb, while the jejunum is mostly functional adaptation. The ileum, which has a shorter villi, it has a much smaller surface area than the jejunum there. Most of the fluid that have been lost in the jejunum will be absorbed in the ileum, and part of the fluids will be absorbed in the colon later on. So ileum is mostly fluids, while jejunum is mostly nutritional or nutrients absorption. So if the patient have lost the ileum, please be prepared for more fluid problems. However, the ileum is responsible for absorption of certain nutrients, as you all know, B12 and the bile acids there. Bile acids are mostly absorbed, again, in the terminal ileum. If the terminal ileum is resected, the bile acids will not be absorbed there, so they will go to the colon. The bile acids, they work like a detergent, so they cause diarrhea, and it's known like a bile acid or biliary diarrhea there. So because it's very irritant to the colon. How much of the ileum do you need? From the adult literature estimated, if you lose more than 60 centimeters of the ileum, you will have a B12 deficiency. If you lose more than 100 centimeters, you might end up having bile acid deficiencies and fat malabsorption there. The exact definition in pediatrics is different. But the good news about pediatrics, children, they can adapt better than adults, and their small intestine can grow structurally and functionally better than in adults. All right. Ileocecal valve. Ileocecal valve is super extra important because it's the major barrier that slows down the movement from the small intestine to the large intestine there. If the ileocecal valve is not there, all these contents will go down fast without holding them, and that might result in a lot of the fluid and nutrients being rushed down to the colon and losing the chance to be absorbed in the terminal ileum. It's estimated that if an infant has less than 30 centimeters of the small intestine and loss of the ileocecal valve, this patient is probably will be on TPN for the rest of their lives. I call the ileocecal valve يسوى تقله ذهب because it's really, really important to keep the ileocecal valve. And our surgeons, they try their best not to lose the ileocecal valve because really it's an important predictive factor if you're going to be off TPN or you're going to be on TPN for the rest of your life. The colon, of course, it's not part of the small intestine. It's mostly responsible for the absorption of fluids and electrolytes and short-chain fatty acids. It's less likely to absorb any of the nutrients there. However, having a colon is, if you have at least half of your colon equals about half a meter of the small intestine. So the colon is still important, but not as important as the small intestine. If the patient still have colon, this is very good news. He might be off TPN more than a patient who have lost his colon. All right. When I see a patient coming from the neonatal unit, the first thing the parents will ask, will he be requiring TPN for the rest of his life, or are we able to wean him off TPN someday in his life? What are the bad prognostic factors? The first one, if you have a very short bowel, if you have less than 15 centimeters, this patient is unlikely to be off TPN. Unfortunately, at SKMC, we are caring for several of these patients who have a lifelong TPN. If the ileocecal valve is lost, that's a bad prognostic factor. If you have a major resection of the colon, if you have lost more than half of your colon, then probably that's a bad prognostic factor. We try our best to always have primary reanastomosis. When they have the surgery for neck or for volvulus or for other kind of surgical disorder, if they can reconnect it primarily at the time of the first resection, that will give us better chance of adaptation, and hopefully the patient will be off TPN. If there was an ileostomy involved and it took several months before they reconnected, that makes it less likely to be off TPN later on. The adaptation of the small intestine depends on the nutrients to be given to the patient intraluminally. If you don't feed your patient, he will never adapt. Because when you feed the patient intrally through the mouth or nasogastric or gastrostomy tube or others, you are stimulating many of the mediators and many of the growth factors that are essential for the small intestine to adapt. Adaptation happens the most early after resection. So the earlier you intervene with these patients, the much better outcome to expect. All right. In the management part, enteral nutrition is the best thing to give the infant the chance for his jejunum or ileum or whatever is left to adapt. Dr. Haliq and many of the other speakers talk in the morning about the importance of early feeding and early nutrition, as early as possible, even if it's small amount. Even if you are giving 1 ml of, for example, breast milk or an amino acid formula, even if you are giving 1 ml every 1 hour or every 2 hours, is much better than 0. This enteral nutrition is the only way to induce adaptation. If you don't feed the patient, they will never develop the adaptation. We talked about the function, the hormonal. Also, you're going to start moving the biliary secretions as well as the pancreatic secretions there. even in the shortest of the short bowel. Sometimes we get patients who have 2, 3, 5, 10 centimeters. Even in these patients, please stimulate enteral nutrition. Even with the tiniest amount, you have to start that. Otherwise, they will never adapt. Okay, we mentioned that. I wish we have more time to talk about how to do the enteral nutrition, how to stimulate it, but at least please remember these 3 principles. Start early. The earlier, the better if the patient is stable. Start slowly, even with a small amount, and build on it. The best enteral nutrition to offer your patient is probably the breast milk if it's available. If the breast milk is not available, you might consider using an amino acid formula. If that's not available or not desirable, you might use an extensively hydrolyzed formula, because these patients are probably at higher risk of protein allergy. So if you give them breast milk or amino acid formula, probably they are at less risk of developing the allergy. Please remember, these patients, their surface area have been reduced by the surgical or medical disease. So you want to use their intestine as much as possible. And one of the ways to get around this, to give them continuous feed versus bolus feeds, because if you are giving them continuous, you are allowing to use their enzymes and their absorptive capabilities 24 hours, and that will give them the best amount of the best adaptation they might get. I will talk briefly about the proteins, the fat, and the carbohydrate, just mentioning the important principles. We talked about the protein advantages. When it comes to using the fat, it's highly suggested to give them a formula with high MCT, medium chain triglycerides, for the simple fact that MCTs are absorbed directly from the lumen to the enterocytes, and they go to the bloodstream. So there's no need for any intermediates. While if you are giving a patient an LCT, long chain triglycerides, to absorb an LCT, you will require bile from the liver, you will require the lipase from the pancreas, and you will need your lymphatic system. So MCT are easier absorbed in these patients, and probably they are desirable to give in there. However, keep in mind that essential fatty acids are all LCTs, so you give them a formula rich with MCT, but not a formula 100% MCT. So a formula with high MCT, but not a formula with only MCT. The carbohydrate, it depends which part of the small intestine was resected. As we all know, carbohydrates are mostly absorbed in the jejunum. Most of these patients, they still have enough lactose in their body. However, most of these formulas, the amino acid formulas and other modified formulas, they are lactose free, but that's probably not necessarily needed. Again, at the beginning, give them continuous enteral feeds. Later on, you might change it to bolus once the infant grows a little bit better. If you can give it orally, that will be fantastic. If orally it's not gonna work for whatever reasons, then you might use a nasogastric tube. That's your second best. If the nasogastric tube does not work for whatever reason, you might end up using a nasojejunal tube. And I think it's available in most of the hospitals where you practice. It's just the same like an NG tube with a couple of differences. There is a weight at the tip of the tube, so it will help the tube to migrate from the stomach to the duodenum to the jejunum. You can place it at the bed site, and the advantage of the nasojejunal tube, because it's made of polyurethane, you can keep it in a place for 4 to 6 weeks, while the nasogastric tube, you have to change it every week. Later on, you might consider using a gastrostomy tube or a jejunostomy tube or a gastrojejunostomy tube if the patient having some feeding intolerance there. All right, can skip this one. Medications, there are several medications available that you can use to aid in the management of intestinal failure. H2 blockers and proton pump inhibitors, they can be helpful because they decrease the fluid secretions through the gastrointestinal tract. However, they might increase your risk of having infections, and there is probably some long-term problems with the magnesium metabolism and kidney injuries. Antibiotics, we end up giving many of these patients antibiotics because they are at risk of developing small bowel bacterial overgrowth because they have areas of narrowing in the small intestine. If you want to use an antibiotic, please use a broad spectrum antibiotic, a narrow spectrum antibiotic that's non-absorbable. Many of you, they use metronidazole. Some people use neomycin. You can use the newer one, the rifaximin. It's a non-absorbable antibiotic. It has minimal long-term side effects. Most of the authorities, they suggest to use it in a cyclical fashion, i.e. you give it for a couple of weeks, then you give the patient a break for 2 weeks, and then so on and so forth. You can do it shorter or longer duration if you like. Prokinetics, they have a bad press, and nobody likes prokinetics for long term. Please notice that I added amoxiclavonic acid as a prokinetic. Amoxiclavonic acid, the augmentin that you all know, it enhances the jejunal motility, and many of these patients, they respond very well to this treatment. Some of the centers with any patient with nasojejunal or gastrojejunal feeding, they give them augmentin on a regular basis to enhance the motility of the small intestine. Octreotide, you might use it if you have a lot of fluid losses. Cholestyramine, it's available in UAE. I think it's the best to be used in patients who have lost significant part of the terminal ileum and the ileocecal valve. It absorbs the bile and prevents diarrhea there. It's available in many of the hospital pharmacies and is not expensive at all. Iron, please keep in mind that all the TPN preparations in UAE, they don't have iron. So if you don't give your patient parenteral iron, they will develop iron deficiency anemia. In a patient with a long-term TPN, we schedule them regularly to receive iron IV every 2 to 3 months. Others, I think our colleague Lamia spoke in the morning about the different fat preparations. There is a preparation called SMOF, SMOF. SMOF stands for soy, MCT, olive, and fish oil. SMOF is a lipid preparation that has less injury to the liver in patients who are going to use TPN for long term. SMOF pricing is reasonable, so it's one of the things to consider it in long-term TPN. Soy, MCT, olive oil, and fish oil. Growth factors, they don't work. Probiotics, less likely to work. Small intestinal transplant is one of the options if everything fails. At SKMC, currently we have 4 patients with a small bowel transplant with variable outcomes. So, Mr. Chairman, I'd like to conclude by saying short bowel syndrome is a malabsorptive disorder, and actually we should call it intestinal failure. That's a more comprehensive definition. I asked the surgeon 3 questions. What small intestine did you leave for me? Did you leave the ileocecal valve for me? And did you leave part of the colon for me? If there is good small bowel and good ileocecal valve and at least half of the colon, this patient has a good outcome. The ileum can adapt better because of the function and the structure. Thank you very much. Oh, we talked about the intranutrition and the use of the breast milk there as the best adaptive nutrient and to be used as early as possible. Thank you very much.
Thank you, Professor Muhammad, for this wonderful lecture. Let's welcome our next speaker, Professor George Diaz, and Professor George is the Chief Pediatric Gastroenterology Unit at CNT Hospital, member of the Working Group on Inflammatory Bowel Disease with Spinal, President of the Portuguese College of Pediatric Gastroenterology, Council Editor for Journal of Food and Allergy. For inflammatory bowel disease.
Mr. Chairman, dear colleagues, thank you very much for this prestigious and kind invitation. It is really a pleasure to feel that we may get a little bit of our normal life back. Hope this continues. Well, over the next few minutes, I will tell you a few things about inflammatory bowel disease, no conflicts of interest, and overall, probably you have also witnessed an increase in the incidence of pediatric cases of inflammatory bowel disease. This has been occurring everywhere in the world, and it is most notable with Crohn's disease as opposed to ulcerative colitis, where incidence has been a little more stable. It is interesting, and some studies, this one was done in Canada, looked at immigrants coming to Canada from various parts of the world. And if you see here from Middle East and North Africa, the overall incidence of those immigrants is highlighted, I'm trying to point, is highlighted up there in green, but their offspring, their children, have a much higher incidence, as you can see, as you can see here. Then, if we move to Crohn's disease, again, this is the incidence of the original immigrants, and this is their children. And if you look at ulcerative colitis, the immigrants and their children, so the local circumstance, the local environment influences very much the incidence of inflammatory bowel disease despite a common genetic background. And this is clearly important to try to understand the mechanisms behind the emergence of inflammatory bowel disease. And we know nowadays that there is an interaction between the microbiota in the gut, the barrier of the mucosa, and the immune system. And when this delicate balance is broken, then we have inflammation and activation of inflammatory mediators that cause a chronic inflammation. In early age, genetic background plays a major part, so the very early onset forms of IBD usually have some genetic strong component. But with increasing age, the environment factors play a major role, and there it is up to the environment to determine how often this disease occurs. Well, you may have heard of the Porto Group, the IBD working group of ESPGHAN. Years ago, we have proposed an algorithm for the diagnosis of IBD. And I'm not going to tell in detail the whole pattern or the whole steps of this diagnosis, but would like to highlight two things. Ileocolonoscopy and upper GI endoscopy are essential for the diagnosis, to pick up biopsies, to document the exact nature of the process. So we always recommend to do colonoscopy with ileoscopy and upper endoscopy, both for Crohn's and for ulcerative colitis. Then we recommend imaging of the small bowel. This is mandatory in case of Crohn's or indeterminate colitis, not formally recommended for in case of ulcerative colitis. So when you have a patient with a diagnosed IBD, please confirm diagnosis with this full workup, evaluate the extension of the disease, are there any extraintestinal signs or symptoms, assess the activity of the disease, check for immunization. Keep in mind that quite often we need to use drugs that somehow affect the immune system. Therefore, we want our patients to be protected against occasional infections and exclude relevant infections like tuberculosis that in some cases may give a pattern, a clinical pattern, which is similar to Crohn's disease, but needs a completely different treatment. So excluding tuberculosis is always very important. Well, for the small bowel imaging, we may use various techniques. Video capsule enteroscopy is very attractive. We can see fantastic images of ulcers, but this may not be always available. It takes time, it is expensive, and it takes time to make the report. So quite often we use magnetic resonance enterography. This has some advantages over the mere endoscopy or the capsule because it has a transsectional technique, and we can see clearly the thickness of the mucosa. We can see the vascularization. So even if there is a stenosis, if there is increased vascular pattern, we may consider that this might be inflammatory stenosis, therefore amenable to medical treatment. But if there is no increased vascularization, it might just be fibrosis and at some point might require surgery. For perianal disease, we formally recommend the use of magnetic resonance to assess the type of fistulas and the existence or not of abscesses. There are some factors that are very specific to pediatric Crohn's disease as opposed to adult Crohn's disease. We have affection of growth, so quite often patients have growth impairment, and this may be even worsened by the use of certain types of medication. As you know, there is abdominal pain. Most of our patients start by having an inflammatory pattern, while many of the adults, when they are diagnosed, they already have some type of fibrosis. Frequently, there is a family history of IBD, although not necessarily the same diagnosis, meaning that there may be someone with a relative with ulcerative colitis and yet develop Crohn's or the reverse. And clearly, genetic factors are more frequent than in adult patients. I mentioned to you to assess the extension of the disease, there is a Paris classification, which is a specific pediatric type of classification. This is based on the Montreal classification that is used for adults. There are a few differences. One of them is that within the small intestine form of the disease, we distinguish whether it is above or below the angle of Treitz. But there is something else. In Montreal classification, there is a separate group less than 17 years. Of course, all pediatric patients have less than 17 years, so we divide them up to 10 years at onset or above 10 years of age, and growth, which is specific to pediatric patients, and this is really important for us. Some clinical challenges in patients with Crohn's disease is that we need to protect growth. Therefore, we try to avoid medications that compromise growth, this meaning to avoid steroids as much as we can. We want to improve the prognosis by promoting the remission of the inflammatory state. And of course, these are mostly adolescents that have expectations, and we have to match their expectations, and we have to discuss the options in therapy with them and their parents. Crohn's disease may have this natural course. And of course, when we get up here, we are looking at irreversible damage that quite often ends in surgery. So we want to control the disease and bring it under control with early, efficient intervention. And this is very important for pediatric patients. So when we diagnose a patient, we need to stratify the risk. This is a part of the recent guidelines published by the Porto Group, and this has been published in the Journal of Crohn's and Colitis. And if we have a low-risk patient, we may start with more conservative treatment and expect that we may bring disease under control. But in some cases, there may be a medium risk, namely if there is already some sort of growth delay, or if there is extensive disease, perianal disease, deep ulcers, strictures, or fistulas. These are high-risk patients, and we need to be far more aggressive in the initial approach. Well, this is the algorithm that is recommended in the guidelines. This is too busy to get into detail, but just to mention that it leads you to select low-risk patients and you take this branch. If it is a high-risk patient, you take the other approach. In general, the best option for the initial treatment of Crohn's disease is nutrition. Enteral, exclusive enteral nutrition. We use polymeric formulas. This has been documented many times to be the best option for luminal disease, regardless of the location. It is not efficient in perianal disease, but in any other form, it is clearly the best option. We use a polymeric diet with whole protein, and this promotes mucosal healing. Of course, we can use steroids. We know that steroids control inflammation. They are a possible alternative. They are less expensive in the short term. They have well-known side effects. Prednisone may be used. Budesonide is also steroid with topical action, may be an option for mild ileocecal or ascending colon disease. Enemas may be used for distal disease, but steroids must not be used for maintenance. They can be used for induction of active disease, but not for maintenance. We get symptomatic relief, we have improvement of the biochemistry, but we do not heal the mucosa by using steroids. There are several meta-analyses comparing enteral nutrition with steroids. Efficiency is similar, but when we look at the growth, when we look at the growth, at patients with enteral nutrition or steroids, we see that after a while, growth is much more compromised in patients that receive steroids. Therefore, this is clearly not the best option. If we prescribe enteral nutrition, there is no advantage of elemental formulas, and the taste is much worse with elemental formulas, and they are more expensive. We always recommend oral route, but in some cases, a nasogastric tube may be used. Our colleagues in Rotterdam, in Netherlands, when they do the endoscopy, they put in the tube and they start enteral nutrition. If the patient takes it orally, they just take the tube away. If not, the tube is already in place and can be used. I'm sorry. We use a composition with 1 to 1.5 kilocalories per meal. This does not create a huge overload of osmolality. We try to match the preference in taste. We do it exclusively for 6 to 8 weeks and then taper over 2 weeks. I tell patients that they can drink it 5 bottles in a row. They can take 1 bottle every 10 minutes. They can take 2 bottles every 4 hours. They can do whatever they want. They can mix various flavors, do it cold or hot, doesn't matter. But they have to do it exclusively, and I discuss with them the amount they need to take every day. I usually admit the patients for 24 hours so that they are starting the enteral nutrition in the hospital, which is an environment that we can control. Because if I tell a patient, well, this is not very tasty, you know, this is a bit of a pain, well, I'm already telling the patient not to do it. So we have to be very persuasive, we have to be strong, and we need to have the family on our side. Because if the family is crying and say, my poor little boy, poor guy, then it's difficult for them to comply. We allow them to drink water or chew gums, but clearly motivation is the most important issue. Well, nowadays we know that diet, and I mentioned the environmental factors, and diet is very important both for the proper mechanism of immunity, but also for a steady microbiota. Yesterday, we had excellent lectures about microbiota, and clearly diet is in the roots of our intestine and our immune system. Therefore, it is not surprising that there has been a trend to have specific diets to treat inflammatory bowel disease. Still, this is not a formal recommendation, but please be informed that in the near future, you will certainly hear more and more about IBD diet or Crohn's diet or even ulcerative colitis diet. The removal of some type of nutrients like emulsifiers or the heavy load of animal proteins may decrease the inflammation in the gut and therefore may be some form of helping to treat these patients. Well, maintenance, when we stop the enteral nutrition, we need to have some form of maintenance treatment. And usually we use thiopurines. This is a bit questionable. Our colleagues in America don't use so much thiopurines. They go for biologics much faster than we do in Europe. But still, thiopurines are quite relevant forms of treatment. However, they need some control. We need to check blood count regularly because they may induce neutropenia. We need to stop if there are signs of pancreatitis, and we should not restart. If possible, we can assay the enzyme that helps metabolize thiopurines to identify the patients who may be at a higher risk of toxicity. However, even if we do this, we still have to monitor patients. This will only tell us that this is a patient with a higher risk, but it does not exclude the risk in every other patient. So if you do it, okay, you have an evaluation, but always do a blood checkup every 3 months. The effect of treatment takes up to 3 months from start. So usually we start thiopurines at the same time as the enteral exclusive nutrition, because by the time we stop the nutrition, then the drug is reaching therapeutic effect. And we do this, of course, we must, and in this country this is even more relevant, we must warn patients against skin cancers, so they should take additional sun protection measures. And there are other drugs, biologics, and the complex mechanism that triggers inflammatory bowel disease allows to define and try to get specific antibodies for every step of the disease. And currently, we make a huge use of biologic drugs to treat patients with IBD. But as mentioned before, please, before you start any biologic, check the infectious risk of your patients. Infliximab is the most common used drug for IBD. We know that in pediatric patients, levels tend to be lower than in adults. Therefore, measuring the trough levels is useful to adjust the dose. Because if we are giving a drug that is expensive and we allow the patients to have very low blood levels, not only we are wasting money, we are immunizing the patient and allowing to get antibodies against the drug and loss of effect, and we are wasting our money and time. So if possible, check for blood levels. And the guidelines recently published that I mentioned, they propose time points to assess the blood levels so that we adjust the drug according to the levels. Because if it is too high, then we are wasting part of the drug. If it is too low, we need to adjust the dose or the intervals.
5 minutes, please.
Okay, I'm trying. I ask for your authorization to carry on for a few minutes more. Well, top-down strategy means to start from biologics from diagnosis. Still, we're not there. We still don't recommend it for every patient. However, we advocate quick step up. If patients don't get better soon, we need to step up quickly to biologics, and this certainly influences the prognosis and growth. So if there are these signs, which are the signs that I mentioned to you that are high-risk signs, we can either start immediately with biologics upon diagnosis or wait for a short time with enteral nutrition and then move on to biologics if patients are not responding well. In refractory disease, elective surgery may be used, and if we do surgery for short resections, then we need to assess whether patients have high or low risk. And if they have high risk, they should go back to biologics immediately. And we need to do colonoscopy sometime later on to assess if there is any sign of relapse of the disease. Briefly, I would like to tell you also about ulcerative colitis. Again, it must be well confirmed. Monitoring is important. We don't need endoscopy so much as we do in Crohn's disease because we have clinical indexes that allow us to monitor the degree of inflammation. We also use the Paris classification, which is again a modification of the Montreal classification. The differences of this pediatric classification is whether there was ever a severe episode or if there is pancolitis, which is far more common than in adult patients. This is PUCAI, the index activity index score that we use to assess how the inflammation is, and this is much more reliable than the activity indexes that we use in Crohn's. So we don't need to do endoscopy so often. In these patients, we start with 5-ASA if there is mild or moderate disease, but then steroids are an important drug to use. We may use isolated rectal therapy if they have just a proctocolitis. Oral ASA can be combined with rectal ASA. Rectal monotherapy could be used for distal disease, and this is a quite efficient drug in mild disease. Oral steroids, as I mentioned, we use them far more often than we do in Crohn's disease, but again, they are not recommended for maintenance. Some patients develop steroid dependency where every time we try to stop them, they relapse. Therefore, we should step up to biologic therapy. We also use thiopurines, 5-ASA. In some cases, we may use cyclosporine or Tacro for more aggressive disease. If there are no responses within a short time, we need to escalate therapy. This is the algorithm for mild, moderate, or severe disease. As you can see, in severe disease, these patients must be in hospital. They need to mostly start infliximab, sometimes associated with additional drugs. And if they respond, then we can decrease the intensity of treatment for maintenance. Be aware that some patients may have very acute severe colitis, and these patients, this is a medical emergency. All these patients need to be checked in hospital. The surgeon must be informed early because some of these patients need to have colectomy. Always keep in mind that our aim is to save the patient, not merely to save an organ. So these will need intravenous steroids. Always do an abdominal X-ray if the diameter of the transverse colon is more than 55 millimeters, then this may be a sign that the patient is getting into toxic megacolon, and this is really a severe condition, and these patients up to day 5 should be decided to be medically or surgically managed. So the second line of therapy is the biologics, either with cyclosporine or Tacro in some cases. Ulcerative colitis, we need to do recurrent endoscopies for the risk of colon cancer. This may be done in the adult clinics because our colleagues, our adult gastroenterologists, have more experience in screening for cancer. And this is a very recent paper. We have more and more biologic drugs, and now we start to talk about combining these drugs. So this is an ongoing field. We hear more and more about these new alternatives. So in conclusion, we need to provide nutritional support to our patients, psychosocial support, monitor the quality of life, growth, and please take in good consideration the need to make a proper transition of these patients to adult services. Well, Thank you so much. Apologize for going over my time.
Thank you very much for really informative lecture. We will keep the question after the finishing the lectures. Now, it's my honor to present our next speaker, Professor Van Vandenplas. He is the head of the Department of Pediatric at the University Hospital Brussels, Belgium. He has his PhD thesis was on esophageal pH monitoring for gastroesophageal reflux in infant and children, and he has more than 350 publications listed in Medline. His interesting are gastroesophageal reflux, diagnostic procedures, treatment, esophageal esophagitis, infant nutrition, and probiotics. So he is going to talk today about diagnosis and management of non-IgE mediated cow milk protein allergy, except eosinophilic esophagitis and FPIEs. Thank you. Welcome, Professor. Where is he? Our Professor Vandenplas.
I'm Dr. Vandenplas.
It's recorded already, so it will come now.
Following topic: diagnosis and management of non-IgE mediated cosmic protein allergy. This is the layout of my presentation, and we'll start with the introduction by stating that, of course, breastfeeding is the best way to feed all infants, and that mother's milk is an unequaled way of providing ideal food for the healthy growth and development of infants. But not every infant can be breastfed, and so cow's milk-based infant formula is the second choice infant feeding for our infants. Infants can react to this foreign protein and they can develop adverse reactions, which can be non-immune mediated. But they can, of course, also be immune mediated with IgE mediated reactions and non-IgE mediated reactions. Also cell mediated reactions are possible, and mixed IgE and non-IgE reactions are possible as well. Today, the focus of attention will be on non-IgE mediated reactions to cow's milk protein. What about the epidemiological data? While the incidence of cow's milk protein allergy in exclusively breastfed infants is really low, it's probably less than 0.5%. And according to most of the literature, the incidence of cow's milk protein allergy in formula-fed infants ranges from 2 to 7.5%, with the majority of the data around 3 to 4%. However, there is a huge discrepancy between perception and proven cow's milk protein allergy by a double-blind, placebo-controlled food challenge. The perception of infants not tolerating cow's milk-based infant formula is much higher than the 2 to 3%. What about the natural evolution of cow's milk protein allergy? Well, according to the available data, around half of the infants allergic to cow's milk develop tolerance at the age of 1 year, with almost 90% at the age of 3 years. However, we should not forget that the majority of these data come from tertiary care centers on selected infant population. And it is my personal opinion that up to 90% of the infants are probably tolerant at around the age of 1 year. IgE-mediated cow's milk protein allergy has an increased risk of becoming persistent cow's milk protein allergy, and those infants are also at increased risk to develop allergy to other foods. Interesting data are these data from the EuroPreval study. First of all, showing a very low incidence of cow's milk protein allergy of only 0.5, 0.54% of proven cow's milk protein allergy with challenge. Interesting to notice also was the regional differences. According to different regions in Europe, the incidence of cow's milk protein allergy seems to differ. And about 25%, one infant in 4, had non-IgE mediated cosmic protein allergy. And what about the prognosis? Well, according to these data, 70% of the infants were tolerant to cosmic protein at the age of 1 year, and 100% of the children with non-IgE associated cow's milk allergy were tolerant to cow's milk at the age of 1 year. What about the symptoms? Typical for the symptoms of non-IgE mediated cow's milk allergy is that there is not one typical symptom. Digestive symptoms occur in up to 60%, respiratory symptoms in up to 30%, skin manifestations 70%, and general manifestations in 50% of the infants. That means if you summarize this, that you end up by 200%, which means that the majority of the infants develop symptoms in more than one organ system. So the most common symptoms of non-IgE mediated cow's milk allergy are reflux disease, infantile colic, and changes in stool composition, as well diarrhea as constipation. And there is, of course, atopic dermatitis as well as a frequent condition. So a combination of skin and gastrointestinal symptoms increases the likelihood for allergy. Although a combination just by coincidence is of course possible, given the high incidence of all these conditions, which occur in each of them in about 20% of all the infants. What about the incidence of cow's milk allergy in infants with atopic eczema? Well, if you select those infants with severe atopic eczema, you end up by having around 1/3 of the children who have cow's milk allergy. And if you select those with cow's milk allergy below the age of 1 year, 40 to 50% will develop atopic dermatitis. So it's the 1 in 3 rule. But unfortunately, it's not only cow's milk allergy which presents most of the time with a combination of symptoms. Also, infants presenting with functional gastrointestinal disorders have most of the time a combination of different functional gastrointestinal disorders. As shown in these data from France, up to 75% of the infants with a functional disorder present with a combination of at least 2 functional gastrointestinal disorders. So combination of symptoms does not really help us to separate allergy from functional gastrointestinal disorder. For the infants which are exclusively breastfed, there is consensus that there are no data suggesting that reflux as single manifestation, constipation as single manifestation, and infantile colic as single manifestation suggest that this might be related to cow's milk allergy. So there are no data for in exclusively breastfed infant that reflux alone, constipation alone, infantile crying alone are manifestations of cow's milk allergy. Symptoms which are probably still under-recognized are the food protein-induced enterocolitis syndrome, which are relatively severe symptoms frequently caused by cow's milk allergy, but not always. And next to that, there is also the food protein-induced allergic proctocolitis, which is a rather benign condition in young infants, presenting with some red blood in the stools, but for the rest doing very well. And this is 100% caused by cow's milk allergy, and almost 100% of those children become tolerant to cow's milk protein at the age of 2 years. Also, a different manifestation is eosinophilic esophagitis, which in young infants presents very similar to gastroesophageal reflux disease. So it's very difficult, if not impossible, to make the separation just on clinical grounds between reflux disease and the same symptoms caused by eosinophilic esophagitis. And there is the way how to get sensitized with the hypothesis that infants may develop atopic dermatitis through cutaneous exposure to the food protein, that may induce the symptoms of allergy, and that oral exposure most of the time induces tolerance. How to diagnose the allergy? Well, unfortunately, there is not one laboratory test that is sensitive and specific enough to diagnose cosmic protein allergy. Skin prick test, IgE, specific rust are not really helpful. So the diagnosis is based on elimination diet for 2 to 4 weeks, followed by reintroduction in breastfed babies or challenge in formula feeding. But also in functional gastrointestinal disorders caused by the ingestion of cow's milk formula, symptoms will disappear if you stop the formula and will relapse if you challenge with the same formula. And last but not least, although challenge test is mandatory to diagnose cosmic protein allergy, many parents will refuse the challenge test. In order to increase the awareness of primary healthcare providers to diagnose, to better recognize symptoms suggesting cosmic protein allergy, we developed the COMI score as an awareness tool. So it's groups together the most frequent manifestations: crying, regurgitation, constipation, or stool composition changes, atopic eczema, and respiratory symptoms, and also urticaria. It groups that together in a score, and if that score is elevated, then the healthcare provider should be conscious that this is an awareness tool to highlight that cow's milk allergy may be one of the possible diagnoses. How to perform the challenge test? Well, every center does it in a different way. There is no real consensus about it. But what you see on this slide is a proposal how it is performed in many centers. Very important to realize is that the challenge test does not end after the half day of introduction cosmic protein, but that especially for non-IgE mediated cow's milk allergy, because of delayed reactions, that challenge test should be continued for at least 1 week, when every day the infant is taking a sufficient amount of cow's milk formula, up to at least 250 milliliters a day. What about the management of cow's milk allergy? Well, the treatment should, of course, consider efficacy, but also safety and nutrition. And palatability and taste do also play a role. And last but not least, cost of the dietary formulas is also important. According to the ESGAN guidelines published some 10 years ago, diagnostic elimination diet is recommended for 2 to 4 weeks. And if there is improvement of symptoms, then a challenge test is recommended. And if the child presents with anaphylaxis and specific IgE is very elevated, then you might consider to not perform the challenge test. Together with colleagues from the Middle East, we made a Middle East consensus for the diagnosis and treatment of cosmic protein allergy in infants. And what we published was that if there is anaphylaxis or a severe type of reaction, you should put the child on an elimination diet with amino acid-based formula and test for specific IgE. In principle, specific IgE need to be positive if there is an anaphylactic reaction, because anaphylaxis is IgE mediated. And then you continue the amino acid-based formula for at least 1 year. However, if the specific IgE are negative, then the likelihood for an anaphylactic reaction is very low. And so then a diagnostic challenge test should be performed. And here we did put partial hydrolysate for the challenge test, just to highlight that partial hydrolysates have no place in the management, in the treatment of cow's milk allergy. Most of the children will present with mild to moderate symptoms, and then an extensive hydrolysate is the first choice option. And if there is no improvement, then we go to the next slide. But if there is improvement, then again, the diagnostic challenge test should be performed. If there is no improvement, then cow's milk protein allergy is very unlikely. However, very seldom, in about 5% of the infants, the infant can still be intolerant to the extensive hydrolysate. And if you consider that that might be the case, then you need to put the child on an amino acid-based formula to see if there is improvement of the symptoms during amino acid-based formula feeding. Another way how to introduce cow's milk protein in the diet of the child is according to the IMAP milk ladder, which was developed in the United Kingdom, starting with cooked milk in a cookie or a biscuit, because you change the structure of the protein by cooking or baking the milk. And then gradually you induce different food choices from the cookie to the muffin to a pancake with increasing amounts of cow's milk protein to see if the child tolerates these increasing amounts and different structures of cow's milk protein. As you can see in this slide, both for the guidelines from Australia, the DRACMA guidelines and the ESBGAN guidelines, extensive hydrolysate formula is the first option in the management of cow's milk protein allergy. And of course, every extensive hydrolysate is different. They have a different peptide size, but do they also result in a different clinical outcome? In other words, what is recommended is that you use these extensive hydrolysates in the management of cow's milk protein allergy, for which there is clinical evidence, for which there are clinical trials available showing that that formula is effective in the management of cow's milk protein allergy. And it is probably not a good idea to give those infants intact protein from other animals because of the high overlap of allergenicity for a lot of those proteins from other animals, or because of nutritional reasons, because of course, before everything, the feeding should be adapted to the nutritional needs of the infants. Which brings me to conclusion. Reminding you that breastfeeding is the best way to feed all infants and that every effort should be made to stimulate breastfeeding as much as possible. And non-dietary factors such as the way you're born, environment, antibiotic use play all a major role in allergy prevention, and because these factors change the gastrointestinal microbiome. And we know that an unbalanced microbiome, poor in bifidobacteria, is a risk factor for the child to develop allergic disease. A double-blind placebo-controlled food challenge is scientifically the best way how to diagnose cow's milk allergy. An open challenge is in many situations, however, more realistic, and the placebo-controlled challenge may increase the risk to miss the delayed reactions, which are typically for the non-IgE mediated manifestations. And many parents refuse the challenge test. Therefore, alternative diagnostic tests would be welcomed, but are not yet available. And with this, I would like to thank you for your attention.
Our second highly expert speaker will be Professor Alexandra Papadopoulou. She is the Chief of Division of Pediatric Gastroenterology and Hepatology, First Department of Pediatric University of Athens, Children's Hospital Hagia Sophia. She has her specialized in pediatric gastroenterology in Great Britain at Institute of Child Health of University of Birmingham. She has over 100 publications. 5 of her publications, research have received honor. Currently, she is the president of Health Working Group on Eosinophilic Gastrointestinal Disease for year 2019 up to 2021. She is going to tell us today about current trends in the management of functional abdominal pain. Welcome with me, Professor Alexander. Thank you.
Thank you very much, Mr. Chairman. Ladies and gentlemen, I wish to thank the organizing committee for inviting me here. It is a great honor and pleasure to be here for a second time. The first time it was 16 years ago, almost. So what I'll do in the next several minutes is to give you an overview on our current understanding on functional abdominal pain, which is a huge headache for the general pediatrician. How to not miss a diagnosis of an organic disease, how to put the proper diagnosis of a functional GI disorder, and how to treat efficiently without creating more morbidity to the children than the disease itself. These are some colorful pictures from the hospital. I work in Athens, the Children's Hospital Hagia Sophia, which is the largest children's hospital in Greece and one of the largest in Europe. So abdominal pain, new problem? Not at all. 60 years ago, do you recognize this guy? This is a famous British doctor, John Apley. He devoted many years of his life studying these children. He wrote all these books. He wrote articles. What he said, that recurrent abdominal pain is very common. 1 out of 10 children is impaired by this problem, that there are 2 peaks in the preschool age and in adolescence, and girls are more vulnerable than the boys. All of these are still valid. 60 years ago, he said, so still valid. What else he said? He said that those children tend to have some certain psychological characteristics. These children are anxious. They have overconsciousness. They take difficulties of life too much to heart. Many years after the first publications of Dr. Apley studies showed that the incidence was, as he said, increase in adolescents and more frequent in girls. Several decades of research followed the first publications of John Apley, and all roads drove to Rome. In 1990, the first Rome 2 criteria were published. By whom? By experts on these disorders who gathered from all over the world in order to decide how to diagnose, how to put a title on the functional GI disorder. Many of them are members of the ESBGAN. In 2006, these criteria were updated, and the last update was in 2016. You see here the functional GI disorders that are associated with abdominal pain, published in gastroenterology. What do we know now that John Apley did not know at that time? We do know that in certain people who are genetically predisposed, early life events, I'll show you what kind early life events at the next slide, change the process, the way the brain processes the stimulus that come from the afferent nerves when splanchnic pain develops. Later in life, different medical events or psychological events are work as sensitizing factors, which medical events, infection, allergy, anything that can impair motility, but psychological events, the presence of stress on the child or in the family, the history of separation, of abuse, the presence of depression, of anxiety. And you see all this on this scheme. Early life events, nociceptive somatic stimuli that happened in the first month of life. And there are many studies mentioning gastric suction as such event that reacts to the brain and makes the changes in the processing of stimulus from afferent nerves. And then later in life, in people who are genetically predisposed, things like infections, allergy, anything that can affect the normal flora, anything that can affect the motility of the GI tract and cause distension, all of these may help developing functional abdominal pain. And now we have the pain episode due to all these factors that we mentioned before. And the child understands this pain, and the family also, as something very threatening. And then we have different risk factors from early life events, but also later in life, that do not help the child to cope with the pain. And there are other factors that are protective, like culture, religion, say research that helps, social support helps the child to cope with the pain. And if the child manages to cope with the pain, then there is normal development in the future, no disability. If it doesn't manage to cope with the pain, then we have a chronic pain disability. Is functional GI disorders associated with abdominal pain common? We did this study in European Mediterranean region in several countries, and we found that 12% of the children, same as John Apley said 60 years ago, 1 out of 10 children have functional GI disorder associated with pain. Let's see what are these disorders. The most common is abdominal migraine, followed by irritable bowel syndrome, and then functional abdominal pain and functional dyspepsia. And here you see the age and girls in white columns, the highest incidence in adolescents and in girls. When we have to deal with such a child of any age, we need first to know what organic disease we should exclude. These families are frightened. The mother is frightened. Mother, child, and doctor are all three confused. The mother thinks when she knocks the door of the doctor that my child does not make this up. This pain is real. My child is a happy child, has a happy life at home, a happy life in hospital. And then she thinks, oh my God, I hope this is not something serious. I hope I have a diagnosis when I come out of this office. And the diagnosis is not something, threatening. The child thinks, is happy, the child, when it comes to the office. There is no pain in front of the doctor. It happened a few days ago, a week ago. So she wonders why I'm here. I don't know to see this doctor. I don't know to have tests. And the poor doctor is completely confused. People wait in the waiting room, and he has to answer dozens of questions from the mother. He has to deal with a mother that worries very much, and he doesn't understand what is happening with his child. He thinks that everything is in her mind. The family is not normal. Something is wrong with the family. And then he thinks, I should miss something important, maybe H. pylori, and how to treat. What do I have? PPIs I have. Okay, let's try PPIs. Completely confused. What should think? Battery is low, something we need to do with the laptop. It says here. I can see here on my screen that the battery is low. So what he should do? First task, not miss an organic disease. Second task, put a diagnosis, concrete diagnosis of factual GI disorders. And third, treat appropriately, efficiently, without creating more morbidity to the child. How to reveal organic disease? First talk, take a good history. Then ask the child to show with 2 fingers where the pain is. The further the pain from the umbilicus, the less the probability that this pain is functional. Have in mind what are the warning symptoms and signs that speak about organic diseases. Vomiting, diarrhea, fever, weight loss, family history of IBD, and failure to thrive, abnormal skin color, oral pathology, perianal pathology. Now it's okay, now it's disappeared. Ask the child to tell you how severe is the pain. What do we use? We use these nice faces, Von Baker faces, pain rating scale. So the child, if you can speak with a child above the age of 6, can show very precisely how severe is the pain. We need to do a proper physical examination. And we need to have in mind what diseases can manifest with abdominal pain in different age groups. I'll just go through very quickly to some of these diagnoses. First, H. pylori. People thought this is missing for many months. Something else that should have in mind the pediatricians are lactose intolerance. That is very common in Mediterranean Europe, in Mediterranean region of Europe. And something that they don't think about is fructose intolerance. When pain occurs after drinking juices. Okay, I'll go quickly. So no positive association between H. pylori and recurrent abdominal pain. That's why in the that's why in the joint guidelines, in the joint guidelines of ESPGHAN and ASPGHAN regarding abdominal H. pylori infection, we don't say yes to test and treat strategy that is used by adult gastroenterologists. We have to do an endoscopy, and if we find H. pylori, not only gastritis, but ulcer, then we treat. Otherwise, we won't change the symptoms of the child. Other diseases that are manifested with abdominal pain are eosinophilic esophagitis with upper abdominal pain, retrosternal pain, and eosinophilic gastrointestinal disorders like eosinophilic gastritis, enteritis, colitis, that are also associated with pain, new disorders. ESPGHAN and ASPGHAN now are working on new guidelines, first of all, guidelines on the diagnosis and the management of these disorders. In a few months, we'll have the collection of literature finished, and we'll go ahead with the publication. So, I spoke about Crohn's disease. Don't miss Crohn's disease in children with recurrent abdominal pain when the pain is located here. Check for ESR. 90% of children with Crohn's disease and abdominal pain will have increased ESR. And here we talked already about lactose intolerance and fructose intolerance, which is also common, but people do not know about it. And in order to show you how we should check a child with abdominal pain, I need to let you know that in children with irritable bowel syndrome, you find celiac disease in 4.4% of them. So if you have a child with recurrent abdominal pain type of irritable bowel syndrome, don't forget to check for celiac antibodies. This is the first workup we do in children with recurrent abdominal pain. We don't do all of them. We individualize according to the symptoms of the child. And what about abdominal ultrasound? Will we do in every child with abdominal pain? The answer is no, because above the age of 3, abdominal ultrasound will not give any information that we do not know in advance. We will do in order to ask the technician to answer our question regarding pancreatitis or whatever. So if we have no evidence of an organic disease that needs to be revealed with the ultrasound, we don't ask for an ultrasound. Endoscopy, do we do endoscopy? The answer is no. Here is a study showing that if you do endoscopy, you don't help the child to get rid of pain. You know why? Because the mothers ask the doctors, and you ask us to perform endoscopy. We do perform endoscopy, we don't find anything, and nothing is changing in the outcome of the disease in children. So no endoscopy unless we have evidence for an organic disease. So we have excluded organic diseases. How to put a proper diagnosis of a functional GI disorder? We should follow the ROM4 criteria. And here you'll find the criteria to put the diagnosis of a functional abdominal pain. And here for abdominal migraine, abdominal pain in this case has a stereotype pattern, is associated with any of them. Headache, photophobia, pallor. Irritable bowel syndrome, abdominal pain is associated with changes in defecation, in frequency, in appearance of stool. And functional dyspepsia, the pain is located in the epigastrium, in the epigastric pain, is associated with postprandial fullness, early satiety. So now we know how to put the exact diagnosis. Do the pediatricians of Europe know? The answer is from this study we did with the ESPGHAN, the answer is no. 86% based IBS on the predominant symptom. Only almost 26% followed ROM3 criteria, the combination of symptoms. They focused on on one symptom. Wrong. How to treat? Several strategies. Fibers, do they help? No. The meta-analysis show showed no help. FODMAP, modern diet, avoidance of fermentable oligosaccharides, disaccharides, monosaccharides, polyols. Eliminate all of these foods. Very difficult to keep this diet. Does it help? Why first, what hypothesis was hidden behind this strategy? That all these, fructose, polyols, lactose, fructans, GOS, are attracting water in the small intestine, and when they are not absorbed, and when they go into cecum and the large bowel, they create gases, and gas creates distension. A distension creates pulmonary pain in these patients. And there were studies, mainly in adults, shown good result, decrease of bloating, of abdominal pain, of passage of wind in those adults who were on a low FODMAP diet. In children, we need more studies. This is a review by Italian authors saying that in children, there is no evidence to support FODMAP, low FODMAP diet or lactose restriction in these children. An interesting study showed why some adults with irritable bowel syndrome responded to low FODMAP diet. They showed that the responders had microbes in their large intestine with greater saccharolytic metabolic capacity. So only these responded to that diet. So there is a role for microbial flora, modulating microbial flora in order to help these patients cope with the pain, because a specific microbiome signature was found in children with irritable bowel syndrome. So people started to think, what about fecal transplantation? If this is true, maybe with fecal transplantation we can solve the problem. No, the result was modest and not for long term. You see, only 3 months, and in 1 year, then the result was lost. What about probiotics? Stefano Guadagnini used this probiotic and showed a decrease, in green the probiotic, a decrease in 2 weeks, decreased pain intensity and frequency using this probiotic. Other people showed improvement in IBS, only in IBS, not in functional dyspepsia, using 3 bifidobacteria. Lactobacillus GG. 1, 2, 3 studies showed no benefit. This one showed benefit only in patients with irritable bowel syndrome. But Lactobacillus reuteri was used by Romano in Italy, 60 children, and showed benefit in decreasing in frequency and intensity of abdominal pain in 60 children. Similar results were found in Israel by Westman. We did a similar study in our department with Lactobacillus reuteri, and what we found, that both Lactobacillus reuteri and placebo decreased the pain. No difference between Lactobacillus reuteri and placebo.
5
Both
minutes
were
more,
effective.
please. 5 minutes more.
5 minutes.
Yeah.
Both effective. Placebo effect. Then it is shown by studies that the effect of placebo can be reversed, applied an opioidic antagonistic, like naloxone. So placebo has the same effects as opioid on the brain in this area that process the pain. Is it common, placebo effect? it is 41% of patients, of pediatric patients with abdominal pain respond to placebo, 41%. Okay, what else? What else we can do to help the child to cope with the pain? We have drugs. Antispasmoids, they are used. They have no adverse effects. They have some benefit. And there are a large group of drugs that try to change the way the brain processes the pain stimulus from the splanchnic pain stimulus. However, all of these drugs have side effects. Are they effective? Amitriptyline, the most common. Here, it is used in children with daily pain compared to placebo, no difference. So no difference plus side effects. Hypnotherapy. Hypnotherapy. It is, this is very, very interesting because hypnotherapy tends to make the child to have ego strengthening, to take control of abdominal pain, and to learn how to relax. And there is highly effective, it is highly effective in controlling pain, not only the beginning, but long term. And this study was continued almost 5 years after, and you see in green the effectiveness. So in 5 years, it is still effective. And you see here with the functional MRI, the changes in the brain before the hypnotherapy application. Here are controls, and here these ones after application of hypnotherapy. Even better than in controls. It is a circulation in brain. It's difficult to have somebody in the hospital to do the hypnotherapy. You need a skilled psychiatrist or psychologist. And then people thought about audio recorded guided imagery. And the success was like this, 60%. And those who had only medical care had success, only 20% of them. These 20% were put on this technique, and all of them, 60% of them responded. And this study compared hypnotherapy to home CD using this way to intervene in the processing of brain, and found that they were similar. The results were similar on the previous slide, similar results. Other people thought about internet-delivered cognitive behavior therapy for adolescents with the irritable bowel syndrome. What was the thing about it? To learn, to teach, to educate the children to stop when the pain begins, to observe what is going on, and control, take control, let it go. And the results are very good. This in blue was the waiting list. This is red, had this technique intervention. And the treatment was much better effective than the nothing. Social learning cognitive behavior treatment versus education support. Also teach parents, the family, relaxation technique, the whole family. They work with parents to modify family responses, and they try cognitive restructuring. Again, in red, much more effective than just education. And last is this very nice study by Walker. What he did, he divided in 3 groups: children with irritable bowel syndrome, put some air in the rectum in all of them, and one group asked the mothers not react at all. The second group ask the mothers to distract the attention of the child from the pain, and the third group to attention, to have attention. What is going on? How do you feel? How is the pain? What was the result? The patients, the mothers, yeah, it's okay. The mothers who followed the distraction were the most effective. The mothers who followed the attention were the least effective. The interesting thing was that the children liked the way the mothers distract them. The mothers considered that a disaster. How I could distract my child from the pain, how I could not show attention to this. Very interesting. And now, future. These children that have functional GI disorders as children will be adults with depression and functional GI disorders while they are adults. And what risk factor affect? Lack of insight into psychological influence symptoms, 7 times more are at risk to become adults with similar problems, involvement of more than 3 consultants, one after the other, and refusal to engage with psychological services. And the last is that if you have a child with nausea, then it is a tricky thing. These children are at risk for a bad outcome. What they do at Houston, they tried to control the vagus nerve, putting this neurostimulation in the ear, compared with sham. One machine gave impulses, the other nothing, and showed that these children who had this in the ears, giving impulses, electro impulses, were treated completely from nausea, the others not. So, try when you have to deal with such a child to reassure, to educate parents, to reverse behavior, reinforcing pain, to prevent iatrogenic damage. Don't show ambivalence, don't perform unnecessary tests, don't reinforce pain behavior, don't give needless dietary restrictions, don't prescribe unnecessary drugs. Reassure the patient, explain, identify, clarify, and reverse stress factors, reverse reinforcement of pain behavior, lead back to normal activities, and consider behavioral therapy and family therapy. Thank you for your attention.
Thank you so much, Professor Azad, for this such an informative lecture. Thank you so much. So we can open up the discussion, but we have a small announcement. Please, for our meeting residents, can we cancel break, please, and we can continue our last sessions. Then at the end of this closing ceremony, there will be very good profits for all of you, inshallah. So our the end of this highly appreciate. Thank you so much.
The board for questions, please.
Very good. Very good. They are doing a very good job. Exactly. If you see, Claudio Romano in Italy showed efficacy. Swiss Weiman showed efficacy. We showed efficacy too, but efficacy of both glutari and the placebo. And then you saw 40%, 41% placebo effect in these children. So you don't know. Whatever. It does help. It does help. But the most helpful is psychological. It's hypnotherapy if you have somebody to learn, to go to Manchester and learn the Manchester protocol. Or this audio imaginary. You can do it at home. There are specific audio. The same, they do the same. It's like hypnotherapy, but you do at home at night, you listen to music and you listen to somebody who tells you what to do with your pain. And the other, the internet, they create pain and they teach you to stop, to explain what you feel, and they teach you how to control and ignore it. Ignore it and continue your activity.
It will help the mother to distract the kids because it's difficult for the mother to ignore the pain of the kid. But if she give anything, even placebo, she will have time to control the.
You know what I found very, very useful? To explain to the mother from the beginning. So this is the pain, I just draw. I'm not drawing well, but I'm drawing. This is the pain. What you should do is to have a strategy in your mind how to distract the attention of the child for the pain. Not the time that pain is there, just before. A good strategy. And you do this strategy when the time, and if you see that the pain is gone away, then it's functional. Then do it all the time.
Yes, please.
I'm Dr. Ali Kojo. I see our as they talk about another policy, so I'd like to tell so what is the role of biology treatment compared with steroids?
Sorry, the
role of biology treatment, adalimumab and these things. And the second question is in cow protein allergy. How about trying the other animal skin or rice protein?
Well, I thank you very much. I will address just the part on inflammatory bowel disease. Indeed, we use infliximab or adalimumab. Some centers give the patients the option to choose between infliximab, which has to be done in hospital, or adalimumab, which may be taken at home. Personally, and in my unit, we always start with infliximab, and there were several reasons for that. One of them is because there is more experience, although adalimumab now is widely used. The second is because it was cheaper at the time. And the third, perhaps the most important, is that adolescents are quite often non-compliant. So if you have the patient come into the hospital and take the drug, you are sure that he or she is taking the actual dose correctly. If you give the drug to the patient to take it home, if they feel well, they may stop and not use it. And then this is a problem because they lose effect, they gain antibodies, and it's a waste of money. So we usually reserve adalimumab as a second option if they fail infliximab because they have high level of antibodies, and then we switch to adalimumab. But many centers use in the same way one or the other. Oh, clearly, biologics are far more effective than steroids. Steroids, so side effects, well, these are very safe drugs. There are some side effects, there are some risks, and whenever patients ask me, well, is this a risk? I usually tell them, well, it is a risk to be sick, and not be treated. That is a clear risk. Crossing the street is a risk. Some people get run over. But if we look both sides, if we take care, we can probably reach the other side of the street safely. With these drugs, it's the same. There are some complications, but we monitor patients. We don't take the drug and come back in a year, so we see them every 3 months. So using proper monitoring, these are quite safe drugs.
And about this corona season,
Well,
how frequently use these?
it is very interesting, and actually, since the pandemic started, various entities and also the IBD Porto Group and national societies have monitored the risk and evolution of coronavirus infections in patients with IBD that were taking biologics. And in fact, although these patients might have the disease, they never had a severe form of the disease. Probably, and that's why the doctors use dexamethasone to treat coronavirus infections in some severe cases, because it is the immune response that is causing a lot of damage. So by decreasing slightly the immune response, which is very much what we do when we use biologics, we do not expose patients to a more severe disease. If anything, they may have a very light, mild disease, and still there is an ongoing registry. And so far, we have not had more severe cases in patients with IBD than in general population. Well, personally, I do not have experience with using other drugs because, fortunately, in my country, we had no cases of pediatric IBD patients that had a severe form of coronavirus disease, but we advise patients not to stop treatment and take treatment regularly. If there was a patient with Crohn's disease that went into relapse, we would prefer to start enteral diet rather than starting biologics for a while. So try to avoid some sort of added risk. But in patients already on biologics, we kept them on treatment and did not advise them to stop. Thank you very much.
Please have a seat here.
About trying other options in calming protein energy, like rice protein, maybe, or other like oil.
Thank you for the question. The question about patients with cow's milk protein allergy. Can you use other mammalian milk? Well, the short answer is probably no, because if you are allergic to one mammalian milk, probably you are allergic to other mammalian milk. If you are allergic to cow's milk, probably you are allergic to goat's milk or other kinds of milk. But the cross-reactivity is not 100%. It's probably 70, 80%. So 20, 30%, they might not react, but in general, they will react, so I would not. The rice, probably you can use it, the extensively hydrolyzed rice. However, we have a couple of problems. The first problem is you don't develop the tolerance with the rice because it's a plant-based, it's not animal-based. And there is a theoretical risk about arsenic poisoning, el-zernich, because a lot of the rice, not a lot, some of the rice grew in an area with high arsenic in the soil, so there is a theoretical risk of that.
First question for both Gary and George. He's asking, can metformin others cause symptoms and signs similar to inflammatory bowel syndrome?
I'm sorry, I'm not.
Can metformin cause symptoms and signs like metformin? Can it cause IBD-like symptoms?
Well, I have no personal experience, and clearly, I've never seen IBD related to the use of metformin, but I don't know if anyone else has different experience.
All right. There is another question. Will you explain us
Incidents? Yeah, typically the start of the symptoms are in teenager years. And the diagnosis usually is delayed by few years. That's the typical. That's the usual IBD, period. However, there is a category what's called very early onset IBD. The definition of very early onset is usually below the age of 4 or age of 6 years, i.e. before they go to school. Very early onset IBD is a little bit different. It's typically more aggressive disease, not responding to treatment, frequently requiring surgery, and usually associated with some kind of an immune-related disorder characterized by some kind of immune deficiency and autoimmune disease. In the Arab world or in this culture, we see fair number of very early onset IBD, and they follow these characters: severe disease, not responding to treatment, and requiring surgery.
If I may add something, in case someone diagnoses IBD before 4 years of age, please consider getting advice from a genetic department, because quite often these children, and especially if that happens within the first 2 years of life, quite often these children have genetic defects and they do not respond to the usual treatments. And the treatment, the curative treatment, is bone marrow transplant. And that is really effective. While I was here in this session, I got a message from the mother of a child, and this family had had another child with a severe form that died from the disease, and the second child was transplanted, and she's out of disease without any treatment at all. So it is very important to make genetic diagnosis if it is an early onset disease.
With a whole genome sequencing, and sometimes even if you don't find a mutation, bone marrow transplant can be a cure.
Yeah, look, in those cases, look for perianal disease, because quite often there is severe fistulizing disease. And if you see that, or nail abnormalities, or head or skin rash, there may be a genetic condition, mostly IL-10 deficiency, but there are others that may need bone marrow transplant. May I ask you if you...
So there's any rule of the common formula of the market of this pain according to the internet? Well, surprisingly, market of comfort, a lot of comfort. So any rule for that?
Speak about infant alcoholics. Alcoholic is normal, and for masturbating. So, I just need to excuse counseling solidarity because that's before. So, to do so, I'd like to say that, of course, not for pediatricians, but for pediatric dermatologists, and I think that here you see more genetic diseases due to the marriages. But it's very important to establish connection with networks. There are existing networks within Europe and worldwide. So, and you can send colleagues sequence without paying anything. Even the queries are paid by the university. Of course, it takes time to make the research one.
Any more questions?
Now we will give the awards for the moderators and the speakers. May I call on Dr. Muhammad Mikdadi to receive the award given by Dr. Sharif. Next, we call Dr. Monica Kaushal to receive the award. For our moderators, may I call Dr. Misaf Abdul Razak to receive. And Dr. Abu Zaid to come.
Now we move to the last lecture session. Please, Dr. Sujay, for chairing the last session. And I think this is it will be the most amazing session, and it is because of the very two big eminent speaker from ESPAGAN. So I'm waiting for this session really and this workshop. So Dr. Sujay, thank you.
Good evening, everybody. I'm now privileged to invite two eminent speakers again to the dais, Professor George Amidas and Professor Alexandra, to give their final interactive session on GI endoscopy in pediatrics. I welcome both of them for the last session.
Well, thank you very much again. Well, dear colleagues, endoscopy is a very broad topic, so I will focus only on some situations in the emergency room when we are called anytime, day or night, to decide whether to do or not an endoscopy to a child. The typical situations that we face in this situation is foreign body ingestion, usually followed by acute dysphagia, caustic ingestions, bleedings, or acute epigastric pain that has no other diagnosis. So one of the common situations, well, Portugal is a country by the coast, so we eat a lot of fish, and quite often children have had a fish bone and they complain of pain. And sometimes we do find something there, but in most cases, there is nothing to be seen. And quite often, it is small fish bones. So over the last few years, I tend to refrain from doing endoscopy unless there is an information about eating cod, and cod has some sharp, big fish bones. But in most cases, I tend to send the patient home and come back next day in the morning, because usually when they come at night, they just had dinner, so they are not fasted anyway. So I tell the parents to go back home, let the child sleep, and try to feed them early in the morning. If they tolerate, there may still be some slight pain there, but even if there was a fish bone, it probably went away. But if the symptoms persist, then they need to come later in the day for, with proper fasting for endoscopy. Well, foreign bodies are very varied, and probably anyone doing pediatric endoscopy will have such a similar collection. Well, there is here a nail clipper. Actually, in this collection, I've had 3 nail clippers, and I tell you, all of them were swallowed by children of less than 2 years of age. So age is not a limit for whatever they can swallow. So be aware, even if the story is hard to believe, well, it does happen. So we have a lot of these. Facing foreign body ingestion, we need to know what was ingested, when it happened, which symptoms they have, and when they had the last meal. And trying to do an endoscopy to find a foreign body in a child who is not properly fasted is quite a risk and quite a pain, because usually the foreign body is in the middle of a large amount of food, so don't do it. Wait at least 6 or 8 hours fasting before you do endoscopy, unless there is indication for more urgent attitude. So if the foreign body is in the esophagus and is causing dysphagia, pain, there is increased sialorrhea, well, in these cases, we may need to keep the child in the hospital and do endoscopy as soon as safe. If it is food, a non-sharp object, magnet, a single magnet, then we tend to be rather conservative and let it go and wait. Perhaps it will go away. But with a button battery, this is a true emergency. Button batteries are always our worst nightmare in endoscopy. When there is a coin stuck there like this, then we want to take it out as soon as it is safe to perform endoscopy. And if it is a button battery, we want to take it as soon as we can. Don't waste to fasten the patient. Put in an endotracheal tube and do it very fast, and I'll show you why. Well, the number of episodes in this review of button battery ingestions is quite high. The risk of complications is rising, although when I started doing endoscopy, our main concern was about the batteries opening and leaking chemical fluids that could be damaging. That very, very rarely happens. Mercury batteries are virtually absent from the market. So our problem is not about leaking liquids or fluids into the gut. It's about the electric current of the button batteries. So if they are in this, if it is a traditional long battery, I don't bother. It's not an emergency. If it doesn't go away within a couple of days, then I can schedule an endoscopy. But the button batteries in the esophagus, these are really severe situations. I usually ask the surgeon to be on standby because there are cases of severe perforation and fatal bleeding. So whenever I go to the operating room in these patients, I want the patient anesthetized with a tube, and I take a dilation tube with me just in case there is some dramatic bleeding. I could never happen, but I could put in a dilation balloon, inflate it until the surgeon is ready to act. So the complications are clearly perforation, bleeding, fistulas. So these patients need follow-up. One of our cases, as you can see, the lesion went into the vertebra and caused a collapse. Fortunately, this girl healed with time, but it may be as severe as this. You can have severe narrowings, and this is one case that happened to us. You see, some food residues, but a lot of fibrin. You see the battery there, greenish. And within a couple of hours, caused a dramatic damage. So I could put in a forceps and grab the battery and take it out. So you see it there, and it's coming out. It's a bit slow, but I assure you that it came out all right. Yeah, it's coming out. Hmm? Okay, so on day 3, we repeated endoscopy, and you can see that there was a severe deep burn in the esophagus, still a lot of fibrin. And on day 11, there was here some, here, the ulcer. And 1 month later, all was healed and the child was all right. Sometimes we have these lesions because of the current between the 2 plates of the battery. Through the mucosa, they cause a circuit, and this is really damaging. Well, we use several devices to grab foreign bodies depending on the type. Well, I love these baskets. They make our life so much easier to retrieve coins because it's very easy to grab them. This is a spring from a device to hold the clothes while drying. And you see, we apply the basket, we push it, close the basket, and then retrieve it very easily. So this is a wonderful device. Sometimes we use these cups to protect some sharp foreign body or these tips. We apply these tips. These are the banding, the varicial banding that we can put the sharp body inside this cap. Sometimes we use that hood, that bell hood, to protect from devices like this. I think I skipped, no. Well, this is the cover of an earbud in the esophagus of a child and was causing dysphagia. This is the bell hood. It goes inverted into the stomach, and when we pull back through the cardia, then it unfolds and grabs the foreign body. So there is a bit of some tricks to use this, but just to give an idea. We use the forceps to grab some foreign bodies like this. Well, if you are in a situation where you don't have endoscopy or even access to endoscopy, and you have a coin, for example, in the esophagus, you may try this trick. This is a Foley catheter, which is pulled beyond the foreign body. Then you inflate the balloon and try to pull it out. Well, I must say I tried this once and it just didn't work, because if it is very thin to go through, it folds and doesn't get through. If it is thick, it will just push the coin down. So I was not very successful, but it's been described. Another alternative is to have a tube with a magnet on the tip so that you can grab them, or you can even combine the two, pass the Foley catheter below the foreign body and the magnet on top, and then take everything out together. And you can even put in some X-ray contrast so that you see exactly where each piece is. This was a little girl of 11 that had this long pin. You see how long it was. It caused a small, when coming out, it caused a small perforation of the esophagus, which healed spontaneously without any problem. Food impaction occurs quite often. We have to be aware that some of these cases already have a past history of similar episodes. And when that is the case, then we have to consider the possibility of being with a eosinophilic esophagitis, sorry about that. This is inflammation, and this is a mucosa that bleeds very easily. So whenever we see one of these cases, we must take biopsies to confirm a diagnosis. Quite often we have cases of upper GI bleeding. There are very options of various diagnoses. I will not address this because Professor Papadopoulou will then talk about how to manage bleeding. So, but just remind you that in case of upper GI bleeding, consider to pass a thin nasogastric tube and gently wash with saline and let it flow out again, because if there is active bleeding, you will see red blood coming out. If the bleeding is not active, you may just have some clots, and then you don't need to rush so much for endoscopy. We may have diffuse lesions like this. We may have ulcers or bleeding vessels. Another situation that commonly needs our care is caustic ingestion. In these cases, we must do endoscopy usually within the first 24 hours. We don't need to do it immediately because some of the lesions take a few hours to be established, so we want to allow some time to make a proper assessment. Endoscopy does not cure or treat the lesions of caustic ingestion, but it allows us to select the patients that will need follow-up from those that do not have lesions and can be sent home without further concerns. So within 24 hours of the accident, if it was an alkaline product, you expect to find lesions in the esophagus. If it is an acid, probably lesions will be more severe in the stomach. The most common place in the esophagus to have lesions from caustic ingestions is over there, is in the upper third of the esophagus. And this is because the esophagus crosses the great vessels, so there is a slight narrowing that opens up every now and then. So the liquid, the burning liquid, stays there for a few seconds before flowing down, and it causes deep damage. Sometimes the aspect looks terrible, like here, like this one. It was peroxide hydrogen. So it makes a nasty look, but usually these heal without a problem. But there are more severe lesions. Sometimes they evolve to stenosis. And again, Professor Papadopoulou will address the issue of dilations in those cases. This was a boy that had a PEG, had a gastrostomy, but the food wouldn't go in. So when we did endoscopy, well, we could identify the place where the button was, but there was nothing to be seen there. And we could pass a guide wire through the tiny hole, and then pulling it with the endoscope, we could pass a dilator to dilate the tract again from inside out, and then we could replace with a new balloon on the same spot. For lower GI bleeding, we have to consider possibility of polyps, but also think of ulcerative colitis or other forms of colitis. And I would like to share a couple of ideas from my experience. Always have various devices at hand, because sometimes even if you grab a foreign body, it may be loosened in the pharynx, so you need to have the tools to get it out quickly. This was, I can't remember, was a boy or a girl that had a coin. And by the time he came to the emergency department, they did an X-ray and said, well, it's far away, it's almost in the colon, so no problem. But a week later, still it had not come out, and the X-ray showed that the foreign body was in the very same place. So what I did was to take this boy to the X-ray. I picked him up, shook him a little bit, and asked for an X-ray lying flat. And what happened was that the foreign body actually was still in the stomach all the time. So now I recommend to all my colleagues, if you do an X-ray for foreign body ingestion, do it on a lying position rather than standing up. This is another case, and again, on repeat X-ray, it was up there. Well, this is a funny trick. This is a pin, a safety pin, inverted in the esophagus. So by inserting a nasogastric tube with a tip cut, we could, with a little bit of expertise, you see, we could protect the tip. It's slightly down into the stomach. So the nurse always went with the tube after the pin, and then we could grab it and take the whole thing out without damaging the mucosa. Of course, if I would find this in the stomach, I would grab it by the other end and take it out with the tip facing down, and usually it's quite safe. But in this case, as it was facing up, we used this technique, and I could grab it on this end with the tip protected there, and we took it out altogether, as you can see. Well, this is just, I learned this from a French colleague many years ago, and when I saw a case, I said, well, I'll try and do it, and it worked very well. Okay, this was another case. A child came in the middle of the night because had this pin, and she came from another hospital, so we repeated the X-ray, and it was still in the same position, although the child was very comfortable. So we took her to the operating room, and when she was already anesthetized, my colleague called me and said, well, there is a pin on the floor. So actually, this was not inside the esophagus, it was on the clothes. It does happen. Well, magnets are a dreadful toy for children. If it is a single magnet, it would not be a problem. Well, it should not go near the fridge, or it might be stuck there, but otherwise it's not a problem. But there are these toys with various balls, and if they swallow various of these can be very dangerous. There is one case in the United States where the child needed a small bowel transplant because of multiple fistulas due to these magnets sticking to each other. So this is a very dangerous toy and not to be given to children. You can see this can be dangerous. I was telling you that the risk of button batteries is the electric current. So this is a bit of chicken, and I picked up a new battery and put it there, and you can see 50 minutes later, it was burning. It caused deep burns just by sitting there. So it is the electric current rather than any chemical leaking out that causes the lesions. The ESPGHAN published recently some guidelines about endoscopy, and I love this device. Thank you very much.
Can we invite now Professor Abdul for the next session?
Great. Dear colleagues, pediatric endoscopies is the most fascinating part of pediatric gastroenterology. You are not pediatric gastroenterologists, you are general pediatricians. So what I will do is to give you an overview of the equipment we use, of how do we use this equipment, just a quick overview of everything. A bit of history. Fiber gastroscope just became 60 years of age. Fiber sigmoidoscope, almost 50 years of age. If I go back to my archive, my personal archive, this is me in 1991, 1994 in Birmingham, when I had the specialization in pediatric gastroenterology. I was doing endoscopy with this scope, No anesthetist, one nurse here looking after the child, the pulmonary, you know, and the other helping me doing the taking the biopsies. And here you can see my boss, Ian Booth, Professor Booth, doing a colonoscopy with an endoscope to an infant in the presence of the mother. This way, of course, you can do only diagnostic endoscopies. In order to do interventional endoscopies, you need much, much more. You need endoscopes of advanced technology. You need CO2 pump. You need water pump. You need advanced technology of diathermy. This is argon plasma coagulation, several uses to stop the hemorrhage, to use in different other conditions I'll show you later. And you need to have consumables. Several types of clips in order to clip a bleeding ulcer. Hemostatic spray. This is the hemospray we use to spray over the bleeding ulcer and stop the hemorrhage. Very easy. Everybody can do that. Tissue sealant. We also use this in order to stop bleeding when bleeding is mild. We need the forceps that George just showed you in order to grab foreign bodies, and this in order to protect our scope. We need dilators, any kind of dilators, balloon dilators, bougie. This is a new one. This is endoscopic bougie that goes to the infant scope. So in order to dilate esophageal stenosis. We need to have banders in order to perform budding of esophageal vices. And we need to have different types of electrocautery knives. So this is the equipment we need to have. And then we need to have very well-trained personnel. ESPGHAN has put into tradition educational events with training on live, on biological models and on mannequins in order to get training in all kinds of interventional techniques. These three courses have taken place in Athens. And you can see experts from ESPGHAN. George is somewhere here teaching also. Some pictures. We have people from all over the world, not only Europe. George is here. George loves very much teaching and he does it wonderfully well. So next time you may organize such a teaching course. You see here people. We have also in real time connection with endoscopic suites from all over the world. You see here Victor Fox from Boston showing advanced techniques. And you need to maintain the skills, not only to get the skills, but maintain. For that, in our hospital, we have mannequins, and we have a specific tower for educational purposes. And this way, we teach younger doctors to do an endoscopy, to do a colonoscopy, to learn polypectomy, banding of variceal esophageal varices, and all kinds of techniques, interventional techniques. If you have this equipment and if you have the trained personnel, you cannot miss any diagnosis. You can diagnose, which diagnosis is 3/4 of the remedy, as Mahatma Gandhi said. So you can diagnose several conditions. when the child has retrosternal pain or epigastric pain, or when the child has bleeding, upper GI bleeding, lower GI bleeding. We can diagnose H. pylori infection and ulcer. You can even see the characteristic findings of celiac disease. Of course, the diagnosis is based on histology. We can find different causes of bleeding in children. You see Pedia here. We can diagnose Crohn's disease and ulcerative colitis. And we can do interventional endoscopies in emergency GI cases. George talked about foreign body removal. I won't say anything about this. We can stop bleeding using this forceps and this one. This is over-the-scope clip device. You can use this in certain cases. This is the hemospray. This is argon plasma coagulation in order to stop superficial bleeding. Tissue sealant also can be used to stop a mild bleeding. And here I'll show you my hospital and some things that, some techniques that we have performed for first time in children. This is a fistula, tracheoesophageal fistula. The anesthetist gave methylene blue, and you see methylene blue comes out from the fistula. What we did is we used argon plasma coagulation here in order to cause burn of the area of the fistula from the esophageal side and cause epithelialization afterwards. That's why we did it. You see here. And then we put down the clip over the scope clip, and we asked the laryngologist to do similar things from the tracheal side. The fistula was big, very big. So what they did, they used the Bagby electrodes in order to cause burn of the area of the fistula from the tracheal side, and then burn, and then they put tissue sealant, T-seal it's called, through the opening of the fistula from the trachea. And here you see the barium falling through a month after the application. There is some difficulty to pass through, but it goes through. And you can see here the over-the-scope clip on the esophageal wall. We took out the clip using the technique that is published using actually water that makes the clip flexible, and we could take it out easily. And this is the upper GI endoscopy following this procedure. No fistula was seen. This was a child, a refugee, going through Greece to Germany. And when, after this endoscopy, he had to leave in few days. What happened was that the mother was so glad that for first time in his life, this child tried to eat. So she gave everything to eat, whatever he wanted. So this effect was not maintained for long. On this child, however, we did the same, except the over-the-scope clip, we didn't do that. We just used the argon plasma coagulation, and the laryngologists, they put the tissue sealant after burning the area of the fistula with Bagby electrodes. You see the tissue sealant. And now the child, 1 year after, is well, has no problem, asymptomatic, completely asymptomatic. This is another child who had Hirschsprung's disease. He was operated with the UML procedure, and then for almost 3 years, he had protracted constipation and recurrent admissions to the hospital due to severe enterocolitis. We did an endoscopy and we found this. We found this. This was a complication of the UML procedure and did not let the rectum the child could not defecate. The rectum could not move at all. So what we did, we used these electrocautery scissors and needle knives. You'll see the scissor here. You see how thick it was. The surgeons wanted to redo the procedure, the UML, but redo the UML is a huge operation, very difficult to redo it. So I decided to go for it. You see how thick it is. So you see the scissors, and then I changed technique and took the needle knife. This is needle knife, and cut. Managed to cut. And here you see 10 months after, the child was completely symptomatic, normal stools, plus 3 kilos weight gain. And the rectum was completely normal. We were very, very glad to manage to do this child. Esophageal dilation is something that we do very often in our hospital with balloons. And in this case, you see after caustic injury, very, very long stricture and very, very small, lumen. In this case, what I used was this, bougie cups. These are new. These are the only bougie cups that go into an infant, a neonatal scope, and tried this way to dilate the esophagus here, and managed to dilate 2/3 of the esophageal stricture. At the end, there was almost closed. The lumen was closed. I could not go further without the surgeon. So the surgeon took over with bougie and dilated further under radiology control. Esophageal variceal banding. Also, it is a standard procedure carried out in our hospital. We use the bander you saw before. This is the procedure. You see the bander. And last, endoscopic gastrostomy placement. George, I think, showed some pictures of the gastrostomy placement. You see from the stomach, we put out the needle. We take out this from the road. We connect to the bottom. And we take out again through the mouth, through the esophagus and the stomach, and out of the body. And inside the stomach, you see this. Connect, and in 2 months or 3 months, we change the stoma, the gastrostomy bottom with the bottom. And where we do all these procedures, to finish with, this is our endoscopy unit in my hospital with 21 beds. And this is our endoscopy room. This is where we performed all these endoscopies you saw. And now I share the love for the endoscopy as George and as every gastroenterologist feels about this organ. We do love our endoscope. Thank you for your attention.
Thank you very much for very elaborative lecture on various advances in interventional endoscopies. It was very nice overview and very informative. And Professor George talked on the various practical aspects of the practical problems what most pediatricians face about the foreign bodies, especially the button batteries and magnets. Nowadays we see a lot of children ingesting them, and recently Dr. Sharif recently announced had a 4 or 5 years old child that ingested button batteries. Now I open the floor for any questions you have to both the speakers. Professor George, I wanted to just ask you my question about these button batteries and magnets. When they ingest, when we get a history like that, what is we are planning to refer to the pediatric gastroenterologist or to a place, a referral center. What is the take-home advice to the parents during that period? Anything is there, especially the button batteries and magnets?
Well, if it is a single magnet, it is just an artery. The foreign body doesn't pose any problem. And I would advise parents not to come to the hospital to do X-rays every day or every other day, but it's a waste of time. I would tell them to go home, feed the child with a lot of fiber, and wait. And if the foreign body does not pass for a week, then we might repeat the X-ray and consider doing anything. If those are multiple magnets, then the problem is a bit more complex. I would try, fortunately, I did not have such cases, but considering the experience of others, I will try to get them out as soon as possible to avoid the risk of causing friction between the two of them and causing fistulas in the small body. So, if more than one, I'll try to get them out as soon as possible.
Any advice in that time for the parents? Any advice not to do or to do? No, any advice to the parents till they go to the referral center? If they've taken multiple magnets or button magnets?
Thank you, George. If I may comment, I think the question was if you swallow the battery and going to take them a while to get to the hospital, some people would suggest to take some honey, asal, and swallow it every 10 minutes till you reach there. There's some evidence it might reduce the burning that's happening by the current that's happening there. However, more importantly, to send him to the hospital immediately and intervene. It's like top emergency. Even if they just ate or whatever, just put them to sleep and remove it. In the magnet story, I agree with you. If it's a single magnet, it's much safer than double. Keep in mind, sometimes in the X-ray, it looks like a single magnet, but it can be two magnets stuck to each other. Even if it's a single magnet, I will suggest for them to avoid any metals like a belt or anything, because that might cause problems there. And well, in your practice, you tell them to come back in a week. In my practice, I would like probably to see them sooner, because you never know what happens. We had an experience, somebody swallowed a magnet, was sent home. Later on, he swallowed another magnet. So keep a close eye on these patients, in particular, the ones with the behavioral problems, because they can swallow different kind of things. And we just submitted our abstract to the next SPGAN meeting, and we have, unfortunately, a large number of children who swallowed magnets, and many of them, they have perforations and serious complications. They are available in UAE, yeah. Agree. Yeah, I think that the most important, just get them to the ER. If they have honey in the house, it's available, give it. But don't go shopping for honey, and not going to the ER.
And then we'll have
even if there is a slight glucose of birth, not never had severe complications from that. So I would like that. The one sitting in the esophagus are really the negative.
In the stomach, I agree. Some people will do what you said, just wait. Others will say, if it's reachable, go and get it out. But I think both ways are fine.
when honey is used, then you have to talk to your anesthetist and say, please disregard that the child has eaten honey and go ahead with an endoscopy. Otherwise, he will say, okay, wait 3 hours. He ate honey. He is not fasting. I don't do the endoscopy.
Yeah, don't wait 3 hours. No.
So it's very important. And about the multiple magnets, we had recently an experience. So the child took one day, a second day, a third 3 days after.
Exactly.
When the pediatricians made an X-ray, they showed all these magnets like they were together. In fact,
4-year-old come to me last week.
Oh.
This picture is having iron deficiency anemia and having what's called bica. Yeah, and he is eating magnet, and it is coming like this. You know that balls and rods.
Yeah.
So it's coming, making the shape. So I advise him to go to gastroenterology, but unfortunately he refused and he stayed. 4 days later, he has severe abdominal pain and is go to emergency.
Perforated, yeah.
So, yeah. Several intestinal parts are attracted. And fistula is created between the fistulas are created. Yeah. I did endoscopy. I found necrosis. I had to go down to the jejunum. So I did endoscopy. I found necrosis there. So the surgeon came in and found 80 centimeters from trach was the second part of intestine.
Yeah, thank you.
So,
yeah, this is very interesting, really, that you found like, yeah. But how we can see this is upper or this is in large intestine or small intestine?
If you do a series of X-rays and they stay in the same place, go for surgery.
X-ray, not CT.
X-rays, but yes, a series of X-rays. If they are on the same place, they do not move. It means that many parts of the intestine are attracted
Small
together.
intestine, yeah. Exactly.
If they move, it's a different thing.
Okay, thank you very much.
Any other questions?
We thank you all, and we will now make an raffles. And at the end of our conference, thank you for all who are waiting. So I congratulate all of you for success of the first hybrid physical and virtual meeting. And I want to thank you all because you are staying till now. A special thanks to who's coming from abroad. Really, it is we cannot, no word can appreciate that your effort and attending our lectures. And even that coming from UE, but from Abu Dhabi and from far areas. Thank you very much. From Fujairah also, but from Abu Dhabi there is special. Jumeirah, لا Jumeirah no. Jumeirah it is near to us. So I feel that we have a lot of very interesting lectures and very eminent speakers. I learn a lot today from all of you. And I can conclude that is the first lecture in our meeting. It was the bronchial asthma and how to deal the personalized bronchial asthma for Professor Dr. Ashraf Al-Baqi, and how to not everyone having bronchial asthma to be managed the same, because many factors can affecting the management for each one. Phenotype is it is the same, but maybe genetically or some factors affecting the management. Also, I learned a lot today from Dr. Mahmoud Al-Haliq and about how it is important to keep the baby in ICU in the silent situation, and also kangaroo position. And even he told that just touching the baby in ICU, the parent, if they are touching the baby, even 26 weeks, it will make a lot for him in neurodevelopment. So it is all this new knowledge for me. And also this note for Professor Alexandra and Professor George. We are learning a lot today from their lecture about endoscopy, functional GIT disorder. As I told you, the dessert of the conference, Dr. Muhammad Maghdadi, and we are congratulate him that he's promoting as a professor of pediatric in Abu Dhabi, and congratulations, and you deserve more and more. Maybe you will congratulate you next year as a dean of the. So congratulations, Dr. Maghdadi. And I want to thank the organizing company, CME company, Mr. Muhammad Al-Banna. Really, he is did a lot on the great job in communication with and arrangement and organization. Thank you very much, Mr. Muhammad Al-Banna. While not forget also Mr. Sami. He's an director of the hotel here, and he is taking all precaution and arrangement to make you convenient and safe on the same time. He maybe 1 week he's not sleep. Maybe that today he will sleep after finishing the conference. So thank you, Mr. Sami. Thank you very much. Thank you. And again and again, thank you for all for your support, and Dr. Abir, and really that Dr. Muhammad Ahmed Abdelal, he came from Abu Dhabi also today, and he's to attend our lecture. So thank you very much, Dr. Ahmed, and thanks all of you. We will just make an small raffles to end our conference, and we hope for all of you to win. It is an valuable prizes, and the lucky one he will win, and I hope for all of you to win, inshallah. So we will start.
I will draw the first lucky person to receive the first prize. First to receive is Muhammad Rashid. Dr. Muhammad Rashid.
So the big prize for he deserved, Dr. Muhammad, and really congratulations.
Thank you. It was a nice conference. Really, it was very nice. Yeah, usually we are not attending on Fridays at all, but really till the end, we are really appreciating all the speakers and your effort, and it was really amazing. And we are waiting for a new inshallah gathering together, and we need maybe more discussions and more workshops I know you are limited with all these circumstances, but really we need something more, inshallah, with the lovely, speakers and outstanding and amazing presentations. Thank you very much, really.
Because the conference really, it is not only for scientific, for social also, because we are since long time we don't see each other. And for Dr. Mesaf, really, I saw him many times in virtual, but Dr. Muqdadi, last time I saw him in the cinema. There is one conference and he was in the cinema. Dr. Ashraf Demiri, really, he is my friend since 30 years. So really, it is good for gathering, for see each other face to face. So we hope that will continue, and maybe next year also we'll be invited by Dr. Muqdadi for his elite. And every year he is very successful, but this year because of this situation he postponed to the next year. But you have to invite me, yeah? Okay, inshallah. Thank you.
Okay, the next is Dr. Khalid Rashid.
Because he's asking a lot. He's the most active one really in the asking the question, so he deserves.
Wonderful conference, such nice presentations, such knowledgeable presentation. Really learned so much from it. Well, it was wonderful. And your efforts really, mashallah.
Thank you, Dr. Khalid. You deserve really. From the first lecture till the end, the only person. Sometimes I go outside, but Dr. Khalid is staying here, so he deserves really the prize.
Come meet and eat.
Thank you. Yes. Thank you. Yes.
Thank you.
Thank you very much, Dr. Khalid.
Next is Dr. Muhammad Mikdadi.
This is because of promotion, Dr. Muqdadi. Thank you, Dr. Muqdadi.
Inshallah, ya Mus'ab. Inshallah, we'll see you on the 10th. Mus'ab. Yeah, آسف. Inshallah, we'll see you on the 10th Pedia Dubai, inshallah. Inshallah, يشرك. يلا بالتوفيق, inshallah.
Thank you.
Thank you. Thank you
very much. Thank you.
Next, Dr. Osama Elasi.
Thank you very much.
Thank you very much. We are all very impressed with your nice and very nice conference. And really, we are all congratulating you and all the committee.
Thank you. Thank you. Thank you. The last, not the least.
Next, Dr. Suad Amin.
Female. Come from this side.
أنا حتى لو ما فزتش أنا فزت بإني حضرت معاكم وحضرت مع أعظم الأساتذة وأعظم المحاضرات. شكرا لكم حتى لو ما فزتش.
Called Mr. Muhammad Al-Banna. So this is a hero. This is a hero, really, and he is the one. And we have to congratulate him. And we want to take group photo, please, if we can allow. Because we are wearing masks, so no problem. So we will just take for that is staying till the end. Yeah, social distance. Thank you very much. Yes.